invited guests and delegates, a very blissful morning to one and all present here. It gives us immense honor and heartfelt pleasure to welcome each of you to this intellectually stimulating continuing medical education program hosted by the Department of Radiodiagnosis, KoIMS Medicaid.
This academic congregation stands as a testimony to our collective pursuit of excellence, learning and ethical clinical practice in the realm of radiodiagnosis. I am Aishwarya Raj.
And I am Anu. Together, we are delighted to guide you through this day of scholarly discourse and professional enrichment.
We now delve into the heart of today's scientific agenda, commencing with the live demonstration and mid-trimester anomaly scan and fetal Doppler studies, an indispensable tool in modern antenatal radiology.
We are honored to welcome an illustrious panel of radiologists who will be spearheading this session. Dr. Raghavendra, Dr.Rachitha Ramamurthy, Dr.Muralidhar Kamalapur, Dr.Ravi Badagandi, Dr.Pratiksha Shetagar, and Dr. Abhilash. We welcome all the radiologists as well as faculty to this session.
The age set from her LMP, last menstrual period, is 22 weeks. So the first step before we start off an anomaly scan is to actually validate her dates. So I've gone through her reports and her earliest dating scans are correlating well with the last menstrual period. So we will stick to those dates. And then we start off the scan by doing a transverse sweep from the top of the fundus of the uterus. You go down, just a transverse sweep down to the lower segment and cervix. So this kind of a survey with a full sector angle, a wide sector angle, will give us an overall idea of what are the contents of the uterus. So now I know that the uterus has one gestation, one single live fetus, and we also know the lie of the fetus. The lie of the fetus is basically the presentation and the orientation of the spine. So I know that the head is actually at the fundus, that's the fundal end. I reach the head of the fetus first. And then as I go down, I see the neck, the body. The spine is on to the right side of the screen, right? This is the spine, which is on the right side of the screen, which is basically maternal left. And then you have the rump of the fetus, which is at the cervix. That's the cervix, and you see that the rump of the fetus is in the lower segment. So now you have a longitudinal lie. Head up, rump reach down. So that's a longitudinal lie, meaning long axis of fetus is along the long axis of the uterus. And in this longitudinal lie, we next see the situs, the side of the fetus and the situs of the fetus. So again, imagining ourselves in the same position as the fetus, head up, spine to this side, to the right of the screen. If you lie down like that, this side, so the side that is up becomes the left side of the fetus, and the side that is down, the far side, is the right side of the fetus. Just by imagining yourself in the same position, lying down on the right. It's a right lateral decubitus, right down, left up. So once you know the side of the fetus, then you can determine the situs. And the situs is to see where the apex of the heart is, where the stomach is. So we start with the upper abdomen. In the upper abdomen, you see the stomach bubble is on the near side, which we have already labeled as left. So that is normal abdominal situs. Liver is on the right, and you also have to notice the abdominal vessels, that's the spine. The vessel that is immediately anterior to the spine and a little to the left is the aorta, and a little more anterior and to the right is the IVC. So the position of the abdominal vessels are also normal. So this is normal abdominal situs. Liver on the right, gallbladder on the right, stomach on the left, and the abdominal vessels are also normal. Once we determine that the situs in the abdomen is normal, we go up to the chest, the thorax, four-chamber view of the heart. You know that the apex is also pointing up, which is the near side, that is the left side of the fetus. So apex of the heart to the left, stomach to the left, this is situs solitus. So we've determined the side of the fetus and the situs of the fetus is normal. Now the fetus is turning a little bit, so let me try and do the heart study before it turns back around. So we're going to do an anomaly scan in an opportunistic method, meaning when you need to examine the fetus head to toe, we're going to be opportunistic based on the position of the fetus, based on what part the fetus is showing us, that part you examine first. And you have a checklist on the side of your table so that you cover by the end all the points that you need to see in the fetus. So coming to the heart, you all again start off with the upper abdomen, determine the upper abdomen is normal, the landmarks that I told you. Then you just move the probe up, axial sweep up into the thorax, and you start getting the 4-chamber view. And for the 4-chamber view, I am going to reduce the sector angle to look at the heart clearly. I don't want to see all the sides, right? I don't want to see this side, that side, the heart is over here. So to get the best frame rate and resolution, I will reduce the sector angle just enough to cover from one rib to the other, and then I will take a box zoom. This click is the box zoom. Okay, and I set the size of the box just enough to cover the heart and the spine, and then zoom in. So now you have the 4-chamber view of the heart. So in the 4-chamber view, before we get into the landmarks of the heart, I need to study the heart as a whole. That means I am studying the heart in relation to the position in the thorax. The heart is occupying the middle 1/3. The left lung and the right lung are looking symmetric on either side. The shape of the heart is okay, it's oval in shape. The apex is to the left. And the axis of the heart, if you take a line through the interventricular septum and another line through the midline of the thorax, the axis of the heart is also normal at about 45 degrees plus or minus 20 degrees. Up to 65 degrees is normal cardiac axis. The pumping action, the squeeze of the 4 ventricles are looking okay. And then I go into the details of the 4-chamber view. So when you get into the 4-chamber view, you need to see that in fact it has 4 chambers. You are visualizing 4 chambers of the heart. The right chambers and the left chambers are equal to each other. You already know this is the left of the fetus. This is the right side of the fetus. That you have fixed by looking at the lie presentation of the fetus and lie. So once you fix right and left, these two will become the right-sided chambers. These two are the left-sided chambers, and they are equal to each other. And then you see the crux, the interventricular septum, the 2 AV valves, the right being the tricuspid valve, the left being the mitral valve. They are normally inserted into the crux, and there is an offset. There is a little bit of a step that happens between the insertions of the tricuspid, which is a little bit more basal, and the mitral, which is a little bit more, the tricuspid, which is a little bit more apical, and the mitral, which is a little bit more basal. So that little step that you see between the 2 valves is called the offset, AV offset, atrioventricular offset, and that should be seen in all fetuses. And then you see a little bit of the septum primum, which is the little tiny septum over here, part of the septum primum, interatrial septum. This is the inlet septum. This is the rest of the muscular septum. And always in an apical view, this is an apical view because the heart is up, okay, the apex is up. In an apical view, you always might get a little dropout artifact in the inlet part of the septum. Just rotate the probe, go a little bit more lateral to lose that sort of dropout, and you will see that the septum is in fact intact throughout. So you see that the septum is intact throughout, and you make out the crux is normal. And you see the 2 atrial chambers, the right atrium, left atrium. Left atrium is always closest to the spine, and the left atrium should receive 2 pulmonary veins that you are seeing here. The inferior pulmonary veins are joining the left atrium. And then the left ventricle, the right ventricle. The right ventricle has the moderator band. This moderator band is the morphological landmark telling you that truly the right-sided ventricle is morphologically a right ventricle, and the right ventricle will always carry the tricuspid valve, which will be more apically inserted compared to the mitral valve. So, and that is a good 4-chamber view. The 4-chamber view is normal. So you save a clip. Always for documentation of the heart, we save clips rather than stills. I can just pause and save a picture like this, which is showing you all the 4 chambers, but I would rather save a clip so that I know the contractility of the walls, I know that the 2 AV valves are opening and closing well. So you always have to save real-time clips of the heart. So once we are done with the 4-chamber view, you next go on to the LVOT, left ventricular outflow tract, for which it is a rotational view. It's no longer a pure axial view. From the axial view, I rotate my probe 45 degrees towards the right shoulder of the fetus. And once I rotate the probe like that, you start getting the LVOT. The fetus is turning a little bit. Let us see if I get a good LVOT. Okay, so this is the LVOT view. 1 ನಿಮಿಷ ಉಸಿರು ನಿಲ್ಲಿಸಿ. ಉಸಿರಾಡಬೇಡಿ. Little bit of rib shadowing because it's a little on its side still. It's not a pure apical view. ಉಸಿರಾಡಿ, ಆರಾಮಾಗಿ ಉಸಿರಾಡಿ. So I've saved a clip already as the fetus is very jumpy. I'll show you the landmarks on the clip. As I've saved, I'm going back and forth and you can see the left ventricular outflow. This is the left ventricle. That is the sternum with the ribs. Always the ventricle which is closest to the sternum, retrosternal ventricle, is always the right ventricle. And the other ventricle, outside of the interventricular septum, the other side of the interventricular septum, you have the left ventricle. Left ventricle is giving out an outflow, so that is LVOT, left ventricular outflow tract. So this outflow should be morphologically the aorta. So how do you identify it as the aorta? It is going straight up without any branches. The aorta is an arching vessel, not a branching vessel. So the first branch it gives is only after the arch, where it gives the neck vessels, right? So until that, it is not bifurcating, it has no branches. So that is the aorta. And then you go back and forth as you are scanning. You see that little dot appearing and disappearing. This little dot appearing and disappearing is the aortic valve, the semilunar valve, aortic valve. So that normally should appear, disappear. So when the valve closes in ventricular diastole, the cusps meet and you see the valve. And when there is ventricular systole, the valve opens and the valve is not seen, that dot is not seen. So you should notice that blinking on and off of the valve, telling you that the cusps are not thick, they are not atretic, and they are opening and closing well with the phase of cycle of the cardiac rhythm. So that is one first landmark that you see. The second is that you see the continuity of the anterior wall of aorta with the interventricular septum. Aortoseptal continuity is maintained. There is no gap here telling you that there is no VSDs. So that's a continuous septum, and you also notice that there is an angle between the interventricular septum and the aorta. There is an angle. It's not collinear. So that is a normal angle. And you also notice mitral continuity. The posterior wall of the aorta is continuous with the mitral valve. So that's the aortomitral continuity. So those are 2 landmarks that you notice. And then you notice that the 2 anterior and posterior walls are parallel to each other. That means the caliber of the entire vessel is uniform. There's no stenosis, there's no widening, there's no flaring of the vessel, there's no narrowing at the valve level. So that is a normal LVOT. Okay? So I'll defreeze, we'll see if I can get the RVOT in this position. So from the LVOT, I go back to the 4-chamber view And then I rotate the probe 45 degrees towards the left shoulder of the fetus to get the short axis view of the RVOT. Again, position is not very great over here. I think I'll wait for the fetus to turn to give me a better apical position to get the rest of the heart. So I've shown you half the heart. We'll come back to the heart as the baby turns. That is what we do. Normally, this is what is called an opportunistic approach. So you move with the fetus. As the fetus moves, whatever it is showing you, you document. So we'll come back to the heart a little later. What I can see is that the baby is actually, fetus is nicely posing for the face. So let's finish the face. So I'm leaving the thorax, coming up to the head, and I go to the orbits first. And the way I examine the orbits is an axial section. You take through the orbits, 2 orbits, and you freeze at the level of the lenses. You need to see that there are lenticular echoes in each of the orbits. The 2 orbits are symmetric in size, and the distance between the 2 orbits is equal to the size of 1 orbit. Okay, that means you can fit 1/3 globe over here in between. So this is the normal appearance of the orbits, and you also are seeing the lens echoes very well inside over there. Let me zoom in some more for you. Is it visible well for you all? Projecting well? Okay. So you can see the lens echoes also very well there. I have frozen, and this tiny little line that you can see is the actual posterior capsule of the lens. That's of the left orbit, this is of the right orbit, and what you're seeing here, this line is actually part of the vitelline artery, which is alright, which is normal. In the mid-trimester scan, we expect the vitelline artery to still be there, so that is normal. You just need to notice that the lens is a thin, sharp line. The posterior capsule is a thin, sharp, paper-thin line, and it's not looking thick or opaque, and it's not looking like a nodule, a white nodule there. So that's normal lens. The presence of the lens and the appearance of the capsule of the lens is what you need to document. The 2 orbits being symmetric in size, and there's no other lesions around the orbits. So we're done with the orbits, and then we move down to the lips. Okay, this is actually a very mobile fetus, so it's going on moving, but let's see, we will see if it poses for the rest of the face. So from the orbits, I just come down to a modified coronal view. Orbits you do in an axial view, and when you come to the lip and tip of the nose and nostrils, you take a modified coronal view. And in this view, you see the tip of the nose, 2 nostrils, the upper lip. This edge of the mucocutaneous junction of the upper lip is called the vermilion border, and that is where it is highly echogenic, where the skin meets the mucous membrane of the lip. And that is what you need to document, saying that the edge of the lip, right up to the edge of the lip, there is no cleft. So you can even save a clip if you want, or you can save a still, that's up to you. And then you have made sure that there is no cleft lip. Then you also need to look at the palate inside. You can do it by just going 1 step in, more axially. You go in, and then you see the arch of the maxilla. That is the alveolar ridge. That is where all the dental roots are, right? The teeth buds are there. So that is the alveolar ridge, and you make sure that is also intact. There is no cleft palate. There is no cleft lip, there is no cleft palate. So that is what you need to document. If you want to go 1 step further, you can also look at the rest of the soft palate and try and get, so the rest of the hard palate, and try and get the posterior palatal line. To see that the rest of the hard palate is intact, you need to document this line, which is called the posterior palatal line, telling you that there is no cleft isolated in the back of the hard palate. Okay, that shows an intact primary and secondary palate, bony palate. So that is how you document the palate. Routinely, the lip and the alveolar arch is enough. As of now, in the guidelines, the posterior palatal line is not mandatory, but if you want to make it a good practice, you can always include it in your your own checklist. And then you can even go into the throat and see that two little equal sign. If you come a little more laterally and get into the nasopharynx, oropharynx, can you see this little equal sign? Is that visible?
Yes.
What is that? What structure is this little equal sign?
Soft palate.
Yeah, what part of the soft palate? Uvula, perfect. That is the uvula. And if you document the uvula, it means that even the soft palate is intact. Okay, there's no cleft in the soft palate. So that's how you document the palate and the uvula, and we're done with the axial sections of the face. We move into the sagittal sections. So from axial, I turn my probe 90 degrees to get into the sagittal section, and you go right to the mid-sagittal section, freeze in the mid-sagittal section. And what are you going to study in the mid-sagittal section? What landmarks do I want to look at? You want to see mainly the nasal bone. That's the frontal bone. This is the nasal bone. The angle between the frontal and nasal bone are normal. Then you can measure the nasal bone, look at the ossification, it's nicely well ossified, it is brighter than the skin above, so it's a well ossified nasal bone. You can zoom in, take your calipers and measure the nasal bone, and you need to see that the nasal bone length is more than 2.5 centile for gestational age. For 22 weeks, I know by heart that 5.6 is the 2.5 centile cutoff. I'm getting a measurement of 5.9 millimeters. So that is normal for 22 weeks. You document that as well. Then what are the other landmarks you see in the same mid-sagittal section? You see that the tip of the nose is good. You see the upper lip, lower lip, chin. Okay? Straight line. The chin doesn't look tucked back. It doesn't look receding. It doesn't look like a micrognathia or a retrognathia. So you're ruling out micrognathia and retrognathia here. Then you see the neck and the rest of the thorax. So when you document any section, notice that I am nicely magnifying so that I'm not saving the face like this. I can save the face like this also, but I don't want to see the rest of the body and have one very parasagittal view. And nicely optimize the image, go to the mid-sagittal view and document the face. Now it's turned back, the fetus has turned even more posterior. So what shall we take the opportunity to study now? Spine. Perfect. Since the fetus is turning prone, we look at the spine. So you go back up to the head. Notice that the spine is up now. Firstly, I'll do the sagittal section of the spine. You can increase your sector angle as much as you want. I use a split screen and I document the upper half of the spine in one side of the screen, the cervical and the thoracic spine, and then I go to the next half of the spine and look at the rest, the lumbar and sacral spine. The rump of the fetus here is actually inside the maternal pelvis. So you're not getting to see the sacrum and the lumbar spine very clearly right now. The fetus has to lift its rump up to get the rest of the spine well. So I'm not going to complete the spine like this. I can either wait for the fetus to move and get its rump up, or I can try and manipulate and see if I can push the fetus up a little bit with my left hand to see if I can get the spine. So I'll lose bidding. Lose and bidding content. I'm trying to push the rump up to see if I can get the rest of the tip of the sacrum. Go right up to the tip of the sacrum, and only if you document the tip of the sacrum and the skin covering the tip of the sacrum, you are completing your spine study. So then, I've got an okay section, not a very great section because it is still buried in the rump is in the maternal pelvis, but I'll just document that for now. We can always wait and study the sacral tip and up tilt better. So in the sagittal plane, you're going to notice two lines of the spine. there are 3 ossific centers of the spine, right? Each vertebra has 1 anterior and 2 posterior ossific centers. So in the sagittal plane, you are noticing, let me just remove the dual screen. Yeah, so you're noticing 1 line of anterior ossific centers and 1 of the posterior ossific centers. If I in fact go truly mid-sagittal, you will lose out on the posterior ossific centers and you will get only the anterior ossific centers. Here actually the spines are well seen, so you are getting both lines continuously. But anyway, you will need to notice 1 anterior ossific center line, 1 posterior ossific center line. They should be parallel to each other. There's no missing segments anywhere. And the skin over the spine is continuous. And to see the skin well, I need to lift the probe off the maternal abdomen. Don't press down. If I press down, I get the spine sticking to the uterine wall. I can't see the skin. I need a layer of liquor, contrast, to overlie the spine so that I see this nice echogenic white line of the skin going all across. There's no gap in the skin, telling me that there's no lesion, there's no open neural tube defect. So once you're done with the sagittal section, you also see the curvature of the spine is normal cervical lordosis, thoracic kyphosis, lumbar and sacral lordosis. So that's normal curvature. From the sagittal section, I go to the coronal section. In the coronal section, again, I'm zooming in so I can show you. You see 1 line of anterior ossific centers when I go a little bit more anteriorly, ventrally. And if I come dorsally, I see 2 parallel posterior ossific centers. So this railroad appearance you have to notice throughout. And the anterior ossific centers, you should notice that it is in 1 single straight line. I cannot get the entire spine coronal in 1 plane, right, because of the curvature of the spine. So I'll study the cervicothoracic and then I'll move down to the lumbar, sacral and make sure all the ossific centers are complete. It's in 1 single straight line and there's no scoliosis, there is no side to side bending of the spine. So that you can make out only in the coronal section. So this straight line is what you need to notice. There's no S-shaped bend, there's no C-shaped bend telling you that there's no hemi-vertebrae. So once you're done with the coronal section, you move into the axial section. All the major organs you have to try and see in as many views as possible. So in the axial section, you keep the spine at 12 o'clock position and you take a sweep right from the cervical spine down into the sacral spine, which is now not accessible due to position, but go up and down, a nice sweep showing you that there is no defect even on the axial section. And what are the landmarks that you need to study on the axial section? You will in fact see the 3 ossific centers. The anterior ossific center, 2 posterior ossific centers. And these 3 are equidistant from each other. They form an equilateral triangle. And inside you see the spinal canal, you can even see the cord inside. Can you see that? That's the cord inside the spinal canal. You can zoom, study it better if you want, and just go an entire sweep. You also notice the skin continuity of over the spine is maintained. So you notice the skin continuity both on sagittal and on axial, and that is how you document the spine. I won't go into showing you the level of the conus medullaris because again the rump of the fetus is down. I can't get a good section to see the conus medullaris level. But anyway, that is not required to document routinely in your regular TIFA scan, so I'll skip that for now. So once you're done with the spine, then we can go on to the abdominal organs, and first I look at the 2 kidneys. Because the spine is anterior, spine is at 12 o'clock position, this is a good way to look at the kidneys. Follow the spine down into the lumbar area, and in the lumbar area you see the 2 renal fossae, and in the renal fossae you see 2 kidneys on either side of the spine. So you document the presence of the 2 kidneys. That's 1 kidney, that is the left kidney, this is the right kidney. Okay, 2 kidneys are present. These are the pelvises of the kidneys. This and this is the renal pelvis. There's no dilatation of the renal pelvis. If you want to, you can measure it. You don't need to measure routinely. If subjectively you feel there's no pelvic dilatation, you need not measure it. But if you want to, this is the only section where you can measure the 12 o'clock position of spine, or if spine is at 6 o'clock position, the kidney in a cross section view, the antero-posterior dimension of the renal pelvis is what you measure. Up to 4 millimeters in the mid-trimester is normal. So 2.8 millimeter over here, I'm not even going to mention it. This is normal, it's not pelviectasia. So you no need to even say so in your report, but if you want, you can just document the measurement. You can even measure the other side. That's, yeah. Antero-posterior of the left kidney, antero-posterior of the right kidney. Both of them 2.8, 2.8, absolutely normal. So that's how you document the kidneys in an axial section. You can then turn coronal and make sure you see the kidneys in the coronal section as well. You see both kidneys over here on the coronal section. You see the entire kidney length. You see the upper pole, lower pole, upper pole, lower pole. So that's how you document the kidneys on coronal. You can save that as well. And I'm going to put on the color over here. In fact, I'm going to put on the power Doppler, and immediately I start getting the renal arteries. Yeah. I'll optimize my color. I don't need such a big box. Okay. That's the descending aorta. And I'll freeze there. Can you see the two renal arteries? 1, 2. The near artery is showing flow towards the probe in red. The far artery is showing flow away from the probe in blue. So if you document the renal arteries with color or with power Doppler, this is unequivocal proof that the two kidneys are present. That means you're not mistaking some bubble loops for kidneys. Okay? That's a good practice to use color to document the kidneys. So go back to grayscale imaging, and the rump of the fetus has come up a little, so we'll finish with the sacrum end of the spine. See, the fetus is rotated now and the rump is up. So I'm documenting the sacral taper, sacral up tilt. You freeze that and save that as well. And let me see if I can get a more sagittal view for the conus medullaris. No, it's again going down. We'll skip that for now. Okay. So once you finish the kidneys in the abdomen, go in the same coronal section, go a little bit more ventrally, and you see the 4 major cystic structures in the abdomen. 2 major, 2 minor cystic structures. Can somebody name the 2 major cystic structures that you have to document in every abdomen? Stomach bubble, I heard, and urinary bladder. So that's the stomach. Near side is still the left side. Stomach on the left. That is the urinary bladder, a little half empty. The bladder is emptied in the pelvis. So those 2 major structures you have to document. And then the minor structures, gallbladder, minor cystic structure, and the umbilical vein. That's the umbilical vein. So those are the landmarks that you notice. Liver on the right. Bowel loops, you just notice that the bowel loops, there's no dilatation of any bowel, there's no free fluid in the abdomen, and the bowel echogenicity is less than bone. If the bowel echogenicity crosses that of bone, you will call it echogenic bowel, which becomes a marker of aneuploidy and UGR and infection, etc. So right now, bowel echogenicity is normal. That's just what you need to notice. Always do a little sweep to cover the entire abdomen, back and front, and axial top to down. Any organ that you are studying, make sure that you do a sweep to cover the entire organ, the entire region, that you don't miss any cystic structure anywhere, you don't miss any pathology anywhere. So we've finished with the abdomen, we've finished with the spine. The heart is still not in position to show you the rest of the views. Let me see if I can do the 3 vessel view at least. And narrow the sector again. From 4 chamber view, you go up into the neck and you start getting the 3 vessel view. This is the 3 vessel view, and in the 3 vessel view, 3 vessel trachea view, you notice that the ductus arch is the leftmost vessel, aortic arch is the middle, right SVC is the rightmost vessel. This is the trachea. The ductus arch and the aortic arch are converging into a V. to the left of the trachea. This is the left side of the fetus. This is the trachea, both the vessels are converging to the left of the trachea. That means it is a normal left-sided aortic arch. Okay? Normal left-sided aortic arch you need to document, and that is ruling out a right aortic arch. So that's how you document the 3-vessel view. It's again good practice to see all your views, 4-chamber view and your LVOT, RVOT. Let me increase the scale. Yes. Can we go for, okay, it's invert. Can you remove the invert? Yes, perfect. So that is how I document the 4-chamber view with color. I'll just freeze for you and see the 2 ventricles filling well with color. Is there a interventricular septal defect? Is there a VSD? Is that a VSD? No. Why are you not going to call that a VSD? Because did you see that defect on grayscale? On grayscale, the septum was absolutely intact, no? There was no such a large gap. So that is just your color settings. If your wall motion filter is low, if your PRF is low, so you go up on your scale and optimize your color setting well so that you don't have over bleeding onto the 2 sides of the septum. Get 2 nice fills like this, showing you the interventricular septum discrete over there, 2 inflows of the ventricular inflows on either side, parallel inflows. Okay, that is how you document color of the 4-chamber view. You turn to your LVOT, you notice that there is antegrade flow in the aorta, and when I say antegrade flow, I mean the aorta is taking off like this, and so I expect flow away from the probe, so it is blue. Okay, that's correct direction. And both in the 4-chamber view and in the LVOT, what you need to notice is red, black, red, black. There's no regurgitation of the AV valves. Same over here. Blue, black in the LVOT. There's no red happening. That means there's no regurgitation of the aortic valve. So you're ruling out regurgitation, you're seeing the direction of flow. And then you move to the 3-vessel view and you show that the flow over here is actually in red because my view is on the lateral side. It's not an apical view, it's a lateral view, so the direction of flow is actually towards the probe and both the vessels are showing you a red colored flow. So as long as you know the orientation of the vessels, you will know what way the flow has to be. The pulmonary artery to ductus is going like this, aortic arch is going like this. So the flow has to be forward direction like this, towards the probe. So you expect red only in both the vessels, right? I can even show you a view like this, where this vessel is going this way, that vessel is going that way. So I will actually get one in red, one in blue. But that's not reversed flowing one, it's just the orientation of the vessels. That's a very common pitfall. Make sure you are seeing the orientation of the vessels before you interpret the direction of flow in the vessels. So you come up like this or wait for an apical view and see that the both pulmonary and aorta is showing you antegrade flow. I am not able to show you a 3-vessel view because of the position. I mean RVOT view because of position. Let me see if I can manage. Okay, I've got some amount of the RVOT view. Let me see. That's the sternum. Nearest the sternum is the right ventricle. This is the pulmonary artery taking off from the right ventricle. That's the pulmonary valve. Again, blinking on, off, appears, disappears. That again shows you that the pulmonary valve is normal. MPA is looking normal. There's no flaring and narrowing. And I can't show you the bifurcation in this view because again, there's a lot of rib shadowing and the position is very lateral. I'll show you that a little later if it turns. Okay, so we are mostly done with the heart, we are mostly done with the spine, we are done with the abdomen, and we are done with the thorax and other abdominal structures. So next I'll move on, we are done with the face also. We next move on to the head and the limbs. Those are the parts left. So the head you see in an axial view. The 3 basic axial views you freeze from the, let me optimize the gain, narrow the focus. Use a little bit more gel. Okay. So That is the first view that I'm going to take, an axial transthalamic view. You freeze over there, and the landmarks that you see is the CSP. This box, rectangular box, is the CSP, which interrupts the midline. Midline interhemispheric fissure and Fox, it interrupts as a box there. You have the two anterior horns, frontal horns on either side of the CSP. You have the thalamus over here in the middle. Okay, those are the right and left halves of the thalamus, and you see the two hemispheres on either side. You can see part of the sylvian fissure, and this view is our basic view to measure the head, BPD and HC. I'm keeping the midline horizontal, and I take my measure tool and go take the BPD preset. Automatically the machine is recognizing the BPD. I do a fine tuning and I measure the BPD from the outer surface of the near calvarium to the inner surface of the far calvarium. You can even do outer to outer like the latest ISWA guidelines say, but I stick to outer to inner because the inner edge is well seen of the far calvarium and the outer edge of the near calvarium is sharply seen always. So your caliper placement is good. So that's how you measure the BPD at the most widest portion of the head, the parietal eminences of the head, absolutely perpendicular to the midline. And then I take the next measurement, the head circumference. Automatically when I choose head C, you get an ellipse which automatically tries to fit around the cranium. You can again do a little bit of fine tuning. I'll update, get the points where I want them to, so that I am not including the scalp. The measurement is only of the cranium, bony cranium. You are not including the skin and the scalp. So that's how you take the head C measurement. Automatically you are getting the measurements here. I've entered the gestational age from LMP. BPD is almost 5 centimeter. Percentile over here that is displayed next to the measurement is important. 15.8 meaning 16 percentile is normal. Anything for BPD, HC, AC and FL between 5 to 95 percentile are normal. So biparietal diameter 16% normal. Head circumference 19.1 means nothing to me. I don't know if 19.1 is normal for 22 weeks. But if I see here again 15.8 which is again 16th centile for gestational age is normal. It is above 5, below 95 which is normal. So I select and save those images. The next I go from the transthalamic view, I go into the transventricular view. A little tilt of the probe takes us to the transventricular view over here. How are we on time? Can I take another 5-10 minutes to finish off anomaly scan? Okay. Alright. So you go to the transventricular view by tilting your probe and you again maintain the landmark of the CSP. CSP is still seen. You see the symmetry of the anterior horns on either side. This is the lateral ventricle of the far hemisphere. Near hemisphere is always hidden in reverberation. But the far hemisphere is well seen. You see the sylvian fissure. You see the near wall of the ventricle, you see the far wall of the ventricle. Median wall, lateral wall. What is this echogenic part inside the ventricle? Choroid plexus. The choroid plexus is filling up to the atrium. This is the atrium where the occipital horn, temporal horn and the body meet. So choroid plexus usually goes up to the atrium. You see the shallow notch on the medial surface of the cerebrum? That's where the parieto-occipital sulcus is starting, and that is your landmark to measure the transventricular dimension. And I measure it, let me zoom in further for you to see. I measure it from the inner wall, the inner surface of the medial wall to the inner surface of the lateral wall, absolutely perpendicular to the long axis of the ventricle. This is the long axis of the ventricle, right? So I am measuring perpendicular to the long axis of the ventricle, inner to inner. That is the correct way to measure at the level of the parieto-occipital sulcus. I am getting a measurement of 4.5 millimeters, that is normal. Anything up to 10 millimeters is normal. So you save that, I de-zoom, and then after seeing the far lateral ventricle, you must always make sure that you are studying the near lateral ventricle. And to do the near lateral ventricle, I do a little maneuver where instead of keeping the midline, interhemispheric fissure horizontal, I move the probe towards the occipital end of the fetus head, and I try to insonate through the lambdoid suture. This is the parietal bone, that's the occipital bone, and if I insonate, beam passing through the lambdoid suture, where I make the midline a little oblique. The midline is no longer horizontal, I am making it about 15 degrees, 20 degrees oblique. I start seeing the near ventricle because the beam is passing through the lambdoid suture. So you can document the near ventricle as well. You don't need to measure right and left ventricles routinely in every case, but you can make it a practice to at least save a still of the near ventricle just by subjectively assessing. And you know the near ventricle is also not dilated. If you want, you can measure it as well, again inner to inner along the perpendicular to the long axis, 5.7 millimeters, that is normal. Okay, make sure that you're trying to keep the section as axial as possible, where you see both the ventricles symmetric with each other. That means the, I'm sorry, where did I go? Yeah, okay. So you see the midline, the near hemisphere and the far hemispheres are equal to each other. That means you're truly in an axial plane. You're seeing the near ventricle, far ventricles, they're looking symmetric. You can measure both and document that there is no ventricular dilatation on either side. Don't forget to do that exercise of seeing the near ventricle, because if you miss it, you may miss out on a unilateral lateral ventriculomegaly. At any stage of pregnancy, if the size of the ventricle crosses 10 millimeters, you need to do a lot of other tests, so don't miss out on that. So you always notice that the choroid plexus doesn't have any choroid plexus cyst over there. The walls of the ventricle are sharp and nice and thin and smooth. There's no irregularity. And you must also notice the sulcations. That is the parieto-occipital sulcus. I'm getting a little lower than usual. That's alright. That's the parieto-occipital sulcus as a dip in the medial surface of the parietal lobe over there. That's normal for 22 weeks. And the sylvian fissure or the lateral aspect of the surface of the brain is also normal. You see a smooth obtuse angles at 22 weeks, that is normal. So you document all that and you go to the last plane of the brain, axial plane, where it is a little bit more rotation of the probe towards the cornal view, and you start getting from axial, you go cornal, and you get the cerebellum going to the posterior cranial fossa. And here you have the nice dumbbell shaped cerebellum. You see the echogenic vermis in the middle, that is the handle of the cerebellum. You see one hemisphere, other hemisphere, symmetric on either side, and you see cisterna magna behind the cerebellum, which is looking normal as well. And the measurements that you take here, you can take the AP dimension of the cisterna magna in the midline, again inner to inner edge of the cisterna magna up to the occipital bone. 5.9 millimeter is normal, up to 10 is again normal, and you can measure the transcerebellar dimension. You take TCD on your preset of the measurement, and you take from the convexity of one hemisphere to the convexity of the other hemisphere, outer edge to outer edge, click save, 2.2 centimeter, that is, I'm not able to see the 43 of the, let me do that time, measure it again. You again have to notice the percentile. Okay. What is the percentile? 27%. Okay, that is again normal. 5 to 95 percentile of TCD, transcerebellar dimension, is also normal. So you finish documenting the three basic axial planes. I show you a little tip over here which is not mandatory, but it's a good point to always notice. When you're doing the cerebellum, again do a sweep. Cover the entire cerebellum, cover the entire brain top to bottom, so that you're not sticking only to the three planes. You're noticing there's no cystics, there's no calcific foci anywhere in the brain. Even the transcerebellar plane, you go up and down so that you don't miss out on any cystic lesion over there in the cerebellum. And when you go down, a little bit more further down, you also get this structure anterior to the vermis, and what is this? Fourth ventricle. The fourth ventricle orientation is directly opposite the CSP orientation. CSP is a rectangle with the long axis in line with the midline. It is lesser in width, longer in the AP dimension. Okay, that is normal CSP characteristics. But in the fourth ventricle, it is wider than it is longer. So the AP dimension is always lesser, the side-to-side measurement is always more, and that is also important to note that the fourth ventricle is wider. You just have to notice that so that you are not missing out on any fourth ventricular pathologies, Wormian pathologies. That's how you see the fourth ventricle. So you're done with the cranium. If you want to see the midline of the cranium, so from the axial view, I go up to the vertex and try to do a mid-sagittal view to get the CC and the vermis. Again, the head is not very much in position. Let me try to move the head and try to get a mid-sagittal section to see the... No, it's not cooperating. The fetus is not in position for me to show you the C. That is the corpus callosum and the vermis. Let me try. There we go. Are you able to see that? That's the mid-sagittal view of the... sorry. This is the rostrum, genu, body, splenium. The entire length of the corpus callosum is present. Vermis I'm not getting very well. Ikkade banni, ಸ್ವಲ್ಪ ಕೆಳಗೆ ಬನ್ನಿ. ಅಷ್ಟೇ. ಕಾಲು ಉದ್ದಕ್ಕೆ ಬಿಡಿ. ಲೂಸ್ ಆಗಿ ಬಿಡಿ ಹೊಟ್ಟೆ. There we go. Is that a good mid-sagittal section? All of you agree? What are the landmarks in the mid-sagittal section? How do I know it is in fact mid-sagittal? By this fibrous sheath over here. What structure is that? Falx cerebri. That's the interhemispheric fissure with the falx cerebri telling me that I am truly in the mid-sagittal section. And the falx cerebri is interrupted by the corpus callosum, rostrum, genu, body, splenium. Entire length is present, and in the posterior cranial fossa, this kidney bean shape is what? Vermis. It's echogenic, it's bright. You see the fastigium over here, upper pole, lower pole, nice kidney bean shape, cisterna magna, fourth ventricle. That's normal vermis of the fetus. So if you want, again, good practice, if you want to document the mid-sagittal section, you can. Otherwise, you need not. It's not part of mandatory sections as such. Okay, so we're done with the cranial study. You can also complete, if you want, by doing a corneal sweep through the entire brain. I always do that, even though it's not mandatory. I just do a nice sweep from the frontal end to the occipital end, so that I'm seeing that the two hemispheres are equal, the midline is maintained truly as a midline, and I'm seeing all the extended views as well. Just to complete, I just always document that as well. Okay, so we're done with the head, we're done with the face, we're done with the, okay, it's turned now. Let me finish the heart. Reduce the sector angle again. Go in to the heart. I'm sorry, update. Okay, 4-chamber view of the heart, very nicely seen. See, when the fetus turns, you get really nice views. Document 4-chamber view, LVOT view, short axis RVOT view. Beautifully you start getting the MPA and the bifurcation of the MPA. I'm freezing there to show you the landmarks. What bone is this? Sternum. Under the sternum, what chamber? Right ventricle. Right ventricular outflow. What is this white dot? Pulmonary valve. Main pulmonary artery, bifurcating. What branches? What is the branch that goes directly towards the spine? Ductus arteriosus. Goes directly towards the spine. The right pulmonary artery wraps around the short axis of the aorta. Let me remove the cursor, play the clip back and forth. Can you see the short axis of the aorta? This is the short axis of the aorta, and the entire right side of the heart wraps around the aorta. Right atrium, right ventricle, let me go back, yes. Right atrium, tricuspid valve, right ventricle, pulmonary valve, MPA, right pulmonary artery. All the right side structures go wrap around the aorta, and that's why it's called a circle sausage view. And I find this short axis RVOT view very much more useful than the long axis view. It's easier to get from the 4-chamber view. It's just a 45 degrees rotation towards the left rather than into LVOT, which is a clockwise rotation. Anti-clockwise rotation gets you into the short axis RVOT. So I've finished the study of the heart as well, and of course you can document even the RVOT view with color. Let me increase the scale and see that there is antegrade flow in the RVOT as well. So we're done with the heart, we're done with the abdomen, spine. What is left? Anything left in the fetus to document? Limbs. The two upper limbs. You see the arm. I always split screen when I'm doing the upper limbs. You see, sorry, yeah, right arm and left arm. I document the two arms on either side. Subjectively, I know the humeruses on both sides are equal. And then I document left forearm, two bones of left forearm, and two bones of right forearm. Can you see that? Radius and ulna, document that. And then hand. And the way I document the hand is to just do a axial section through all the digits. I at least want to see 4 of the digits. The thumb is usually tucked in. So document hand, right hand, and left hand. The other hand is down here. Just make sure all the digits are present. You don't need to count the number of digits in each limb. That's not mandatory. But you need to make sure the digits are present. You're noticing digits are present, and you're not seeing any bony syndactyly, and you're not seeing any polydactyly. That's enough. So you can either go and save a clip like this, or you can just save a still like this and document the two hands. Okay, done with the upper limbs. Go to the lower limbs. Again, still in the split screen. Left femur, right femur. Okay. And when I'm measuring, you always need to measure the near femur, but I'll get it a little bit more horizontally to take the measurement of the femur length. So try and keep the femur as horizontal to the beam as possible so that you see the entire length, and you take the diaphyseal length of the femur, not including metaphysis. So 3.5 centimeter, 15th percentile. Good, normal. This baby is very symmetrically growing, no? BPD, HC, FL, all 15th percentile so far. So you measured the femur, then you document the leg. The near side is still left, so I'll document it on this side of the screen and go and document the right leg on the other side of the screen. Two bones. When I'm seeing the two bones of the leg, I only see the cross section of the foot, telling me that there is no club foot. Okay, and then you see the foot. I document the soles of each of the foot. That's the right foot, and this left foot I won't get the sole, I'll get the sagittal view. That's also alright. Document it there. The 2 feet are present and there's no ectrodactyly here, there's no problem with club foot. You can also document the leg like this, where you're showing that the angle between the leg and the foot is maintained. This is a sagittal view where only one bone is seen and the cross section of long axis of foot is seen, showing you that there is no club foot. You're not seeing the entire face of the entire sole of the foot with the bones over here. So that's how you rule out club foot. So you're done with the 4 limbs. Anything else left to document in the fetus?
Placenta.
In the fetus? Before we go on to placenta? Umbilical cord. Brilliant. So you always have to see the insertion of the umbilical cord, both the fetal end and the placental end. This is the fetal end in an axial view. I'm going up and down, and you're seeing the root of the cord going into the fetus, and you have to notice that it is only the vessels that are crossing the skin, nothing else. There's no bubble going out. That's the bladder. So zoom in some more. Go up and down. You're not seeing any bubble going across. Put on the color and notice that there are two umbilical arteries flanking the bladder. The two umbilical arteries are present. You are ruling out single umbilical artery. That's how you document the cord insertion. And then you also notice the placental site of cord insertion. And look at the placenta first and dezoom and find the placenta. Placenta is fundus and posterior wall. Okay, that's where the placenta is. Through an entire scan through the full placenta, I'm seeing that there is no cystic lesions in the placenta, there's no masses, it's uniform in thickness, the echo pattern is normal, thicknesses of the placenta is normal, etc. And then you try to find the cord insertion of the placental end of cord insertion. I'm actually finding the cord insertion here. Okay, that is where the placental, the other end of the cord over here is inserting. Is it inserting into the placenta? Is the placenta there? Put on the color and make sure that you are documenting the true cord insertion itself. Is that where the vessels are splitting and going across the surface of the uterus? Yes or no? That is the cord insertion, right? But is the placenta there? No. Where is the placenta? Turn your probe axial. You will find that the edge of the placenta is here and the cord insertion is actually next to the cord. Increase the gain so that you see the cord insertion well. That's where the cord is ending. This is where the placental edge is ending. The cord is actually inserting vellumentously outside the placenta and the vessels are then going into the placenta. So this is a nice incidental finding in this case of a vellumentous cord insertion. It's good to document that as well, and as long as the vellumentous insertion, the vessels are not in the lower pole across the cervix, we are not really worried. It may cause a little bit of growth IUGR in later gestation, but otherwise we are just wanting to rule out any vasa previa or placenta previa. You also notice the lower edge of the placenta is far away from the cervix. I'm doing a sagittal section of the uterus where I'm seeing the edge of the placenta high above and the cervix down here. Internal os is here. You can measure the internal os, the cervical length as well. That's the length of the cervix. Let me get a good cervical canal. Okay. That's the cervix. You can measure the cervical length. Anything else left? I think I've only left the abdominal measurement, abdominal circumference, and that's how you do an abdominal circumference. Spine is now bottom, so I can't put the spine at 3 o'clock or 9 o'clock position and try to get as laterally as possible and freeze where I get the stomach, umbilical vein and portal vein curvature, convexity towards the stomach. I use my measure tool, click on abdominal circumference, and this is giving me a trace method, ellipse tool itself it is giving me, and I will try to adjust so that I fit the abdominal circumference. Can you give me a trace tool? I'm much more comfortable with a trace. Excellent. I prefer a manual trace of the abdomen because the abdomen is never a perfect circle. I'm just drawing a rough outline here. You please do a neater job. And you are measuring the abdominal circumference on the outer edge of the skin, and the measurement is 17.2 centimeter, 50 percentile normal. So you're done with the biometry, you're done with all the entire top to head to toe structural assessment of the fetus, and you can go to your report. When you click on report for your worksheet, you will get a chart like this which is showing you that the gestational age by ultrasound is around 21 weeks 4 days, Your gestational age by LMP was 22 weeks. That is good correlation. Weight is 443 grams. Do I get a centile of the weight? Yeah, centile of the weight is over here, Hadlock. That's good. 28 percentile of weight. Anything between 10 to 90 percentile of weight is also normal. All the percentiles over here are normal. Ignore this. This has come in TCD measurement. That's wrong. Okay, our TCD was actually normal. I need to remove this measurement. Can I erase this measurement? Back. Okay, perfect. So now your TCD is also correct. So you make sure all your measurements are normal. Document the worksheet. Can I get a graph? The trend. You need to document the chart as well. For the EFW, you see this graph showing you that the EFW is within 10 to 90th percentile. That's today's weight. And then you go on to see each of the parameters, BPD, HC, TCD, FL and AC. Okay? Document each of these charts and make sure you include these charts in your report as well. So that completes the anomaly scan. You see Liker is normal subjectively itself. In the mid-trimester you can assess that the Liker, there's a good amount of fluid all around the fetus. You don't need to take an AFI or any measurement in the mid-trimester. If you want, you can measure the single deepest vertical pocket, and anything between about 4 to 6 centimeters is normal, and this is good Liker. Anything else you want me to show you in the anomaly scan? Or shall we wind up? Any doubts, please?
Airway and esophagus, airway.
Trachea.
Yeah.
Trachea, again, you don't need to document routinely, but if you want to, you can. That is the trachea that I'm showing you in the sagittal view, but usually we see the trachea in the axial view, and that is in the 3-vessel trachea view. Narrow the sector angle. Yeah. This echogenic ring that you see, that is the trachea. This is the trachea, and you see that the ductus arch and aortic arch are going to the left of the trachea. You can see the trachea there. To see the esophagus, I'll switch to a higher frequency probe. Okay. This is a lovely machine. Mindray is giving us Resona i9 for the demonstration purposes, and I'm switching to the SDB, yeah, high frequency probe over here. We'll see if we can get the esophagus. Depth I'm reducing. Going to a corneal section of the thorax, reducing the sector angle as well. Zooming in nicely and trying to see little corneal to sagittal. You'll see muscular signature, 4 lines. Can you see this here?
Yes.
That is normal gut signature. Okay? Gut signature anywhere, small intestine, large intestine, esophagus, will have 4 echogenic lines. 2 outer lines are the serosa, 2 inner lines are the mucosa, muscularis and mucosa interface. Okay, so those 4 lines is the normal gut interface, and that tells me that the esophagus is present in that segment. You can try and see the entire length of the esophagus. Well seen?
Yes.
Beautifully seen, no?
Yeah.
Amazing. So that is a high frequency probe usage for looking at the esophagus. This you will not get in your routine curvilinear probe. So if there is any indication for you to try and trace the entire esophagus, you can, but routinely it is not at all required. Even if you trace the entire length of the esophagus, it does not mean that there is no atresia anywhere. All you need to document is the stomach bubble. If you're seeing a nicely filled stomach, subjectively nicely filled stomach, you don't need to measure it, you don't need to use any nomograms to see whether the stomach size is normal. That's a nice filled stomach. That means that there is patency of the esophagus, the swallowed fluid is reaching the stomach, and that indicates that there's no complete esophageal atresia. There could be a H-type tracheoesophageal atresia which you cannot rule out, but tracing the entire esophagus you can with a high frequency probe. You can even see the adrenal gland over here. Can you see the adrenal gland over here?
Yes.
Yes, beautifully seen. That's the medulla inside, which is echogenic, cortex, which is hypoechoic around. That's a nice adrenal gland. Again, you don't need to routinely document it, but with any previous history of adrenal hyperplasia, congenital hyperplastic adrenals, etc., you can look at that as well. So, just caps the kidney over there. Anything else?
Optic nerve.
Optic nerve. Alright, let's see. Okay, let me see if I can get it. That's the long axis of the kidney, and you can see that sector so, yeah. That's the long axis of the kidney and the adrenal sitting on top of the kidney, like a cap. Okay, that's a triangle adrenal. You can see that as well. Okay, let me see if I can show you the optic chiasma. You go back to the cranium, increasing the sector angle. I'm so sorry, you're holding the mic throughout, your hand is alright. Okay, zooming in from the transthalamic plane, I go down to the base of the skull where I expect the circle of Willis. Can you all see the circle of Willis? If you want, I'll put on the color and you see the circle of Willis there. I'm sorry for the interference. I think there's some electrical interference happening there. Ignore that. Can you see the circle of Willis beautifully there? That's the circle of Willis, okay? And in real time, if I go up and down in the circle of Willis, you start seeing a solid bar, horizontal solid bar of tissue inside the circle of Willis, which is actually the optic chiasma. Can you see this? Seen or not seen? That is the optic chiasma. You can measure it. You can use nomograms to tell you whether the optic chiasma is normal. 5 millimeters for 22 weeks is good. It's actually very surprising that I'm getting the optic chiasma in a 22 weeks fetus. This lady is beautifully thin and we are using a high frequency probe, so you're getting the optic chiasma well. Otherwise, generally we expect to see the optic chiasma at least after 24 weeks. That's that horizontal bar that you can document for the optic chiasma. Optic nerve is a little bit more difficult transabdominally. You'll see optic nerve better transvaginally. But you go to the orbit, go to the retroorbital area, the cone behind the orbit, and go a little laterally. Okay, can I move the zoom up? Okay, go a little bit more laterally into the retrobulbar region. There is going to be a lot of shadowing because of the bony orbit around, and if you go a little up and down, you should find the optic nerve. Can you see the movement of the orbit? Nicely moving. Lot of shadowing here. Fetus is also very jumpy, so I'm not able to freeze properly. But in the retroorbital, that's the orbit. Can you see the nice hyaloid artery going from the lens to the optic cup? Okay, that is the optic cup, and this structure that you're seeing behind is a part of the optic nerve. It's not very clearly seen as the section is not good. There's shadowing from this bone over here, but this is part of the optic nerve. You'll get it much better transvaginally. We don't expect. There we go. Can you see that? Beautiful. Zoom in further, reduce the gain, optimize your image. This hypoechoic line is the optic nerve. Yes? Good. Are we done? I think I should stop. We can show any number of structures, but I think this completes our anomaly scan.
Radiologist from Karnataka Institute of Fetal Sciences for an extensively informative session. Live demonstration on fetal Doppler by Dr.Muralidhar Kamalapur. Dr. Muralidhar Kamalapur sir is a consultant radiologist and fetal medicine specialist, Department of Fetal Medicine and Intervention, Father Muller Medical College, Mangalore. He is a secretary of Society of Fetal Medicine, Karnataka chapter. He has completed his MBBS in JN Medical College, Belgaum, and his residency in DMB, New Delhi, SDM Medical College, Dharwad. He has 15 plus research articles in national and international journals. He is a faculty of national and state conferences. We welcome you, sir.
Outset, I'd like to congratulate IRIA Karnataka for venturing into the outreach programs and also the organizing committee at Kodagu Institute of Medical Sciences. So I'll be demonstrating a case which has been priming gravida, hypertensive on labetalol. So I'll be doing demonstrating the growth and the Doppler aspects of this case. So initially, so I'll be demonstrating growth as well as Doppler. Initially, I do a survey of the fetus. I just want to know how is the lie of the fetus. It's it's a breech presentation. Then liquor, as you eyeball, you see that liquor is reduced. So now I am on the right lateral aspect. The spine is anterior on the right lateral aspect, maternal right, and liquor is grossly reduced and the placenta is posterior. So with these things, we will start to evaluate this fetus. Either you go with the biometry first and then look into certain aspects. But here the main area, as she is hypertensive, we need to look into the growth as well as the Doppler parameters. So you can evaluate the growth, the biometry, whichever way you want, whether it's head to toe or being opportunistic as told by Rachitha, whichever area. But here I am first focusing on the head, right? So I am focusing on the head. I want to measure the BPD and the head circumference. So in the first stage, I go into the transthalamic plane and I look for the biparietal diameter. Kindly note that when you are in the transthalamic plane, you should always see the KoIMS septum pellucidum anteriorly. This always serves as a checking point to evaluate all the three axial planes. So after seeing the BPD, which is almost less than third centile, I go and look for the head circumference. So the head circumference is roughly coming up to 30 weeks. So the biparietal diameter and HC are less than third centile, right? So I would also like to have a look at the posterior fossa. This I always do because I want to look at the vermis, because I have not done the scan. Even though you have done the scan, the posterior fossa always has a relook during third trimester, the fourth ventricle and the vermis. Then I have a short look at the ventricles, right? I don't measure the ventricles in third trimester in all cases, but I have a eyeballing of the ventricles and the choroid plexus. Here in this case, liquor is less, so you might not, these are the real time case challenges. You might not get a classical clear images as you expect them. But now once I have seen the measured head circumference, I would like to go and look for the Doppler. So when I look at the Doppler, I would like to zoom and look for the greater wing of sphenoid. And then at that point, you can appreciate some pulsations, right? You are able to appreciate some pulsations. At that point, you put color, right? You can nicely see the circle of Willis. You can adjust the PRF to your to the most appropriate stage. Then you can actually reduce the box size to focus that part of the MCA. You need not have this bigger box. So I am focusing here, then I put the pulse. It's very important that you need to have the angulation correct, parallel, less than 30 degrees has to be the angulation between the long axis of the MCA. You can see that how the mother's breathing movements is affecting. So you measure the MCA parameters. So you can see PI is around 0.85. It's definitely reduced. Now when you see the waveform, usually MCA has a high resistance waveform, but here the resistance is reduced, and that's why the MCA PI is actually measuring 0.85, which is much reduced than what we normally see. Now after going to the MCA, the next vessel you would like to look for is the umbilical artery. It's always better you choose the free loop of the cord, not near the fetal or the placental ends. So whenever you do have a case with reduced liquor and you are unable to track the cord, just put colors, right? And make sure that it's away from the placenta and even at the fetal end. Now you are classically seeing that the umbilical artery is pulsating. Normally we don't see an umbilical artery pulsating like this. So this itself is the initial clue to tell that what you are going to expect on Doppler. So you are going to expect high resistance in the umbilical artery on the Doppler angle. Now, as expected, you can see the resistance is high. There is no absence of diastolic component, but it's high. It's as high as around 1.48, right? So you have a case, a hypertensive female, 34 weeks, with a high resistance in umbilical and a low resistance in MCA. Low resistance in MCA tells you that there is redistribution of central redistribution happening. So apart from this, what would you like to do next? Which vessel you would like to see? Ductus venosus, yeah. So I usually have a protocol. That is a protocol that you have some abnormality in either the MCA and umbilical artery like this, you have a problem. So the next thing our obstetrician will ask, what is the time frame we are looking at, right? So how much can I wait? So the two things which I always tell them is a diastolic component in the umbilical and the ductus venosus Doppler. So these two things I always look for tell the obstetrician what is the time frame we are looking at. And of course they do the CTG and do monitor her blood pressure. I have seen in good number of cases where patient comes with absent diastolic flow. Momentarily they are not treated well. They come, they undergo antihypertensive measurement, treatment, and then after a couple of 1 day or 48 hours, we see there is slight improvement in the umbilical artery Doppler, and that gives us a clue to say that how clinical manifestation and treatment does have impact on management. I am trying to figure out umbilical ductus venosus. It's difficult in third trimester, especially when the liquor is less. But there are two ways. One is axial and a sagittal. I am trying to go through the sagittal section. You always see alazing at the area of ductus venosus. An important practical aspect when you use power Doppler, the alazing is not well appreciated. This is not practice. I'll try it sagittal way because I'm not getting the right section because of the reduced liquor I am unable to get to the right plane, but I'll try my level best. But you have to, it's always better you get a ductus because that really helps.
Applause. Sir is also an eminent radiologist. Welcome you to the CME, sir.
This still has a time. More so that my diastolic component in the umbilical artery is above the baseline and ductus venosus is way above the baseline when the PI value is well within normal limits. At this stage, it's also important that you evaluate the uterines. Because I am seeing the case for the first time. I don't know what is the status at the first trimester. So you also get to know the maternal component, what's really happening in this case. So the very look of the right uterine is satisfactory, that there is no resistance in the right uterine artery. And I would like to see the left uterine artery. It's very important to have your angulation less than 35 degrees, almost along the long axis of the vessel. The left uterine artery does show mild bit of resistance. It's measuring around 1.77. We'll calculate the mean of the two, and then the growth parameters, what we have seen is less than third centile. I need to again look for the other growth parameters. I have done with the head. Then I would like to see the abdominal circumference, and this is one such indication where it's always better you follow a trace method to look for the AC. Especially when you don't get the exact contour of the abdomen. So you measure the AC of the using the trace method. So it's around 28 weeks 4 days, less than third centile. So the next parameter what I would like to see is the FL. It's always better you always avoid the epiphysis to be in your measurement. It's always diaphyseal length. So you are getting all the parameters in the range of 28 to 29 weeks, and all the parameters are symmetrically reduced, that is around third centile. So when you view the report, what you get to see is all the parameters are less than third centile, so as even in the weight, but the Doppler parameters, when you look at, it's definitely the CPR is reduced. You have a CPR of 0.57. Then at this stage, we go and put them in our calculator charts, and then we'll but practically what happens, my obstetrician will ask, what should I do? So what are the two things which I will tell them to please monitor, and I'll rescan the patient. That is some amount of diastolic flow present in the umbilical artery and a very good ductus venosus flow. So it falls under stage 1 FGR. Stage 1 FGR is we have to just evaluate the patient, and we need to take it up with following up the scans. The Liker is definitely less. I'll just evaluate the Liker, and then this categorizes into stage 1 fetal growth restriction. So we need to regularly follow up with the Doppler as well as the Liker and the growth. It's usually a bi-weekly Doppler because she is hypertensive, and the close monitoring has to be done. So the percentile CPR ratio is definitely less than the first centile, and this fetus requires regular follow-up for umbilical, MCA and DV, and that will help you to help the obstetrician plan the termination or delivery. So the Liker, how do you measure the Liker? I usually follow the 4-pocket method, because even during an anomaly scan, following a single pocket becomes very tricky at times. 4-pocket. So always remember that whenever you are measuring the Liker, always when you are measuring the Liker, it has to, your probe has to be longitudinal, straight. This pocket should not contain any of the part or umbilical cord. So I got one pocket. This is another pocket. This is the 4th pocket. So you measure all the 4 quadrants. AFI of 11. I'm okay with the AFI. I'm not pressing the panic button. So the Dopplers are definitely not normal, but there is no need for emergency intervention at this stage. She'll be on close follow-up with good medication and proper rest, etc. Basically, they have to monitor the BP and treat her hypertensive status, and then we'll do a bi-weekly follow-up and then take the pregnancy as it progresses. What other points I would like to tell here is, apart from the Doppler, as a part of the third trimester scan, what you are supposed to see, right? Here you are looking at anterior spine. You look for the lie of the fetus. Fetus is breech. You comment on did all your parameters. There are certain structures which you need to see. The one important structure is looking for the position of the stomach, right? Stomach, why? In the sense, diaphragmatic hernias are always progressive. You might have done an anomaly scan and it would have looked normal, but it can progress to a hernia at a later stage. It's always important, especially when you get a case at around 28 weeks or even at a later stage, to demonstrate the position of the stomach. Here you can appreciate the stomach well within the abdomen. Spine is anterior. At the same time, you just look at the kidneys, right? You can also appreciate the two kidneys. We basically look for the position of the renal pelvis. You know, UTD can be progressive. It can manifest as a renal pelvis dilated urinary tract dilatation at later stages. So that is what I am looking for. And then, as a screening tool, you just anyway you are in the axial section, just do an axial sweep to look for the spine. Right? Not required if you already had a regular report done by a regular person elsewhere. Another important thing what I look for in all cases coming for third trimester is aortic arch. Recently we had a case which presented to us at 34 weeks. It had ventricular asymmetry and it was a classical coact. Baby delivered, we did a CT scan, it was a preductal coact, and baby was shifted to Bangalore for further treatment. So I am trying to get aortic arch. It's very important these days that you do look for the aortic arch. I usually look for, when I'm looking at the spine, especially when the spine is anterior, it's not that difficult to get an aortic arch. You don't have to measure the aortic isthmus in all cases. You can just do an eyeballing, and you can at this stage just put color and look for the caliber of the arch. And even if you have some narrowing, you can further go ahead and evaluate. See, you can nicely see the aortic arch and the branches of the aorta. So as a part of extended growth scan, you have to look for 1 stomach bubble in the abdomen, 2 kidneys, 3 aortic arch, and you can also add up with a 4-chamber view. It's not easy in this case because liquor is reduced, and even with change of positions it's not going to change. And I also look for the posterior fossa, because we had a case of Joubert syndrome which we came to us, the open fourth ventricle. So that we always look for those cases. Non-closed posterior fossa, where an anomaly scan is not done in a proper way, or you don't have the reports of a good anomaly scan. So you have gone through an overview, and you also saw a case of FGR in a hypertensive lady, and you evaluated this.
List of radiologists from Karnataka Institute of Fetal Sciences for an extensively informative session.
Now invite an esteemed academician, a guiding force within the department, Dr. Sachin L. Sir, Associate Professor and In Charge HOD, Department of Radiodiagnosis, KoIMS Madikeri, to deliver the welcome speech.
Invited guests, dear colleagues and students, it gives me immense pleasure to welcome you to all this continuing medical education program organized by IRIA Karnataka State Chapter and Department of Radiodiagnosis, KoIMS Madkeri. At the very outset, I extend a warm welcome to our esteemed Chief Guest Dr. Mantar Gowda sir, Honorable MLA Madkeri Assembly Constituency, whose presence adds grace and significance to this gathering. Sir made significant contribution to our Kodagu Institute of Medical Science for the first time, bringing 1.5 MRI Tesla machine. And he is the backbone for organizing this CME. So we welcome you, sir. We welcome. Yes. Now I welcome Dr.Paveen GU sir, President IRIA Karnataka State Chapter. Welcome you to the event, sir. A warm welcome to Dr.Lokesh sir, our esteemed Dean and Director, whose guidance have been instrumental in transforming KoIMS into a beacon of clinical and academic excellence. We welcome you, sir. Srimati Rohini Madam, our Chief Administrative Officer, KoIMS, we welcome you, ma'am. I also extend my welcome to Dr. Vishal Kumar sir, Principal KoIMS. On this occasion, we welcome you, sir. I take this opportunity to welcome Dr. Somshekar sir, Medical Superintendent, KoIMS Teaching Hospital. We welcome you, sir. I welcome Dr. Nanjundaya sir, District Surgeon, KoIMS Teaching Hospital. We welcome you. A warm welcome to Dr. Shyam Ampanna sir, Consultant Radiologist and IMA President, Kodagu. We welcome you, sir. A heartfelt welcome to Dr. Chetan MU, Secretary KGMO, Kodagu. I welcome Dr. Nanjraj sir, ex-Dean MMCRI and retired HOD Radiology Department MMCRI. Now he is the Vice Principal of Chamundeshwari Institute of Medical Sciences. We welcome you, sir. Now I welcome Dr. Vijay Sadhi sir, Secretary IRIA Karnataka State Chapter. Sir is also the active member of Inspection and Monitoring Committee of PCPNDT Karnataka. Sir is the main person who inspired us and guided us in organizing this CME. Wonderful esteemed speakers, Dr. Raghavendra sir, Dr. Murli sir, Dr. Rachitha ma'am, Dr. Ravi sir and Dr. Pratiksha, who has travelled from a long distance to enrich our knowledge with their expertise. Teaching and non-teaching staff and our dear students, we wish today's session leave you enriched, informed.
Let us begin our event with the lighting of lamp as we invoke the Almighty.
प्रिय हे गणप साकार वंदने हे गणप नಗುमुಗದಿಂದ ಜಗವನ್ನು ನೋಡುತ್ತ ಮಂದಹಾಸದಲ್ಲಿ ಕುಳಿತಿಹ ದೇವಾಗನಾಥ ಧಿಮಿ 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 ನಾಟ್ಯ ಸ್ವರೂಪ ನಿನಗಿದು ಅರ್ಪಣೆ ಭಕ್ತಿಯ ಧೂಪ ಹೇ ಪ್ರಭು ನಿನಗಿದು ನಮ್ಮ ನಮಸ್ಕಾರ ಓಂಕಾರನಾದ ಪ್ರಿಯ ಹೇ ಗಣಪ
ಈ ಬೇಕು ಬಂದರೆ
Fellow radiologists, teachers, and students to Kodagu Institute of Medical Sciences. It's a privilege having our own people where I started, where I've started and I've now ended up as a representative of the Legislative Assembly of Madikeri. My roots I'll never forget, right from MBBS days to MD days and then working as a radiologist for 4 to 5 years. So I keep saying, when there's always an alternative for doctors. Politics is a very good alternate job career as well. So firstly I'd like to thank our IRA president, Dr.Paveen sir, for helping us and hosting the program in our own institute, KoIMS. Our secretary, Dr. Vijay Sarthi sir, he is one of our teachers as well during my PG days. And Dr. Subhash also was here, but now he's stepped out for a bit. And Dr. Mahesh, all of our senior radiologists who have helped me during college days. Our departmental two stalwarts, we have only two. So Dr. Ananda and Dr. Sachin, who have, the burden is immense for them. And with that, you're adding a CME to your hectic schedule is a great way of actually saying that we're also improving, teaching other students and imparting knowledge for everyone else. And especially in this place called in Madikeri, and I'm guessing all our students, it's a privilege to actually be in this kind of a setup to study. But to practice, nobody wants to come back. So that's another topic of discussion. And from our departmental side, I'd like to again welcome Dr. Lokesh sir, then Roni madam, our principal, Dr. Vishal, Somshekar sir, Nanjundaya sir, Dr. Mohan Appaji, our Dr. Chetan, and all our distinguished speakers for today. So this is actually like a nostalgic situation where we used to run off every time we used to get a chance from college to attend these CMEs and programs. But what we used to really feel bad is, whenever it used to fall on a Saturday, Sunday, we used to feel like, sir, yes, sir, Sunday. So Monday, Raja Kodi, sir, and we used to keep asking our departmental HODs. But the best part of life, what I'm thinking is, to join medicine, more than the degree is, medicine humbles you more than in many ways. When you come in from a political background and you come in from a decent background, arrogance sets in when you try to achieve during your progress. But medicine humbles you quite a bit. That has actually helped me to achieve where I've come. Otherwise, what happens is you've seen politicians' children and how they behave and how they interact with people. So it humbles you, it makes you bow down for everyday service. So that arrogance comes down whenever you see patients with their issues and their, so not only sympathetically but empathetically also you have a connection with the patients and on a day-to-day routine. And coming to the radiology side, I was privileged to study in Kempegowda Institute of Medical Sciences 2008-2011. We had a huge distinguished teachers. We had our HOD Dr. Srinivas Babu sir, Dr. Krishnappa, and our speakers, Father Dr. Ramamurthy sir. We've been privileged, Dr. Balakrishna Shetty, and then we've had other guest faculties coming in and going in who have actually shaped us. And unfortunately, they couldn't contain me into the department and continue with medicine. But I think 3 years of college is one of the best times you'll ever have talking to the students. Wherever you can learn from these kind of interactive studies is the best way to go ahead. And my thinking was, the way I did it was, I just went to college regularly. I didn't have to do something like majorly sit and study. Okay, understood. Then during the examination time, we used to sit and study. But just attending regular day-to-day classes, day-to-day work in clinical wise, that's more than enough where you pick up cases and you can study on hand. But what happens is, as students, we just keep everything to the end of the end of 3 years and expect to study all three, for all the 3 years in the last 1 month of studies. It gets a little hectic. But when I was studying in KoIMS, I was the second batch of students. So we had only 2 MDs, I think 1 senior MD and me. So it was a very difficult time because even the college didn't know what has to be done, how the teaching methods had to be done. But now I'm thinking there are huge curriculums which are put through for every colleges, and the number of radiologists also increased. Unfortunately, in our district, Shyam sir is the only one of few people who are practicing privately, and Sachin and Ananda are the only few guys. So I kept on requesting our seniors, as in our Ministry of Health and Medical Education, whenever you need me to practice as well, I can come, but my reports will be a little faulty because I haven't practiced for a long time. But my students enjoy these 3 years. I know it's a big headache, it's a burden, but if you take it positively, I'm sure I'm sure you'll do well. Passing the exam is the easiest way. Is the easiest part of it. But to take what knowledge you have for practice every day is most important. What happens is, what you do in college, you will never do that practice. So my thinking is, getting knowledge, getting degrees are not as important as developing skills and patient interactive skills. That is most important. What happens is, now this we had an FGR patient here, and now what happens is, how do we follow up that patient? How do we actually connect with them? And what happens after delivery? Is the child okay? That kind of a holistic approach, if you get into during the training, you develop as a complete doctor. It's not only yes case how many cases you did. I did 30 CTs, 25 ultrasounds. It becomes a number game. Radiology should never be a number game. Though it is a very competitive field, people want to beat one another. You want to go one up on the other diagnostic center, or as practice is the number of cases you do. It's not quantity, it's quality. Where I've learned from Srinivasa scans, Dr. Ramamurthy sir, he sees only 10 to 20 patients, and I was privileged that all my 3 children were scanned by my wife during 3 pregnancies was scanned by him, and so that way you should develop much more than just acquiring subject knowledge. And one more important thing which I like to tell the students is, be positive in what you study. College time is very difficult, pressures of duty, pressures of social obligations are always there, but it should be a happy and positive kind of a 3 years. Then actually you because my college life was hell. I should actually to tell you this, I did Saturday duties for 2.5 years. So from first year MD to the final 6 months just before giving my exams, they made me do Saturday morning up to Sunday afternoon. So it was like a torture, but still, we enjoyed it, we studied well, it went off positively, so it was a great achievement by us. And a few subjects which I really like actually is, I had one semi-dissertation type we did was sonography of aneuploidy. So at that time, we didn't have specified fetal, cardiac, soft markers, I've forgotten all that. And then also we had one, I think if Vijay Sathi sir remembers, I did a poster presentation in one of our IRIA in this one for GIST, gastrointestinal stromal tumors. And then there was, unfortunately we couldn't get the cell typing or whatever you all call that from some stainings. I'm sorry. So don't get into politics, stick to the medicine field. And there are lots of vacancies in Kodagu. Kindly, after you pass, I'm selling our brand Kodagu for all the new radiologists who pass out. Please come and work here, and it's a beautiful place. And once you come here, you'll never leave. So, but that initial stage of setting up your practice is a little difficult. I'm wishing all our students the very best. I'm hoping today's CME with our distinguished speakers improves your mental acumen on the subject, and make sure you all attend more of these programs, because only when you all visit other institutes, you know how much less you know. And then don't be scared, because that might not come in the exams, but comparatively you should be at least in one way. Because when I remember when there were DNB students who were excelling in CT and MRI, but they did not do much ultrasound and X-ray, basic X-rays. So there's a balance which needs to be made, and you can't say I'm going to only study or practice X-ray, ultrasound, CT or MRI. A holistic radiologist is when you have all modalities and you're well versed with all modalities, and very importantly is like the teachers and the speakers here, you all also should share knowledge to others as well. Now, once you learn something, you don't want to share it, because if it comes in the exam, I'm the only one who needs to know it. So, not holding up this program any further, I would like to wish all the students a very best. And radiology and radiodiagnosis is a very elite subject, a very elite profession, but don't make it very commercial. Do it as and do it as a service as well. And once the service comes through, 100% of that financial backing, financial aspects will follow and suit. So I wish all of you all the very best. I thank once again our IRIA chairman, Dr. Paveen, and Secretary Vijay Sarthi sir for having it in Coorg. Attendance might be slim, but the other people are missing out on the beautiful weather of Kodagu as well. So make sure you all may rub that into the students who didn't come into our program. Thank you, our volunteers and students of KoIMS for helping out. I wish all of you all the very best again. Thank you.
President IRA, Dr. Praveen GU, and other dignitaries on the dais and off the dais. My dear students, colleagues, and speakers and guests here. So this CME is organized by radio department. So they are very busy. I can make out. But in spite of that, they have arranged this CME program. And this is the place where you can share your knowledge. And depending upon the places, regions, and availability of facilities, all this the caseload will varies, and PG students will learn so many things. So during your college time, you know that however busy it is, so they should take it as a passion. Okay, during your PG course, you don't grumble for more cases, more duties, all those things. So this will definitely help the department, and also gives good service to the patients also. So nowadays, you know, the CBME curriculum, the MBBS undergraduate, if you take competence-based medical education has been started. So here, even first year also, starting in the anatomy itself, they need to know a little bit of clinical details. Okay, like early clinical exposure is one of the component. So there, in case of radiology, we will teaching from our level whatever best we will teach. X-rays, something about X-rays, special X-rays. So we are not competent enough as anatomists to teach about MRI, CT, all those things. So even for the first years, even students also, it is the basics of the radiology is quite useful. Okay, for so that they can second year or third year final if they come, they can correlate so very easily with the clinicals. So with this note, I wish good luck for the Department of Radiology. So thank you.
ನಿನ್ನೆಯಲ್ಲಿ ಮೊದಲು ಕೊಡಗು ಜಿಲ್ಲೆ ತಲುಪ್ತಿದ್ದಂಗೆ ಬಹಳ ಜನಕ್ಕೆ ಅನಿಸುತ್ತೆ ಅಂತ ನನ್ನ ಭಾವನೆ. ಕೊಡಗು ಜಿಲ್ಲೆಗೆ ಬಂದ ತಕ್ಷಣ ನಮ್ಮ ದೇಶದ ಬಾವುಟ ಕಾಣಿಸುತ್ತೆ. ಯಾಕಂದ್ರೆ ನಮ್ಮ ರಾಜ್ಯದಲ್ಲಿ ಅತಿ ಹೆಚ್ಚು ಯೋಧರನ್ನು ನೀಡಿದ ಸ್ಥಳ ಈ ಕೊಡಗು ಜಿಲ್ಲೆ. ಇಷ್ಟು ಯೋಧರನ್ನು ಕೊಡೋ ಜಿಲ್ಲೆಯಲ್ಲಿ ಮಾನ್ಯ ಶಾಸಕರು ವೈದ್ಯರನ್ನು ಸಹ ಕೊಡಬೇಕು ಅಂತ ಈ ಒಂದು ಸಂಸ್ಥೆನ ನಿರ್ಮಿಸಿದ್ದಾರೆ. ಸರ್ಕಾರದಿಂದ ಪ್ರತಿಯೊಂದು ಅನುಮತಿ ಪ್ರಗತಿಗೋಸ್ಕರ ಪಡೆದು ಈ ಒಂದು ಸಂಸ್ಥೆನ ಅತ್ಯುತ್ತಮ ಮಾಡಬೇಕು ಅಂತ ಒಂದು ಏನು ಅವರ ಆಸೆ ಆಕಾಂಕ್ಷೆ ಇಟ್ಕೊಂಡಿದ್ದಾರೆ, ಅದು ಯೋಧರ ಥರ ವೈದ್ಯರು ಸಹ ಇಲ್ಲಿ ಹೆಚ್ಚಾಗಿ ಬರಲಿ ಅಂತ ಆಶಿಸ್ತೀನಿ. ದೇಶ ಕಾಯಕ್ಕೆ ಯೋಧರಾದರೆ ಆರೋಗ್ಯ ಕಾಯಕ್ಕೆ ವೈದ್ಯರು ಅನ್ನೋ ಒಂದು ದೃಷ್ಟಿಲಿ ಈ ಒಂದು ವೈದ್ಯಕೀಯ ವಿದ್ಯಾಲಯ ಬಂದಿದೆ. ಶಾಸಕರು ಹೇಳಿದ್ರು ಇಲ್ಲಿ ಹೆಚ್ಚು ಜನ ಸೇರ್ತಾ ಇಲ್ಲ, ಆದ್ರಿಂದ ಐ ವಾಂಟ್ ಟು ಬಿಕಮ್ ಎ ಬ್ರ್ಯಾಂಡ್ ಅಂಬಾಸಿಡರ್ ಟು ದಿಸ್ ಇನ್ಸ್ಟಿಟ್ಯೂಟ್ ಟು ಗೆಟ್ ದಿ ಡಾಕ್ಟರ್ಸ್ ಅಂತ. ಇದಕ್ಕೆ ಮಾನ್ಯ ಶಾಸಕರಲ್ಲಿ ಒಂದು ಮನವಿ ಮಾಡ್ಕೊತೀನಿ. ಹೇಗೆ ನಮ್ಮ ದೇಶದ ನಾರ್ತ್ ಈಸ್ಟ್ ಸ್ಟೇಟ್ಸ್ಗೆ ಏನು ಹೆಚ್ಚುವರಿ ಆರ್ಥಿಕತೆಗೆ ಸಹಾಯ ಮಾಡ್ತಾರೆ, ಈ ಜಿಲ್ಲೆಗೆ ಬರುವವರೆಗೆ ಬೇರೆ ಯಾವುದೇ ಒಂದು ಸರ್ಕಾರಿ ವೈದ್ಯಕೀಯ ಕಾಲೇಜಲ್ಲಿ ಇರೋದಕ್ಕಿಂತ ಹೆಚ್ಚು ಆರ್ಥಿಕತೆಯನ್ನು ಡಾಕ್ಟರ್ಗಳು ಕೊಟ್ಟರೆ 100% ಬರ್ತಾರೆ ಸರ್. ಅವ್ರಿಗೆ ಒಂದು ಅದು ಎಕ್ಸ್ಟ್ರಾ ರಿಮ್ಯುನರೇಷನ್ ಇರ್ಬೋದು, ಸೌಲಭ್ಯತೆ ಇರ್ಬೋದು ಕೊಟ್ಟರೆ ಇದು ಪ್ರತಿ ಯಾವುದೇ ಒಂದು ಸರ್ಕಾರಿ ವೈದ್ಯಕೀಯ ವಿದ್ಯಾಲಯಕ್ಕಿಂತ ಹೆಚ್ಚು ಮಾನ್ಯತೆ ಅಂತ ಪಡೆಯುತ್ತೆ ಮತ್ತು ಹೆಚ್ಚು ಪ್ರಗತಿ ಪಡೆಯುತ್ತೆ. ಈ ಒಂದು ನಿಟ್ಟಿನಲ್ಲಿ ತಮ್ಮಲ್ಲಿ ಮನವಿ ಸಲ್ಲಿಸ್ತಾ ಇದ್ದೀವಿ. ನಮ್ಮ IRIA ಪರವಾಗಿ ಈ ವರ್ಷ ಕಾರ್ಯಕ್ರಮಗಳು ಮಾಡಕೊಬೇಕು ಅಂತ ನಾವು ಅಂದ್ಕೊಂಡಾಗ ಮೊದಲನೇ EC ಮೀಟಿಂಗಲ್ಲಿ ಪ್ರತಿ ಸರಿ ಬೆಂಗಳೂರಲ್ಲೇ ಆಗ್ತಾ ಇದೆ ಜಾಸ್ತಿ, ಎಲ್ಲ ಜಿಲ್ಲೆ ಕಡೆಗಳು ಹೋಗ್ಬೇಕು, ಎಲ್ಲ ಕಡೆ ಕಾರ್ಯಕ್ರಮ ಮಾಡಬೇಕು, ಎಲ್ಲ ಕಡೆ ನಮ್ಮ IRIA ಒಂದೇ ಎಲ್ಲ ರೇಡಿಯಾಲಜಿ ಬಗ್ಗೆ ತಿಳಿಸ್ಬೇಕು ಅಂತ ಹೇಳಿದಾಗ ನಮ್ಮ ಸೆಕ್ರೆಟರಿ ವಿಜಯ ಸಾರಥಿ ಅವರು ಜಿಲ್ಲೆ ಕಡೆ ಅಂತ ಒಂದು ಕಾರ್ಯಕ್ರಮ ಶುರು ಮಾಡೋಣ ಅಂತ ಹೇಳಿದ್ರು. ಈ ಜಿಲ್ಲೆ ಕಡೆ ನಮ್ಮ ನಡೆ ಏನು ಕಾರ್ಯಕ್ರಮ ಇದೆ, ಎಷ್ಟು ಸಾಧ್ಯವೋ ಅಷ್ಟು ಜಿಲ್ಲೆಗಳಲ್ಲೂ ಒಂದೊಂದು CME ವರ್ಕ್ಶಾಪ್ ಇರ್ಬೋದು, ಔಟ್ರೀಚ್ ಪ್ರೋಗ್ರಾಮ್ ಇರ್ಬೋದು ಮಾಡಬೇಕು ಅನ್ನೋ ನಿಟ್ಟಿನಲ್ಲಿ ಅವರು ನಮ್ಮ ಆನಂದ್ ಮತ್ತು ಸಚಿನ್ ಅವ್ರನ್ನ ಮಾತಾಡಿಸಿ ಇವತ್ತು ಇಷ್ಟು ಮಟ್ಟಿಗೆ ನಿಮ್ಮ ಕೊಡಗು ಜಿಲ್ಲೆಯ ವೈದ್ಯಕೀಯ ವಿದ್ಯಾಲಯದಲ್ಲಿ ಈ ಕಾರ್ಯಕ್ರಮ ಇದೆ ಎಂದೇ ಒಂದು ಕಾರಣಕರ್ತರು ಅವರು ಮತ್ತು ಸಚಿನ್ ಮತ್ತು ಆನಂದ್ ಅವರು. ಇಷ್ಟೇ ಅಲ್ಲದೆ ಇವತ್ತಿನ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಶಾಸಕರು, ವೈದ್ಯಕೀಯ ವಿದ್ಯಾಲಯದ ಅಧಿಕಾರಿಗಳು, ವೇದಿಕೆ ಮೇಲಿರುವ ಪ್ರತಿಯೊಬ್ಬ ಗಣ್ಯರು ಹಾಗೂ ವೇದಿಕೆ ಮುಂದಿರುವ ಮಾನ್ಯರು, ವಿದ್ಯಾರ್ಥಿಗಳೇ, ಶಾಸಕರು ಹೇಳಿದಾಗೆ ಆ ಆರೋಗ್ಯನ್ಸ್ ಇರ್ಬೋದು, ಯಾವ್ಯಾವ ರೀತಿಯಿಂದ ಒಬ್ಬ ಮೆಡಿಕಲ್ ಸೇರಿರ್ಬೋದು ಅಂತ, ಮೆಡಿಕಲ್ ಮುಗಿಸ್ತೀರ ಅವರು ಟಚ್ ಮಾಡಿದ್ದು ಇದೇ ವಿಷಯನ. ಎವ್ರಿಬಡಿ ಹ್ಯಾಸ್ ಅನ್ ಇಂಟೆಲಿಜೆಂಟ್ ಕೋಶೆಂಟ್, ಬಟ್ you have to develop the emotion quotient. That is where you are going to touch the patient. You are touching the lives of the patient. Their lives are what you will live because of them. That emotional quotient we have to develop. Not sympathy, empathy anta heludru. This is what we show to the patients. Last but not the least, before I conclude, I want to tell IRIA has got many programs. Samrakshan and Raksha program for the girl child and the women health ಇದೆ. ಅದಾದ್ಮೇಲೆ ಶಕ್ತಿ ಅಂತ ಒಂದು ಪ್ರೋಗ್ರಾಮ್ ಅದು, ದಟ್ ಈಸ್ ದ ವುಮೆನ್ಸ್ ವಿಂಗ್ ಆಫ್ IRIA. ಹೆಚ್ಚಾಗಿ ಮೇಯ್ನು ನಮ್ಮ ಫೀಮೇಲ್ ರೇಡಿಯಾಲಜಿಸ್ಟೇ ಮಾಡೋ ಒಂದು ಕಾರ್ಯಕ್ರಮ ಇದು. ಇದಕ್ಕೂ ಎಲ್ಲರೂ ಜಾಯಿನ್ ಆಗಿ ನಮ್ಮ ಪ್ರತಿಯೊಂದು ಕಾರ್ಯಕ್ರಮನ ಬೆಂಬಲಿಸಿ ನಮ್ಮನ್ನು ನಿಮಗೆ ಸೇವೆ ಮಾಡೋ ಒಂದು ಅವಕಾಶ ಕೊಡಿ ಅಂತ ಕೇಳ್ಕೊತೀನಿ. ಹಾಗೂ ಇವತ್ತಿನ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಒಂದು ಔಟ್ರೀಚ್ ಪ್ರೋಗ್ರಾಮ್ ಆಗಿ ಸ್ಕೂಲ್ಗೆ ಚಾರಿಟಿ ವರ್ಕ್ ಮಾಡ್ತಾ ಇದ್ದಾರೆ, ಅದಕ್ಕೂ ಸಹ ಧನ್ಯವಾದಗಳು. ಮತ್ತು ನಮ್ಮ ಶಾಸಕರಿಗೆ ಕೊನೆಯದಾಗಿ ಒಂದು ಹೇಳ್ಬೇಕು ಅಂದ್ಕೊಂಡಿದ್ದೀನಿ. ಅವರು ರೇಡಿಯಾಲಜಿಸ್ಟ್ ಇದ್ದಾಗ ಫೀಟಲ್ ರೇಡಿಯಾಲಜಿ ನೋಡಿದಾಗ ಆ ಫೀಟಸ್ನ ನೋಡಿ ಕೊನೆಗೆ ಅದು ಅಂಬಲಿಕಲ್ ಕಾರ್ಡ್ ಕಟ್ಟಾಗೋವರೆಗೂ ಅವ್ರ ಜವಾಬ್ದಾರಿ ಇತ್ತು. ಇವತ್ತು ಈ ಕಾಲೇಜಿನ ಪ್ರತಿಯೊಂದು ವಿಭಾಗನೂ ಬೆಳೆಸಿ ಕಟ್ಟಿ ಅದ್ರ ಟೇಪ್ ಕಟ್ ಮಾಡೋವರೆಗೂ ಅವ್ರ ಜವಾಬ್ದಾರಿ ಇದೆ. ಬೆಳಿಗ್ಗೆ ಬಂದಾಗ ನಮ್ಮ ಡಾಕ್ಟರ್ ಲೋಕೇಶ್ ಅವರು ಸಹ ಯಾರು ಬಂದ್ರು ಎಲ್ಲಿಂದ ಬಂದ್ರು ಬರ್ಮಾಡಿಕೊಂಡು ತಿಂಡಿ ತಿನ್ನೋವರೆಗೂ ಬಿಡ್ದಂಗೆ ತಿಂಡಿ ತಿಂದ ಆಮೇಲೆ ಒಳಗಡೆ ಕೂತ್ಕೊಳ್ಳಿ ಅಂತ ಹೇಳಿದ್ರು. ಈ ರೀತಿ ಇಷ್ಟೊಂದು ಜನ ಬಂದಿದ್ದೀರಾ. ಆಮೇಲೆ ಸ್ಟೂಡೆಂಟ್ಸ್ ಸಹ ಬೆಳಿಗ್ಗೆ ನಾವು ಬರೋಕ್ಕೆ ಮುಂಚೆನೇ ಬಂದು ಕೂತ್ಕೊಂಡಿದ್ರು. ಭಾನುವಾರ ರಜೆ ದಿನ ಆರಾಮಾಗಿ ಮಲ್ಕೊಳ್ಬೇಕು ಅಂತಿದ್ರು ಅನಿಸುತ್ತೆ. ಆದರೂ ನಮ್ಮ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಬಂದಿದ್ದೀರಾ. ಬಂದ್ರೂ ಆ ಕೆಲಸ ಮಾಡಿದ್ರು ಏನೋ ಒಂದು ವಿದ್ಯೆ ಕಲ್ತಿದ್ದೀರಾ ಅಂತ ಭಾವಿಸ್ತೀನಿ. ಹಾಗೂ ಇವತ್ತಿನ ಎಲ್ಲ ನಮ್ಮ ಟೀಚರ್ಸ್, ಸ್ಪೀಕರ್ಸ್ ಅನ್ನೋದಕ್ಕಿಂತ ಅವ್ರಿಗೆ ಟೀಚರ್ಸ್ ಅಂತಲೇ ಹೇಳೋದು ಅತ್ಯುತ್ತಮ ಅನಿಸುತ್ತೆ. ಇಷ್ಟನ್ನು ಹೇಳಿ ಎಲ್ಲರೂ ಒಟ್ಟಿಗೆ ಬೆಳಿಬೇಕು. 2 ಮೆಂಬರ್ಸ್ ಅಂತಂದರು, ಬಟ್ ಆ ಟುಗೆದರ್ನೆಸ್ಸು ಸಹ ಅವರಲ್ಲಿ ಇದೆ. ಇಟ್ ಇಸ್ ನಾಟ್ ಜಸ್ಟ್ TWO, ಇಟ್ ಇಸ್ TO ವಿತ್ ಗೆದರ್. ಇಷ್ಟು ಹೇಳಿ ಇವತ್ತಿನ ದಿವಸ ನನಗೆ ಇಲ್ಲಿ ಕರೆಸಿ ನಿಮ್ಮೊಂದಿಗೆ ಒಂದು ಮಾತಾಡೋ ಅವಕಾಶ ಮಾಡಿಕೊಟ್ಟಿದ್ದಕ್ಕೆ ಎಲ್ಲರಿಗೂ ಧನ್ಯವಾದಗಳು. ಜೈ ಹಿಂದ್, ಜೈ ಕರ್ನಾಟಕ, ಲಾಂಗ್ ಲಿವ್ ಐಆರ್ಇ.
Associate Professor, Department of Radiodiagnosis, to address the gathering.
ವೇದಿಕೆ ಮೇಲೆ ಇರತಕ್ಕಂತಹ ಎಲ್ಲ ಗಣ್ಯ ವ್ಯಕ್ತಿಗಳೇ ಹಾಗೂ ಇಲ್ಲಿ ನೆರೆದಿರತಕ್ಕಂತಹ ವಿದ್ಯಾರ್ಥಿಗಳು ಮತ್ತು ನನ್ನ ಸಹ ಸಿಬ್ಬಂದಿಗಳೇ ಹಾಗೂ ನನ್ನ ಆತ್ಮೀಯ ಎಲ್ಲ ಟೀಚರ್ಸ್, ರೇಡಿಯಾಲಜಿ ಟೀಚರ್ಸ್ಗಳೇ, ಇವತ್ತು ವಿಶೇಷವಾಗಿ ಸರ್ ಮೆನ್ಷನ್ ಮಾಡ್ತಾ ಒಂದು ಕಾರ್ಯಕ್ರಮನ ಹೇಳಿದ್ರು. IRIA ವತಿಯಿಂದ ಸಾಮಾನ್ಯವಾಗಿ ಎಲ್ಲ ಥರದ ಒಂದು ಸೋಷಿಯಲ್ ಔಟ್ರೀಚ್ ಮಾಡ್ತಾ ಇದ್ದಾರೆ. ಅದರಾಗೆ ನಾವು ಕೊಡಗುನಲ್ಲೂ ಸಹ ಬೇರೆ ರೀತಿಯಾದಂಥ ಸೋಷಿಯಲ್ ಆಕ್ಟಿವಿಟೀಸ್ ಮಾಡಲಿಕ್ಕೆ ಒಂದು ಯೋಚನೆ ಮಾಡಿದಾಗ ಕೊಡಗು ಕುಶಾಲನಗರದ ಪರಿಶಿಷ್ಟ ವರ್ಗದ ಬಾಲಕಿಯರ ವಿದ್ಯಾರ್ಥಿ ನಿಲಯದ ಮಕ್ಕಳಿಗೆ ಅವ್ರಿಗೆ ಅವಶ್ಯಕವಾಗಿ ಏನು ಬೇಕಿದೆ, ಏನು ಆಲ್ರೆಡಿ ಅವ್ರಿಗೆ ಗೌರ್ಮೆಂಟ್ ಕೊಡ್ತಾ ಇದೆ, ಅದಲ್ಲದೆ ಏನಾದರೂ ಕೊಡಬೇಕು ಅಂತ ಕೇಳಿದಾಗ ನಮ್ಮ ಶಾಸಕರ ನಿರ್ದೇಶನದ ಮೇಲೆ ಮೊನ್ನೆಗಳು ಅವ್ರನ್ನ ಪರಿಚಯ ಮಾಡಿಸಿ ಅವ್ರನ್ನ ITDP ಆಫೀಸರ್, ಇಲ್ಲಿನ ವಾರ್ಡನ್ ಆದಂಥ ಶಶಿ ಮೇಡಮ್ ಅವ್ರನ್ನ ಕೇಳಿದಾಗ ಆ ಒಂದು ಅಂಬ್ರೆಲಾ ಅವ್ರಿಗೆ ಬೇಕಿದೆ ಮಳೆ ಸೀಸನಲ್ಲಿ ಅಂತೇಳಿ ಒಂದು ಅಂಬ್ರೆಲಾ ಮತ್ತೆ ಒಂದಷ್ಟು ನೋಟ್ ಬುಕ್ಸು ಮತ್ತೆ ನಾವೆಲ್ಲರೂ ಸಹ ಇಂಗ್ಲೀಷ್ ಮೀಡಿಯಂ ಕನ್ನಡ ಮೀಡಿಯಂ ಅಂತ ದಾಟ್ತಿರ್ಬೇಕಾದ್ರೆ ಒಂದು ಡಿಕ್ಷನರಿ ಆ ಥರದ್ದು ಬೇಕೊಂಡಾಗ ಅದನ್ನು ಸೇರಿಸಿ ನಾವು IRIA ವತಿಯಿಂದ ಸರ್ ಈ ರೀತಿ ಆ ಹಾಸ್ಟೆಲ್ನ ಎಲ್ಲ ಮಕ್ಕಳಿಗೂ ಕೊಡ್ತಾ ಇದ್ದೇವೆ. ಬಟ್ ಕುಶಾಲನಗರದಿಂದ ಎಲ್ರಿಗೂ ಇಲ್ಲಿ ಬರ್ಲಿಕ್ಕಾಗಲ್ಲ ಅಂತ ಸಾಂಕೇತಿಕವಾಗಿ ಒಂದು 5 ಮಕ್ಕಳಿಗೆ IRIA ವತಿಯಿಂದ ನಮ್ಮ ಕೊಡಗು ಇನ್ಸ್ಟಿಟ್ಯೂಷನ್ ಮೆಡಿಕಲ್ ಸೈನ್ಸ್ ವತಿಯಿಂದ ಇವತ್ತು ಅವರಿಗೆ ಮಾನ್ಯ ಶಾಸಕರು ಹಾಗೂ ಎಲ್ಲ ಗಣ್ಯರ ವ್ಯಕ್ತಿಗಳು ಅವರಿಗೆ ಈ ಒಂದು ಕೊಡುಗೆಯನ್ನ ಕೊಡೋದ್ರ ಮುಖಾಂತರ ನಮ್ಮ IRIA ಹಮ್ಮಿಕೊಂಡಿರುವಂತಹ ಸೋಷಿಯಲ್ ಸ್ಕೀಮ್ಗೆ ಒಂದು ಸಾರ್ಥಕತೆಯನ್ನ ಕೊಡಬೇಕು ಅಂತ ತಮ್ಮಲ್ಲಿ ಕೇಳ್ಕೊತಾ ಇದ್ದೀನಿ. ಸರ್ ಶ್ಯಾಮಣ್ಣ ಸರ್ ಬರ್ಬೇಕು ಸರ್. ಮಾಡೋಣ ಅಂತ ಹೇಳಿದಾಗ್ಲಿಂದ ಅನ್ನಿಸ್ತು, ನೀವು ಹೇಳಿದ್ರಿಂದ ಇವತ್ತು ಈ ತರ ಆಗಿದೆ ಸರ್. ಹಾಗಾಗಿ ನಮ್ಮ ಶಾಸಕರಿಗೆ ನಮ್ಮ ಇಬ್ಬರ ಕಡೆಯಿಂದ ಮತ್ತೆ ನಮ್ಮ ಕಾಲೇಜ್ ಕಡೆಯಿಂದ ಸರ್. ಹಾಗೂ ನಾನು ಈ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಮಾಡ್ತಾ ನಾವು ನಮ್ಗೆ ಅನ್ಕೊಂಡಿದ್ವಿ ಸರ್, ನೀವು ಇಷ್ಟು ಉತ್ತೇಜನ ಕೊಡ್ತಾ ಇದ್ದು ನಮ್ಮ ಸ್ಪೀಕರ್ಸ್ ಎಲ್ಲ ಬಂದು ಮಾಡ್ತಾ ಇರೋದಕ್ಕೆ ಇನ್ನು ಕೆಲವೇ ವರ್ಷಗಳಲ್ಲಿ ಸರ್ ನೀವು ಅನ್ಕೊಂಡಾಗೆ ನಾವು ಇಬ್ಬರಿದ್ದನ್ನ ಸ್ಟಾಫ್ಸ್ಗಳನ್ನ ಮೊಬಿಲೈಸ್ ಮಾಡ್ಲಿಕ್ಕೆ ಮತ್ತೆ ಈ ತರದ ಆಕ್ಟಿವಿಟೀಸ್ಗಳನ್ನ ಮಾಡ್ತಾ ಇನ್ನೂ ಹೆಚ್ಚಿನ ಸಿಬ್ಬಂದಿಗಳನ್ನ ಇಲ್ಲಿ ಕರ್ಸ್ಕೊಂಡ್ ಬರ್ತೀವಿ. ನೀವು ನಮ್ಮ ಜೊತೆ ಸೊ ಹಂಗಾಗಿ ಅದ್ರ ಜೊತೆಗೆ PG ಬರೋವರೆಗೂ ನಾವಿಬ್ರು ಸತತವಾಗಿ ದುಡಿತೀವಿ ಸರ್. ಅಂಡ್ ವಿ ವಿಲ್ ಬಿ ದೇರ್. ನಮ್ಮ ಡೀನ್ ಸರ್ ಯಾವಾಗ್ಲೂ ಹೇಳ್ತಿರ್ತಾರೆ ಈ ವರ್ಷನೇ ಅಪ್ಲೈ ಮಾಡ್ಕೊಂಡು ಮಾಡ್ಬೇಕಿತ್ತು ಅಂತ. ಸೊ ಹಾಗಾಗಿ ಎಲ್ಲಾ ತರದ ಸಪೋರ್ಟ್ನ ನೀವು ಕೊಡ್ತಾ ಇರಿ ಸರ್. ಮತ್ತೆ ನಮ್ಮ ಎಲ್ಲರ ಸಿಬ್ಬಂದಿಗಳು ಮತ್ತೆ ನಮ್ಮ ರೇಡಿಯಾಲಜಿ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ಅವರ ಒಂದು ಪ್ರೋತ್ಸಾಹ ಜೊತೆಗೆ ನಾವು ನಮ್ಮ ಇಲಾಖೆಯನ್ನ ಮತ್ತೆ ನಮ್ಮ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ಕಾಲೇಜನ್ನ ನೀವು ಅನ್ಕೊಂಡಂಗೆ ಮಾಡ್ತೀವಿ ಸರ್. ಅದಕ್ಕೋಸ್ಕರ ತಮಗೂ ಮತ್ತೆ ಎಲ್ರಿಗೂ ಥ್ಯಾಂಕ್ ಯು ಫಾರ್ ದಟ್.
That education, like healthcare, is a universal right, and we are proud to witness the benevolent gesture from our medical fraternity.
I would now like to welcome our Dean and Director, Dr. Lokesh, sir, to speak a few words.
Dignitaries on the dais, Honorable MLA Dr.mantar sir, Madikeri constituency, dignitaries of the dais, delegates, senior doctors, PG students and my dear students. See, I have nothing but to talk. See, we have been conducting CME in our college almost every month. See, it is not enough. I request our HODs to reach out to state level office bearers to conduct the state level CMEs. I also request to those who are present, state level office bearers present here to give an opportunity to host state level CME in this beautiful place. Whatever possible support we will provide from our college, and our MLA sir and district administration will also support this. We have conducted only one South Zone CME in psychiatry for the last 9 years. Hope you will help me in arranging this state level conference. Thank you one and all.
On this auspicious occasion, we will now reconvene with our scientific session. Thank you everyone.
Dr.Muralidhar Kamalapur.
Dr. Abhilash, Dr.Ananda M,
Dr. Chandan K,
Dr.Abhilash Kumar,
Dr.Ravindra Munoli,
thank you everyone.
Thank you.
In cardiac four-chamber abnormalities, Dr. Rachitha Ramamurthy ma'am did her MBBS from Gowda Institute of Medical Sciences, Bangalore, her DMD from Raghav's Diagnostic and Research Center, Bangalore, and she is a consultant at Srinivasa Ultrasound Scanning Center, Bangalore. Her special interest is in fetal imaging and therapy. We cordially invite you, ma'am.
Okay, so we're going to see about the four-chamber view of the heart. Okay, we know that an echocardiography is not just a specialized test. We are going to study the heart in every fetus from the first trimester, mid-trimester, third trimester. And especially in the mid-trimester, our anomaly scan, TIFA scan, we are going to see the heart a little bit more in detail. And we need to know what are the basic views that we need to study in all the hearts. Okay? And the most basic view that we look at is the four-chamber view, which means it has four chambers. So why is an echocardiography necessary? Why should we even see the heart? Because we know cardiac anomalies, congenital heart defects are common. They are quite common, 8 per 1,000 live births. And it's not that these congenital heart defects happen only in high-risk pregnancies, only in maternal cases that have some diabetes or some other history. Lot of them, 80% of them actually happen in low-risk groups where you don't even expect any problem to happen. Incidentally, you find the anomaly when you scan in the mid-trimester. So that is why we need to screen the heart equally well in all women that are pregnant. Not preferentially see only the high-risk category better and assume that, this lady first pregnancy, she's 24 years old, no history of any problems, heart will be normal, we can leave it as that. You cannot skip like that. Coming to the high risk category, if there's any maternal, paternal, sibling history of CHDs, diabetes in the mother, infection, any drug use, fetal indications, any other abnormalities in the fetus, we will be more carefully looking at the heart. So coming to echocardiography, the basic 5 views that you take are the upper abdomen, 4-chamber, LVOT, RVOT, 3-vessel view, and other views you can add on. But in the 4-chamber view, we are going to basically start with looking at the heart as a whole. Even before you get into the heart, you look at the situs, the size, the axis, position of the heart, the squeeze of the heart like I showed you in the demo. And then you see the 4-chamber view landmarks. And then you also look at the heart as a pump. The rate, the rhythm of the heart, flow velocities, functional indices if it is required. And by looking at all the different views of the heart, you're going to go through the sequential segmental analysis, which basically evaluates the 6 connections of the heart, which are the veno-atrial, atrioventricular and the ventricular arterial connections. Coming to the views of the heart, ISWA guidelines tell us very clearly that 5 basic views are compulsory in all cases. Okay? And out of the 5 basic views, the 4-chamber view is a good basic view. So first, before we go into the 4-chamber view, you need to start with the upper abdomen. I've shown you the upper abdomen in the demo, which basically is a section just under the diaphragm, where after you determine the side of the fetus, and then you see for the situs, stomach to the left, liver to the right, umbilical vein turning into the portal vein, and the convexity is towards the stomach. From this upper abdomen view, you just move one step upwards, just cross the diaphragm into the chest to start getting the 4-chamber view of the heart. So the 4-chamber view is an axial view. It's a cephalad parallel shift from the upper abdomen view, and you get this kind of 4-chamber view. Now, the 4-chamber view is an axial view. It's the most important and basic view. It leads to other views, and it shows us 3 of the 6 connections in the heart. And in this view, you study the situs, size, axis, position, squeeze, the chamber size, the wall septal thickness, and you also can study it in other modes like P mode, N mode, color, spectral Doppler, etc. 90% of cardiac problems will show you some sign in the 4-chamber view itself. So that is why the 4-chamber view is extremely important, and if you know how a normal 4-chamber looks, any small abnormality going away from that you will automatically recognize, and you do a detailed study to pick up what is the problem. So coming to the documentation, you can document a still, you can document a clip as well, like I showed you in the demo earlier. You can also do the 4-chamber view in different views. You can do it from an apical approach, where the apex of the heart is pointing up. That is the best view, ideal view, where you see all 4 chambers well, you see the valves, atrioventricular valve movements well, you see the interventricular septum also fairly well. But you also have that dropout artifact in an apical view. So to rule out any defect in the interventricular septum, you can move to a lateral view where the probe is moved from the sternum of the fetus to one of the sides, where the insunation is through the ribs, between the ribs. So if you take a lateral view like this, you are going to get the interventricular septum horizontal. Whenever you want to see any structure, the best in ultrasound, make it horizontal to the beam. The beam will reflect off specularly from this horizontal structure. So this interventricular septum is very well seen in the horizontal plane lateral view. You can also see the valves a little better. And then the basal view is a view where you insunate from the base of the heart. That is the least used. We don't really need to study the heart in the basal view. It's not good to depend on the basal view for everything. Sometimes when we want to see the pulmonary veins better, we may use a basal view. So majority of the times, 99% of the times, you have to aim to get good apical 4-chamber views to see all the landmarks well. Don't finish a study purely on lateral. Do not ever study the heart only on basal view. So this is the maneuver to go from apical to lateral. Just move the probe to the side of the fetus to get a nice lateral view and see the septum well. Okay, is this normal or abnormal? 4-chamber view of the heart, 4 chambers are seen. Is it looking normal? Radiology PGs, students, answer. Otherwise I will just stop here only until you all answer. Yes or no, normal, abnormal? Can't hear anything.
See, I don't have any exam. I think it's abnormal.
Why is it abnormal?
It's like dilatation on that.
Okay, right ventricle is
smaller.
This is right ventricle, this is left ventricle.
The one ventricle is smaller.
Okay, that's because you're seeing the septa over here. Otherwise, the apex is extending till here. That is the valve. Huh?
The atrium is okay.
Atrium are okay. The 2 pulmonary veins are there.
Normal.
Normal.
Please play the clip.
Normal, abnormal. What is the abnormality?
Contractive.
No, it's a slowed down clip, Ashton. There's a huge hole right in the middle. The crux is absolutely absent. That is the importance of studying the heart as a real-time beating clip. If you study it as a still, you will call it normal. Once you start seeing it as a clip, you see that the crux is absolutely normal. So always document clips. Okay. So coming to the heart as a whole, we'll study the situs, size, squeeze, axis and position. I've already shown you how to look at the situs. You need to look at the stomach on the left side of the fetus. Ascertain the left first, and I've shown you how to do that by positioning yourself, imagining yourself in the fetal position. Once you know the stomach is on the left, go up to the cardia, make sure that the apex is also on the left, and that is called situs solatus. If you have the entire situs mirror image, that means apex on the right, stomach on the right, liver on the left, it is called situs inversus totalis. You will expect some certain cardiac anomalies in such cases, but the incidence is low. If there are any other abnormalities in the situs, if the heart is on the right, stomach is on the left, if the heart is in the middle, mesocardia, and the liver extends from side to side, any other derangement, it is called situs ambiguous, and in situs ambiguous is the highest proportion of cardiac anomalies that you will expect. Okay, this is an exercise for you all. This fetus is in cephalic presentation, head is down. Looking at this clip going from the head up to the rump of the fetus, can you all tell me which side of the fetus is where? Which side is nearest to the probe? Which is the near side?
Right side.
Picture yourself in the fetal position, head down.
Right side.
Spine is here.
Right side.
So what is close to the probe?
Right.
Stomach bubble is on top.
No, you do not determine the side based on where the stomach is. You determine the side based on your imagination as a fetus. So if you put your head down and lie down with the spine on this side, what side is near the probe? Right. And what is happening on the right side? Stomach. So if you just think, oh, stomach is there, that is left, you will lose out on a congenital heart defect in a situs ambiguous. The stomach in this case is on the right of the fetus, and where is the apex of the heart?
Left side.
Apex is
Left.
left. So what sort of situs is this? Stomach on right, apex on left? Situs ambiguous. This is where you will have major cardiac anomalies. You have to do a detailed study. So this was situs ambiguous, and that's the autopsy specimen of a situs ambiguous showing you a large liver extending from right to left, and both the lungs are showing you what?
Trilobe.
Trilobe. Both lungs are right lung morphology. That means it is a right atrial isomerism type of heterotaxy, and you will expect cardiac anomalies. So you're done with situs. Next you go to cardiac squeeze, and you see how well the heart is pumping. Are all chambers contracting and relaxing well? Look at that. If there's any problem with contractility like this, it's a very hypokinetic heart, there's hardly any squeeze happening, then you can think of a dilated cardiomyopathy or a hypertrophic cardiomyopathy, or in a case of cardiac failure where the heart is really failing. So you look at the cardiac squeeze, and then you come to the measurements, cardiac biometry. I'll go through only the main measurements. The cardiac shape, it is longer in the long axis, lesser in the side-to-side axis. So it's a triangular shaped heart normally. If it starts becoming circular, that means the global sphericity index is becoming less. That means the heart is actually trying to expand side to side. Can the heart expand front back? No, it has bony limits. It has a sternum in front, spine in the back. So it cannot expand front back. It can expand side to side because there are lungs on either side which are soft. Okay, so if the heart starts becoming round instead of triangular, you again start suspecting that there's some amount of cardiac failure setting in, and you need to look at the fetus carefully. In the opposite, when the heart becomes very narrow, when it's squeezed on either side by the lungs, it becomes like a tubular heart. There you suspect in a case of congenital high airway obstruction, where both the lungs are very tumescent, very large, and they're obstructing the heart, making it narrow. And you can also see the bronchopulmonary tree over here in a classic case of chaos. Coming to the axis of the heart, this is the tilt of the heart away from the midline. The apex points to the left. And if you draw a line across the interventricular septum and across the middle of the chest, the angle that these two lines make is called the axis. Normal is 45 degrees plus or minus 20. That means 25 to 65 is normal. If the apex is more deviated to the left, more than 65 degrees, you will call it a left axis rotation or a left axis deviation. If the axis is going towards the midline and the angle is less than 25 degrees, you will call it right axis rotation or right axis deviation. Those are the correct terminologies. Don't use any other terminologies. So this is an example, classic example of a left axis rotation where the apex is almost to the side, okay, it's almost to the mid-axillary line. If you measure it, it's almost 90 degrees, and any left axis rotation of the heart, you need to suspect outflow tract abnormalities. So in this case, as soon as I went to the outflow tracts, there's a malalignment VSD. That's the VSD with the aorta overriding, and it's a classic case of tetralogy of Fallot. So in the four-chamber view itself, if the axis is abnormal, you can expect the next views to be abnormal. So please notice the axis initially. Okay, this is a case where it is the opposite. It's a right axis rotation. That's the sternum, that's the spine. This is the long axis of the heart, interventricular septum. The apex is under the sternum. It's almost 0 degrees axis, right? So that's called a right axis rotation, also a mesocardia. There's a shift of the heart towards the midline. And if there is a right axis rotation, you will suspect inflow tract abnormalities. Anything happening wrong in the inflows of the heart, like pulmonary veins or the AV valves. And in this case, it turned out to be a partial anomalous pulmonary venous drainage. This is the abnormal vein, pulmonary vein. Instead of draining into the left atrium, it's forming a vertical vein going down into the abdomen and draining into the IVC, and that's a classic scimitar vein, scimitar syndrome. Again, you've diagnosed it purely because of the axis rotation in the heart. So you've gone and searched for that abnormal vessel and found it. So that's a partial anomalous pulmonary venous drainage. In this case, let's see the four-chamber view again. That's the sternum. That's the apex right under the sternum. So it's a right axis rotation. Anything else abnormal in this heart? I've marked the right and left for you. On the right side, you expect the chamber to be the right morphological right chamber, and it should have what morphological feature? Moderator band. Is the moderator band there? No. The moderator band is actually in the ventricle on the left side. So the morphological right ventricle is on the left. The morphological left ventricle is on the right. That means there is a there is a ventricular discordance, and with the ventricles the valves also move. The morphological right ventricle will always carry the tricuspid valve, which is a little bit more apically inserted, but it is receiving blood from which chamber? Which chamber is this? Closest to the spine is left atrium, and it is the left atrium because it is receiving the pulmonary veins. So the pulmonary venous drainage, which is rich in oxygenated blood, is going into the morphological right ventricle, and the morphological right ventricle is then giving rise to the aorta only. So the oxygenated blood is finally going into the systemic circulation, but through the right ventricle, and the deoxygenated blood from the right atrium is going into the morphological left ventricle, which is giving rise to the pulmonary artery. So even though there is no problem in hemodynamics, the ventricle is switched. So that is called a congenitally corrected transposition of great arteries. That means there is no problem in the hemodynamics, circulation is still maintained, but it's just that the morphology of the ventricles is switched, and it may cause a problem at 30 years, 40 years of the child's life when the right ventricle may start failing. It may not be strong enough to meet the systemic demand. Okay, so that's a congenital corrected transposition, again picked up in the four-chamber view itself. Then next, coming to the cardiac shift, the position, normally the heart occupies the middle 1/3 of the chest. The left lung is on the left 1/3, right lung is on the right 1/3. But if there is a shift of the entire heart, if you draw a midline, and if more than 1/3 of the heart is on the right, we will call it deviation, position shift to the right. If more than 2/3, if the entire heart is lying on the left, we call it shift to the left. This is how you do it. Draw the midline of the thorax and see how much of the heart is on which side. If there is more than just the right atrium onto the right side, there is something either pushing the heart from the left or pulling from the right. And you need to know what is pushing or what is pulling. So this is an example where the heart is completely pushed to the left side, completely pushed to the right side because of an absence of the right lung itself. The right lung is not even formed, so the entire heart is dragged to the right. So that's mediastinal shift to the right. And this is a case where there's a gross, what's this? Pleural effusion. Huge pleural effusion pushing the heart. There again is a right lung aplasia. You can have a CPAM, congenital pulmonary airway malformation, where the lung becomes very, very tumescent and it has a mass effect and pushes the lung. You can have a congenital heart defect that, a congenital diaphragmatic hernia that pushes the heart, and you can even have a bowel-only hernia. You can have a large lung cyst. So anything that is pushing or pulling the heart can cause a mediastinal shift. You need to know which side is the mediastinal shift and which is the side of the abnormality. The heart as a pump, of course, you can measure the heart rate on the 4-chamber view itself. You need to know that the rhythm is regular. You can measure the heart rate. Anything between 110 to 180 is normal in the mid-trimester. I always use M mode to measure the heart rate. You can also use Doppler, spectral Doppler if you want to measure it. Coming to the sequential segmental analysis, out of the 6 connections, 3 connections are seen in the 4-chamber view, and those are the right and left AV valves. The tricuspid valve on the right, the mitral valve on the left, 2 atrioventricular connections and 1 veno-atrial connection, the pulmonary veins draining into the left atrium. So these are the landmarks that you need to see, that the chamber closest to the spine, the left atrium is receiving the pulmonary veins, the morphological right ventricle with the moderator band is closest to the sternum, that is on the right, the morphological left ventricle forms the apex, and you see that the crux is complete. The entire interventricular septum from the inlet portion to the muscular portion, there is no gap, there is no VSD. The septum primum, interatrial septum is intact. The 2 AV valves are opening and closing, nicely opening and closing, and the offset septal valve of the tricuspid is closer to the apex. The septal valve of the mitral is closer to the base. So this step that you can see is the AV offset. That's extremely important to document and show that it is normal. All the 4 chambers are equal in size. Right atrium equals left atrium, right ventricle equals left ventricle in the mid-trimester. The myocardium is normal, pumping action is normal. Flap of foramen ovale is bulging into the left atrium. Those are all the landmarks that you see on a normal 4-chamber view. And this is the list given to you in the SWOT guidelines. You can take a picture, read up on the free guidelines and make sure that you are checking that all of these landmarks are met. I know it's a long list and it's like, oh my god, every time I see a 4-chamber, I have to go, okay, this is there, this is there, this is there, this is there. No, it's not like such a tedious process. As soon as you see a clip like this, as you keep practicing, even without consciously listing out each feature, automatically you will recognize if there's any deviation from these normal features. So you just need to practice in the beginning to see all of these landmarks, and as you see your 10th heart or your 20th or 30th heart, you will, even without going through each one on the list, you will recognize any abnormality. So I've shown you some thumb rules. Let's see a few abnormals and then we'll close. Okay. What is the use of color Doppler? I've already shown you on the demo. You should do a color Doppler study in every view. 2 parallel inflows should be seen. And if you want to see pulmonary veins well, you can put on the power Doppler, use a basal view and see that the pulmonary veins are nicely draining into the left atrium. But as long as you see the pulmonary veins in a normal 4-chamber view, if you're seeing 2 inferior pulmonary veins draining into the left atrium, that's enough. You don't need to show all 4 pulmonary veins normally. Let's look at this clip now. Are the pulmonary veins normal? Are they draining into this chamber? Yes? No? It looks like they are draining into the left atrium. But can you see the amount of distance behind the heart? That's the spine, this is the heart. Normally, this is the spine, this is the base of the heart. you have the descending aorta, and that's all. That's just a little amount of space between the aorta and the heart. You can maximum fit another aorta in this gap. Look at in this heart. Can you see the amount of distance from the spine to the heart? That means the area behind the heart is very, very wide. This happens when there is a total anomalous pulmonary venous drainage. When the pulmonary veins are not actually going and joining the left atrium, there's nothing to tether the heart back. The heart moves forward and the lung tries to get into this gap behind the heart. So here, even though it is actually looking like the veins are joining the left atrium, they're actually joining each other and forming a horizontal vein. And if I take you to a little lateral view, now are you seeing the veins draining into the left atrium or not? Are they joining? Are they going into the left atrium? No, they're joining and forming a horizontal vein, and that is abnormal. And this horizontal vein is giving rise to a vertical vein. That vertical vein is seen on the side of the pulmonary artery in the 3-vessel view. And if you trace the vertical vein up, it takes blood away from the heart and it goes and drains right into the right SVC, into the neck of the fetus, and that is the entire blood flow of the vertical vein away from the heart going into the SVC. So this is a diagnosis of supracardiac type of TAPVC, total anomalous pulmonary venous drainage. That again you have to pick up in the 4-chamber view itself, where you are not seeing the pulmonary veins draining into the left atrium. Let's look at this example now. This is a 4-chamber view. Anything that is looking abnormal? What is this? That is something happening in the right atrium. There's some band. So can it be a cor triatriatum or something? That doesn't happen on the right, in fact. That's a left diagnosis. This actually, if you turn vertical, you see that it is a prominent eustachian valve. Prominent eustachian valve of the IVC normally can look like this on an axial view. Please don't mistake it for an abnormality. That's another pitfall that I wanted to bring to you. Now the next landmark that you will see is the crux. The crux, I've told you, has to have the offset. You should have the septum primum, interventricular septum with the septum inlet septum, the 2 AV valves. This offset is extremely important, and if there's any abnormality in the offset, if the entire crux is missing, you will diagnose an AVSD. In this case, the septum primum has a gap. So is it a primum atrial septal defect? But look at the rest of the heart well. The rest of the heart, you actually see that there is some sort of a bleb on the left side of the heart, and if you come up through the 3-vessel view, there is an extra vessel. In the 3-vessel view, you should have only 3 vessels. There should be nothing onto the left of the MPA, but there is an extra vessel here. The right SVC is actually absent. So this is a persistent left SVC going and draining into the coronary sinus, and actually on the 4-chamber view, what you saw is just a prominent coronary sinus, and it is not a primum ASD. So that's another pitfall that you will see normally. I'm stressing on these normal findings because you should not call them abnormal, and if you call it abnormal, that fetus will go in for a termination. So please know what is normal, what are the pitfalls. This is just a prominent coronary sinus mimicking a primum ASD, and it is actually not an abnormality, and you can call it as normal. If there's any size discrepancy, if the right atrium is larger than the left atrium, or the right ventricle is larger than the left ventricle is smaller, then you can suspect some inflow tract abnormalities. In this case, if you look at this case very subtly, the right-sided chambers are larger than the left-sided chambers. That's normal comparison. In this case, right is looking larger than the left. And look at the crux. Is the crux normal? Is the offset there? This is the tricuspid valve. Tricuspid valve is more apically inserted. Mitral is more basal, correct. But do you expect such a large step between the two valves? No, it is just a 1-2 millimeter step normally. But here it is a very exaggerated offset. That is a condition called Epstein's anomaly, where the septal leaflet of the tricuspid valve is more apically inserted than normal, and that valve will not function well. If you put on the color, there is a regurgitant jet because that valve is loose. It's not tightly closing the chambers in ventricular systole, so you have a jet coming back into the right atrium, and that is why the right atrium is getting enlarged in size. So that's a classic Epstein's anomaly. So this is the last stage of an Epstein's anomaly in the third trimester, where you see the valve very close to the apex, and because of massive regurgitation, there's a huge right atrium. The right atrium balloons, dilated very massively, and that's a classic Epstein's anomaly in the third trimester. Coming to other abnormalities of the crux, that's normal. This is where the entire crux is absent. Instead of two separate AV valves, you're seeing one common AV valve, and it's opening and closing in the middle of the heart. There's a septum primum defect, and there is an inlet ventricular septal defect. And putting all of these together, it's a complete balanced atrioventricular septal defect. The endocardial cushion is missing, it's deficit. So that is only one single atrioventricular valve instead of two, and that's a major cardiac anomaly. And that again is a 4-chamber view diagnosis. The CCTGA I've already shown you, I won't go through this again. Coming to the last few case examples, this is another example of chamber disproportion, where that's the sternum. The chamber right behind the sternum is right. This is left ventricle. Anything abnormal that you're seeing here? As soon as you see, there's a gross size discrepancy. Which is the side that is abnormal? Right chamber. The right ventricle is very small compared to the left. So you will expect an abnormality on the right. Where can the right chamber be very small? Where it is not receiving any blood at all from the right atrium. Means tricuspid atresia. So you see that this tricuspid valve is not opening and closing normally like the mitral valve. It is a thick horizontal band, and if you put on color, you're seeing a nice inflow through the mitral valve. But is anything crossing the mitral valve? The tricuspid valve? Is any blood flow going across? No. That is a tricuspid atresia. And all tricuspid atresias always will have a VSD, ventricular septal defect. They are obligatory VSDs because the blood has to go into the right ventricle from the left ventricle and then get into the pulmonary circulation. So that is a classic tricuspid atresia with VSD, again picked up on the 4-chamber view itself. Look at this clip now. Again, a problem with size. Which ventricle is problematic here? Yes, that's the sternum. Right ventricle is normal. Other one is very small. The left ventricle is extremely small. And is it contracting well? Is it becoming smaller and bigger like the right ventricle? No, it is fixed. It's like one fixed ball going up and down instead of contracting and relaxing. And then if you put on the color, the flow across the tricuspid valve is very good. But is there anything flowing across the mitral valve? No, there's no flow across the mitral valve. And if there is no VSD also, you cannot have forward flow in the aorta. So then you go up to your 3-vessel view. That's your 3-vessel view. And you will classically expect reversed flow in the aorta. That's the MPA, main pulmonary artery and ductus, giving you forward flow in blue. But this should have also been in blue. It's in red. That means the blood flow to the aorta is not coming from the left ventricle. It is coming through the ductus, reversed into the aorta. That's called reversed ductus dependent fill on the aorta of the aorta. And if you see this combination, the classic diagnosis is head shell, head chest, hypoplastic left heart syndrome. Clear? These are abnormalities that are very common. All of us in our lifetimes will see a hypoplastic left heart syndrome. Most of us will see an AVSD, tricuspid atresia with VSD. So these common abnormalities you should not miss in your 4-chamber view examination. Just by seeing the chamber sizes and the crux, you should be able to pick it up. This is a case where you see the normal versus abnormal. Can anybody pick up anything wrong happening in the right-sided clip? Is there any different from the normal in this clip? Exactly. Look at the two AV valves. Tricuspid valve, compare it to the mitral valve. Is the tricuspid valve opening and closing as nicely as the mitral? No. And what is happening to the crux? In a normal heart, the interventricular septum is relatively stable. It doesn't move back and forth. The two chambers on either side of the interventricular septum contract and relax. If the contraction and relaxation on either side is equal, the center will not move. The pressures on both sides are equal. But compare it with this. Can you see how much that septum is moving back and forth? It's almost like a windshield wiper, going back, forth, back, forth. That is because the contractility on the right side is less, contractility on the left side is more. The left is pumping nicely, strongly, the right is not pumping very well. So this interventricular septum is going, dragging back and forth, back and forth. There is a problem on the left side, on the right side. The tricuspid valve also is not opening very well, and you have to suspect pulmonary atresia with intact ventricular septum in this case. If you go up to the four-chamber view in this case, you will have opposite. You will have reversed fill in the main pulmonary artery and forward fill in the aorta, telling you that it is a pulmonary atresia with the intact ventricular septum. You must also always look at the contractility in the end. Here you see a very bradycardiac heart. It's very slowly pumping. Contractility is very slow, less contractility. And if you take an M mode across the four chambers, if you draw a line like this, crossing the atrium and the ventricle, you see that the atrial beats are normal in rate, 150. Ventricular beats are only half the rate, 85. So when the atria are beating normally and the ventricle are beating in half the rate, what is your diagnosis? What is the diagnosis? Heart block, congenital heart block. That means the atria are contracting normally, the impulses are correct for the atria, but half the impulses are not reaching the ventricle. There is some problem in the AV node, atrioventricular node. And if you look at the four-chamber view again, this is where the atrioventricular node is. And can you see one white dot over there? That is calcification of the atrioventricular node. So if the atrioventricular node is calcified, it cannot conduct impulses well, and this happens in cases of maternal autoimmune diseases. If the mother is SLE positive, if she has anti-RNA, anti-LA and anti-SSP antibodies, this calcification in the fetus happens and you get a classic heart block. And that again you pick up in the four-chamber view. Lastly, if you have a heart like this in the third trimester, where the right-sided chambers are looking large, left-sided chambers are looking small, don't worry. In the third trimester, normal right heart dominance is known, and even if you measure and take it across the nomograms, you will see that normally as gestation progresses, the right ventricular size goes on increasing compared to the left ventricular size. That is because the pulmonary circulation is still not open, so this right heart dominance is normal. And lastly, also look at the surrounding of the heart. Is there any fluid around the heart? If you see a thin layer of fluid like this going up to the AV valve level, it is normal. Don't call this pericardial effusion. That's normal, okay? If you measure it, it's just less than 2 to 3 millimeters, it is normal. But if you see fluid going all around the heart, up to the base of the heart, much more than 2 to 3 millimeters, crossing the level of AV valves, that is pericardial effusion. And you can have mild effusion like this or very gross effusion like this, where the entire heart is floating, and then you will also have to suspect cardiac anomalies and also systemic abnormalities and look at the cardia in detail. The last is this example where you have a dot in the heart, a white dot in the heart, in the left chamber most commonly. 99% of the routine cases that we see, you will always see one small dot or the other. Especially in our country, half the fetuses will have an echogenic focus. That is just a small calcium speck in the chorda tendineae of the left ventricle. It causes absolutely no problem. It is just a weak marker of Down syndrome. You do some other test for Down syndrome, like a double marker, you see if she's got it done, or a quadruple marker, or an NIPT. Look for all other markers of Down syndrome. If all of the rest of the heart is normal and the rest of the fetus is normal, you don't need to bother about it at all. Just mention it in the report as an echogenic focus. Reassure the couple that this is not a hole. If you say heart alli chukke ide, they'll go tell their entire family heart and hole idiyante, heart and hole idiyante, and next day they'll go and terminate. Don't do that. Explain to them that it is just a white dot, it is not going to cause any problems and you're not worried about it, and ask her to continue as normal. So, in conclusion, the four-chamber view of the heart is a basic view of echocardiography. 60% of CHDs are picked up on the four-chamber view itself. Remember to study the heart as a whole. That means the situs, side, position, axis, etc. Look at it as a pump, look at the contractility, and then look inside the heart for the four-chamber view features, the landmarks. Also look at area behind the heart. Document the heart in both grayscale and color Doppler, stills and real time, and then move on to the rest of the basic heart views to complete your echocardiography. And also remember, you should do a detailed anomaly scan, and putting together all your findings, you can ask for further investigations and counsel accordingly. Thank you very, very much for your
Is on dating of pregnancy by Dr. Ravi Badagandi. Sir is a consultant radiologist at Ravi Scan and Diagnostic Center, Mudur. He is also a co-director in Karnataka Institute of Fetal Sciences. Sir did his MBBS in Sri B.M. Patil Medical College, Vijaypur, his DMRD in MS Ramaiah Medical College, Bangalore, and DNB in Sri Sathya Sai Institute of Higher Medical Sciences, Whitefield, Bangalore. We cordially invite you, sir.
Like the pregnancy scans, it's dating scan. So this is the most fundamental and most important thing to know, because all the journey of the pregnancy depends on how you date the pregnancy. So just before going through this, see this report. So they have mentioned mean sac diameter as 53 mm, CRL as 38 mm, and in the impression they have mentioned single live, and they have mentioned NT 2.8 mm and appears prominent in the present scan. So this is the importance why you should know the guidelines and why you have to stick to the guidelines. So this will give a wrong report and unnecessarily causing anxious to the mother. So dating is not just like documenting the heart rate and telling it as a viable. So it is gone beyond that confirmation. So there are many questions we need to see, we need to answer. Where is the pregnancy? How many embryos are there? What is gestational age? Is pregnancy normal? And we have to document about the surrounding context. In most of the time, it is very easy to see the gestational sac, the embryo, and sometimes it may be very hard. Then we have to look, literally hunt for the gestational sac, whether it is intrauterine or extrauterine. So always do the TVS scan to document the location of the gestational sac. So primary goals are to locate, to assess the viability, to assess gestational age, and to look for the number. So beyond that also, any vaginal bleeding, pelvic pain, and suspect pelvic mass also can help in like dating of the pregnancy. So I know the Monday morning all will be very busy doing the scans. If the primary goal of the scan or dating scan is only to document the fetal heart and to measure the embryo, we can pass this as a normal one. I can see nice embryo, placenta there, I can see the fetus is moving. I just measure it, the heart rate, I measure the CRL, and just I pass it as a normal. But what's happening? Can someone comment? Actually, we should also look for we should get the detailed history, because this is previous two sections. This is the early pregnancy where already it is located in the lower uterine segment. You can see the placenta accreta spectrum in the first trimester itself. So always look, ask for the history, locate where exactly it is located. Now, this was a case like doctor called me and told like, doctor, I could see multiple gestational sacs, so I am not able to see what's going on. Please see the case. So when patient was referred to me, I could see multiple cystic areas, not only in the endometrium, even in the subendometrium, extending beyond that, even in the myometrium. So you should know these things, because you may pass it as like multiple pregnancy. So this is actually a case of invasive molar pregnancy. So whenever you are dealing in the first trimester ultrasound, we need to have the structured approach, and you should have the knowledge of the key development landmarks. Obviously, a transvaginal scan should be offered to all the pregnant ladies because it has a superior resolution. We can detect many more early anomalies and we can have the detailed assessment. So we use two basic terminologies here, the embryonic period and the fetal period. So up till 10 weeks we can use the word embryo, after 10 weeks we use the word fetus. And two ages, the menstrual age and the fetal age. The first day of the LMP we take it as a menstrual age, that is most commonly used. The fetal age begins at the time of conception. So why dating is important? Is it just the assessment of gestational age giving the EDD? Even if you don't know like detailed examination of fetal age as Rachitha madam showed, but you should know how to date the pregnancy, because any person having the ultrasound machine will get the chance to do the dating of the pregnancy. You should assign it, you should know what to tell and what not to include in the report. So there are three ways, one is by LMP, another is by ultrasound, and third is by the combination of both LMP and the ultrasound. So we use the menstrual age, that is the first day of the last menstrual period, and we add 2 weeks for the date of the conception to get the gestational age. But in case of IVF pregnancy, we will be knowing exactly when the conception is happening. So that is more accurate than the ultrasound. You can consider LMP for the estimated gestational age, provided if you have very certainty of the date, if you have regular cycles, and there is no hormonal contraception or breastfeeding last 2 months. So most of the time, the woman consumes the 2 weeks later, normal 28-day cycle, where we can consider gestational age as a menstrual age. But if cycles are long or short, the gestational age may not be equal to the menstrual age, because the LMP has got its own inherent errors. Because if they don't exactly recall their LMP, or if they have the irregular cycle length. So always it's important to take the good history, so all assumptions are based on the regularity of the cycle. So always expect variation, because we are asking the LMP and we are assigning the gestational age by seeing the landmarks on the ultrasound. But in between that LMP and the appearance of the embryo, there are various steps involved. First there will be ovulation, fertilization, implantation, and followed by the growth. So in all the stages they have the variations. So expect the variations. It is quite common. Is LMP easy to recall? How many actually females remember correctly their LMP? Or education status, maintain records in the previous cycles affect the recall? Or is there any preferential bias? So this was a study conducted where 385 women participated in the study. According to the summaries, the more than 50% of the people, female, they don't actually recall their LMP. And they have the preferential bias like 1st of the month, 15th of the month, like that. And surprisingly, there is no impact on the education status, age, or the maintaining records of the LMP. So why you should need to know for the accurate dating? You want to order something, you want to interpret, you want to tell this is the normal growing, this is FGR, you need to know the dating of the scan. So what are the guidelines? In the first trimester, up to 13 weeks, 6 days, before embryo is visible, we will see the landmark gestational age, yolk sac. So these are indirect markers. But once the embryo appears, CR is the best parameter to determine the gestational age. So this is the direct method and it is more accurate. We need to know the early development landmarks, that is gestational sac followed by the yolk sac, then we see the embryo. So before that we have many challenges, like you can see this section where the tiny sac-like structure is seen eccentric located within the endometrium. We call this as intradistal sac sign. But most of the pregnancy can happen without this sign. If you see any non-specific intrauterine fluid collection in the endometrium, if the adnexs and ovaries are normal, the probability of being in the gestational sac is more than 99%, provided the ovaries and adnexs are normal. So one thing is you need to look at the location, if it is eccentric located, and then you need to look for the margins. If the margins are angulated and if it is center located, it could be more of just a fluid collection rather than the gestational sac. So what are the landmarks you see according to gestational age? First we see thickened endometrium, followed by the gestational sac, then cardiac activity, we measure the CRL, then appearance of the lymph buds, then physiological gut herniation, then we see the fully formed fetus. So we see gestational sac, the eosac, the appearance of the embryo, and we document the cardiac activity with the M mode. So how to measure CRL? First we get the magnified view. You should get the true mid-sagittal neutral position. How can I say I am in the midline? With the true midline neutral position. You can see for the genital tubercle. So that indicates we are in the midline straight line. Then measure from the top of the cranium to the rump. You can take 3 measurements and get the mean of it. This is diamond ring sign where the yolk sac is in close approximity with the embryo. So we can see the first image. This is around 6 weeks. The second image is 8 weeks. But in the 6 weeks, very difficult to see the top and the crown and the rump ends of the fetus. So it's maybe very difficult to assign at this period. So we need to wait for little more weeks, where 8 weeks it is very easy to measure the embryo. Does that mean that if I wait more, is it very easy to measure? Actually no, because once the curvature of the embryo starts, the measurements may be inaccurate. That's why it's best to assess the gestation age by the CRL after 7 weeks, between the 7 to 9 weeks. Once the curvature starts, the measurements may not be that accurate. So what are the checklist? We need to look for the mode of conception. We should validate the LMP. We should audit the image where it is correctly measured. Then to calculate the difference between the LMP and the gestation age. So first, feed the LMP in the machine, measure the CRL by following the guidelines, then find the difference between the 2 ages, then compare, depending upon the guidelines, the cutoff values, either you assign or reassign the LMP. So this is a summary where between the 6 to 9 weeks, the embryonic posture doesn't significantly affect the CRL measurement. That's why this is best time to measure it. So how to reassign? According to guidelines given by the ACOG, SMFM and AIAM, in the first early pregnancy, if it is more than 5 days, then you have to take it as ultrasound. So till 14 weeks, it is 7 days. So as the gestation age advances, the accuracy decreases. So go through this report. So they have given the CRL and they have mentioned the GST. And the impression, single eye intrauterine pregnancy, corresponding to gestation age of 9 weeks 0 days. When you have the direct measurement of CRL, no need to consider the indirect measures. So the correct way to report is you have to assign according to the CRL. See this report. They have mentioned the mean gestational sac diameter. According to LMP, she is around 7 weeks 3 days. According to MSD, she is around 6 weeks 2 days. They have assigned 6 weeks 2 days with irregular sac walls. So what you will do next? So can you redate this based on the mean sac diameter? No, because it is an indirect method. You have to wait for the CRL to appear. So see this one. CRL 7 weeks 5 days, gestational sac 7 weeks 2 days, and they have given it as a mean age by the ultrasound. So they have given the 7 weeks 5 days and 7 weeks 2 days, they have given the mean. So is it the correct way to report? So is dating using the mean or the combined or the average ultrasound, is it accurate? Again it is no, because MSD is an inaccurate. So when the CRL is available, to take into the consideration of the direct measurement rather than the mean sac diameter or the average ultrasound age. So how to correct this one report? So the difference is after 6 days, so I add 6 days to the LMP, so I reassign it. So this is the correct way of the reporting. So in most of the machines, if you go through while entering the patient data, always check for this one. Because here, both the GS and CRL are checked one. So that's why the machine is giving the average one. So the correct way, just uncheck this GS when the CRL is available. So So this is one case where 29-year-old with irregular periods, UPT +2, and she had D&C done for the miscarriage. She came me around 11th of July. According to her date, she was 6 weeks 4 days. But the sac was corresponding to less than 5 weeks. What will first I will do is I will just confirm whether it is intrauterine or the extrauterine by doing like 3D or the 40. So then she came for the follow-up scan. Now the embryo is corresponding to 8 weeks 2 days. So how will you do this in this case? So always reassign the LMP based on the present scan because I am seeing the direct measurement of the embryo. So LMP is reassigned only when you see the CRL. So what is the Godel rule? The Godel rule is gestation age should be confirmed or reassigned when the data from the LMP and the accurate first trimester ultrasounds are available. So once you assign it, you should not change it. So what will, if the mother is coming direct in the second trimester? It is less reliable than the first trimester because the accuracy decreases. So what parameters we use? Second trimester is the composite of both BPD, SC, AC and the FL. But the SC and the corrected BPD is more reliable. In second trimester, if the difference is less than 7 days, we consider the LMP. If the difference is more than 7 days, again the ultrasound has to be considered. If it is beyond at the 22 weeks to 28 weeks, if the difference is less than 14 days, then LMP is considered. If it is more than 2 weeks, again the ultrasound needed has to be used. So what, like in the peripheral setup, like where I practice, is very common to do is a pregnant woman coming for the first time in the third trimester. It is least reliable. So it is the danger of always redating a small growth into restricted fetus. So guidelines say if the discrepancy is more than 21 days, you can reassign it. Then you should write in your report suboptimally dated pregnancy. So this is the American ACOG guideline has given for the management of the suboptimally dated pregnancies. So you should, when you do the scan, again call her after 3 to 4 weeks for the appropriate growth. So what is the golden rule second and third trimester? The gestation never adjusted in a subsequent scan if it is already done in the prior scan. Rather, it should be used to assess if the fetus is growing appropriately or not. As far as possible, don't confirm dating and gestation age in the second and the third trimester. So how we would do in the twins? If it is spontaneously conceived, we use the larger CRL, although there are controversies, but present the guideline says you have to use the larger CRL. If it is IVF pregnancy, we will be considering the conception age, depending upon the embryo transfer date. So if it is the third day one, we minus the embryo transfer date minus 3 days. If it is the fifth day embryo transfer date is done, we will minus for 5 days. So in day 3 embryo, EDD will be embryo transfer date plus 263 days. For day 5 embryo, it is plus 261 days. So in conclusion, before you can ask the lady if it is the IVF for the natural gestation. You use the CRL to confirm it or to reassign it. Then once the dating is confirmed, it is never changed. Then you should put all the efforts to tell your patient to bring all the previous scan reports so that this actually at the end it will be rewarding. And CRL is the most reliable measurement for gestational age. It's a direct measurement. So this is the criteria where you can reassign the dates. So this is the latest guidelines given by 224, consistent by conference like Ultrasound Society of Radiologists, like what terminals use and what not to use. You can go through this article just to show the summary slide. So what are terms to avoid? Avoid term using the embryonic pole, fetal pole, heartbeat, heart flicker, living, viability scan. So all the terms have been changed. So what are the correct way to use? Use embryo less than 10 weeks, fetus more than 10 weeks. Cardiac activity present or absent. You have to use first time ultrasound or rather than the viability scan. Don't use the failure pregnancy or blighted ovum. Use early pregnancy loss or anembryonic pregnancy. So what are the poor prognostic markers? If you see the calcified plaques, the calcified yolk sac, expanded amnion, irregular margins. So these are the poor prognostic markers. So what are the guidelines to say pregnancy failure? So these are the latest guidelines criteria given. If you see the CRL more than 7 mm and if you see MSD more than 25 mm with no cardiac activity, it is definitive diagnostic of early pregnancy loss. For this example, so CRL more than 7 mm, no heartbeat, this is very diagnostic. If it is less than 7 mm, what you have to do? If you don't see the cardiac activity, always call her back after 1 week. Because the differentiation of the viable and the non-viable is based on the CRL of 7 mm. You can see this chart. That's why 7 mm is must. Same with the MSD, if you see more than 25 mm without embryo, we can call it as a diagnostic of pregnancy loss. If it is less than that, again you have to call her after 1 week. If you don't see, then it is a diagnostic of failed pregnancy. So will 3D help? Definitely it is going to help, because in 3D we can appreciate the thick anti, this is the proboscis, this is the cleft lip and the palate, then these are the short and stubbed hands. So one, like the most confusing one is the chorionic bump, where you can see the focal area of convexity that is protruding into the gestational sac. You may get confused with this embryo, but actually this will be seen separately from the embryo. So don't get confused. You need to know about this chorionic bump. You need to have the normal anatomy and development stages to say this is normal or abnormal. Always use the correct terminology, and same you have to communicate with the deferring doctor or with the patient. So first, do not harm. If in doubt regarding the viability, always wait and see. So dating of the pregnancy is essential. Never reassign the EDD if it is one-time event. You need to have the knowledge of the developmental anatomy, variations and appropriate terminology is very much crucial. Relevant clinical history, image optimization and following the appropriate protocols and guidelines is must. Not harm, wait and watch. Accuracy dating is not just optional, it is a responsibility. Thank you.
Hospete, Vijayanagar district, Dr. Pratiksha Ma'am has completed a MD Radiodiagnosis at KS Hegde Medical Academy, Mangalore, and her fellowship in fetal imaging and fetal medicine. We welcome you, ma'am.
A very good afternoon, everyone. Today I'll be discussing about the cardiac anatomy. This is because the fetal cardia is very small in size and it is continuously moving at the pace of 120 to 160 beats per minute. So, by knowing the cardiac anatomy in detail, you can simplify the diagnosis of cardiac anomalies. To begin with embryology. When the embryogenic disc is formed, it has three main germ cell layers, that is the ectoderm, endoderm and the mesoderm. From the lateral compartment of the mesoderm, we have the circulatory system. So, from the lateral compartment, we have angiogenic precursor cells that give rise to the pair of cardiogenic field cells. So, these cardiogenic fields come in the midline and fuse to form something called as primitive heart tube. Later, the newly crest cells migrate into the heart tube and form the conducting system. Okay, here we can see in the image we have a pair of cardiogenic field cells fusing in the midline to form a primitive heart tube, which has a venous end and an arterial end. So this is how a normal primitive heart tube would look like. Primitive heart tube would look like, which has an arterial end and a venous end. At the venous end, we have sinus venosus, primitive atrium, primitive ventricle, bulbus cordis and truncus arteriosus. So we have two main important folds in the primitive heart tube. First being the atrioventricular canal that separates the future atrium and the future ventricle and forms the atrioventricular walls. Next we have a primary fold. It separates the primary ventricle, the primitive ventricle and the great vessels, and it also separates the two future ventricles. So it forms the interventricular septum. And this primitive heart tube undergoes de-looping in anti-clockwise direction to form a fetal heart. So according to updated ISO guidelines 2023, the fetal cardiac screening has to be performed ideally between 18 to 22 weeks of gestation. However, some major cardiac anomalies can be identified in early second trimester. Suppose you are doing an NT scan and you witness increased nuclear translucency. And this increased NT and other enumerated markers will warrant a early detailed cardiac assessment either in late first trimester or early second trimester. So according to ISO guidelines, what we have to do is just we have to take a transverse sweep from the abdomen with cephalad movement of the transducer. By doing this, we will be getting multiple important planes. First being the fetal situs weave, the fourth chamber weave, the left ventricular outlet tract, the RVOT weave, 3-vessel weave and 3-vessel trachea weave. See, we are seeing so many planes here and so many important structures in each plane. So we can simplify it even more by following something known as sequential segmental approach. So what we do here is we divide the whole cardiac into 3 main segments: the atria, the ventricles and the arterial trunks. So again, each of the component is divided into right and left sided component. So for each segment we look for the anatomy, we look for position and we look for the connection with the next segment. And we should not forget the venous connections. In venous connections we have systemic venous connections and pulmonary venous connections. In systemic venous connections we have the IVC and SVC. In pulmonary veins we have 4 pulmonary veins draining into the left atrium. So let us begin each of it. So in this we'll begin with the fetal abdominal situs. Then we look for the atrial arrangements. When I mean the atrial arrangements, we look for the morphological right and left atria. And then we look for the atrioventricular connections. Here I mean the atrioventricular valves, the mitral as well as tricuspid valves. Next we have the ventricular arrangement. So here we label the morphological left as well as morphological right ventricles. Next we have the ventricular arterial connections. So we have semilunar valves here, followed by arterial trunk arrangement. So we look for the orientation, crisscrossing of the great vessels and the orientations of vessels. Next and last is the venous connections. So the first and important step when we start doing the cardiac assessment is the fetal situs. Situs is nothing but the arrangement of organs inside the body. Situs solidus describes the normal anatomical arrangements of the fetal organs in thorax as well as abdomen. This is the first step of evaluating the fetus, because some of the major cardiac anomalies are associated with abnormal positioning of organs in thorax as well as abdomen, like heterotaxy. If at all we focus on only the fetal cardiac without including the fetal abdomen, then we are doing the incomplete diagnosis. This is how a normal abdominal situs would look like, with stomach to the left side and aorta anterior into the left of spine, IVC anterior into the right of spine. Not only this, we should also look for the orientation of the umbilical vein and direction of the portal sinus. Also we have to make sure we look for the location and presence of gallbladder as well as spleen. So this is a grayscale image showing the stomach on left side, aorta on the left and anterior to the spine, IVC on the right side and the portal sinus location to the right side. Now coming to steps to determine the fetal situs. First what we do here is to locate the head of the fetus in the uterus and determine the presenting part. In presenting part, we look whether the baby is in cephalic position or in breech position. Next, what we do is we look for the lie of the fetus in the uterus. Either it is in longitudinal lie when the fetal spine is parallel to the maternal spine, and it is transverse when it is perpendicular to the maternal spine, and it oblique when it is oblique to the maternal spine. Then we locate the lie of the fetus. Then we have to locate the maternal fetal right and left sidedness in relation to the maternal abdomen. For example, if you take the first image, here we can see the baby is in cephalic presentation in longitudinal line, and the baby's spine is towards the maternal left side. Then the right side of the fetus is near the anterior abdominal wall. So the stomach bubble and the cardia are on the left side. So this is situs solidus. So in the second image, we can see the baby is in cephalic presentation in longitudinal line, and the spine of the fetus is towards the maternal right side. It means the baby's left side of the is towards the anterior abdominal wall of the mother. Subsequently, if you see the third and fourth images, the baby is in breech presentation with longitudinal line. Based on the position, we can determine the situs of the fetus. The best way of doing it is, imagine yourself as a baby in the uterus. Okay, this is how a normal fetal abdominal situs and thoracic situs would look like. Stomach and majority of the heart on the left side, IVC on the right side, aorta anterior and to the left of spine. Now coming to the cardiac position, when we see the cardia is in the cardia in the thorax, the cardia occupies the middle mediastinum between both the lungs. 2/3 of the cardia occupying the left side, including the apex, and 1/3 of the cardia on the right side, including the base. So this normal position of the cardia towards the left side is known as levocardia. If it is other way around, then it is dextrocardia. If there is no sidedness and the cardia is in the center, then it is mesocardia. At times you have a very rare entity where the cardia is outside the thorax, then it is ectopia cordis. This is a pictorial demonstration of levocardia, dextrocardia and mesocardia. Now coming to the cardiac axis, how do you measure cardiac axis is, you have to take a transverse view of chest at the level of 4-chamber weave. Then we draw an imaginary line from the sternum anteriorly and to the spine posteriorly, and then we have to draw another line along the interventricular septum. So the angle which is formed between these two is the cardiac axis, which is normally 45 degrees plus or minus 20 degrees. And the cardiac axis does not change with advancing gestational age. So you can see 3 fetuses of 12 weeks, 16 weeks and 21 weeks of gestation, showing a normal cardiac axis of about around 45 degrees. Next, moving on to the basic planes. In basic planes, we have 4-chamber weave, the LVOT weave, the RVOT weave, the 3-vessel weave and 3-vessel trachea weave. And coming to the extended planes, we have ductus arch weave, aortic arch weave and bicaval weave. To begin with 4-chamber weave, this is one of the most important weave in fetal cardiac examination because this is very easy to obtain in all the fetal positions, and this represents the starting plane for basic as well as detailed fetal cardiography examination. This is our normal 4-chamber weave would look like, with 2 symmetrical ventricles separated by the interventricular septum, 2 atria separated by the intra-atrial septum, and 2 inferior pulmonary veins draining into the left atrium. Now coming to the orientation, based on the position and lie of the fetus inside the uterus, we have 4 normal types of 4-chamber weaves. First being the apical, which is most commonly used, and next is basal, and then we have the right and left lateral or axial weaves. This is the apical 4-chamber weave. Here we can see the spine of the fetus is towards the posterior wall of the uterus, or we can say the anterior wall of the chest is towards the ultrasound beam. So the ultrasound beam first insinuates the apex of heart and is parallel to the interventricular septum. So you can appreciate the ventricles, the ventricular dimensions, the atrioventricular walls better in the apical 4-chamber weave. Next we have the basal 4-chamber weave. Here we have the spine of the fetus towards the ultrasound beam, near the ultrasound beam, and the ultrasound beam first insinuates the base of the heart. Pulmonary veins are better appreciated in the basal 4-chamber weave. When the spine is neither anterior nor posterior but near the lateral wall of the uterus, then we have left axial and right axial weave. In this weave, the ultrasound beam is perpendicular to the interventricular septum. So we use this view to appreciate and to measure the thickness and the integrity of the interventricular septum, to look for the contractibility of the ventricles and the atria. Now coming to the cardiac size. Normally we measure cardiac size by taking the cardiothoracic ratio. First we obtain a 4-chamber weave, then measure the cardiac diameter at the level of 4-chamber, at the level of atrioventricular walls, then measure the maximum thoracic diameter, then take a ratio of it. This is known as cardiothoracic ratio. Or we can also measure by taking the area or circumference of the cardia and then take a ratio of the whole thorax or the circumference or the area of the thorax, then take a ratio of it. By doing this, we get a cardiothoracic ratio which is normally constant throughout gestation. The mean value of 0.45 at 17 weeks and 0.5 at 20 weeks. Any deviation of more than 2 standard deviations is fetal cardiomegaly, which is seen in conditions like Epstein's anomaly, tricuspid regurgitation, atrioventricular septal defect and dilated cardiomyopathies. But it can also be enlarged in other non-cardiac conditions like twin transmission syndrome, fetal anemia, uncontrolled maternal diabetes. But there are some conditions where the fetal cardiac dimension, the cardiothoracic ratio is increased more than 2 standard deviation, but the cardia is normal in size, but it is the thorax which is small in size, like in conditions like lethal skeletal dysplasias and severe pulmonary hypoplasias. In those conditions, what we have to do is take a diameter or the circumference of the thorax and measure to the normograms. Next, we look for the morphological left and right atrium. In the left atrium, as described by Madam, we have two inferior pulmonary veins draining into the left atrium, and the left atrium is the posterior most chamber just anterior to the aorta, and two pulmonary veins will be seen on either side of aorta. And we can see the flap of foramen oval in the left atrium, and the atrium next to the left atrium on the right side is the right atrium. Here we can see the posterior baldness because we are not seeing any pulmonary veins opening in the right atrium, and we can see IVC and SVC draining into the atrium in the bicaval wave, not in the fourth chamber wave. Now coming to the ventricles, we have right ventricle which is in substernal location and has trabeculated walls. And when we see the dimensions of the right and left ventricle, the right ventricle is shorter when compared to the left ventricle because of presence of moderator band. And we have apical object of the tricuspid wall when compared to the mitral wall. Left ventricle forms the apex of heart and has smooth surface and is longer than the right ventricle. Now moving on to the interventricular septum. Interventricular septum separates the two ventricles and is wide at the apex and thins at the crux. This is because of the anatomy of the anatomical configuration of septum, because the lower third is muscular and upper one third is membranous. Now coming to the intraatrial septum. Intraatrial septum we have a communication, that is foramen oval, through which there is shunting of the blood from right atrium to the right atrium to the left atrium. See, this is the umbilical four-chamber weave as described by ma'am. You can see a echo dropout artifact. This usually tend to label it as defect. But if at all we change the angle of inclination of the interventricular septum, then we can see there is no defect here. It's just the echo dropout artifact. So whenever you are labeling a small perimembranous VSD, we have to make sure that we are taking two extra weaves to look for the intactness of the septum, and we have to demonstrate the color across the defect. Next we have the atrioventricular walls. Here we look for the closing and opening of the atrioventricular walls in systole and diastole, so that we are not missing out any tricuspid wall abnormalities like dysplasias or any valvular abnormalities. Next we have normal variants of four-chamber weave. See, these are some things we encounter in daily life, like in intracardiac echogenic focus, which is a normal variant and is no more considered as a risk of Down syndrome because it has very small LR ratio. Next we have pericardial effusion. Pericardial effusion of 2 mm in mid trimester and up to 2 to 4 mm in third trimester is normal. And next we have chamber discrepancy. If at all we see the chamber discrepancy in third trimester, then this is normal. Suppose if at all we are encountering this chamber discrepancy in mid trimester anomaly, then we have to look for the conotruncal anomalies, like coarctation of aorta. Now coming to the other basic weaves, that is the LVOT weave. Here we can see the interventricular septum and the aorta arising in the center of heart between the two atrias. So this is the anterior wall of aorta and this is the posterior wall of aorta. So this is the mitral wall here. So here we have to look for the ventriculo-arterial continuity. So first thing what we look here is, we look for the septo-aortic continuity. So it forms a wide angle between these two. So this angle, this orientation becomes parallel in conotruncal abnormalities. And next we have to look for the mitro-aortic continuity from the mitral wall to the posterior wall of aorta. So here we look for the mitro-aortal continuity. So this will be lost in conditions like overriding of aorta. Next we have the RVOT weave. So here we appreciate the inflow as well as outflow of the right side of the heart. So here we are appreciating the right atrium, the tricuspid wall, right ventricle, semilunar walls and pulmonary arch dividing into the right pulmonary artery and connecting into the ductus arch. Next we have very important, that is the 3-vessel weave. So here we look for the 3 main vessels, that is the pulmonary artery, aorta and SVC aligned in the oblique fashion, with pulmonary artery being the anterior most and SVC being the posterior most. And this is also known as pulmonary artery bifurcation weave, we can see the pulmonary artery is dividing it into the left pulmonary artery and right pulmonary artery. The left pulmonary artery is continuing along the course of main pulmonary artery, whereas the right pulmonary artery is arising at right angles and going behind the aorta and SVC. And this is not the ideal plane to measure the pulmonary artery diameter because this is in the oblique rather than the axial plane. And when we take a high resolution image of the 3-vessel weave, you can also appreciate the right and left bronchi and esophagus. And we can see another vessel here next to the aorta. This is the azygous vein which is seen in the location of infradiaphragmatic IVC. So you can see this is next to the aorta, anterior and to the right of spine. Next we have 3-vessel trachea weave. Here what we do is we just tilt towards the left where we see the joining of ductus arch and aorta next to the spine and to the left of spine. So this is the main pulmonary artery, ductus arch, aorta in the V-shaped configuration, and we have SVC on the right side. So this is very important view because most of the conotruncal abnormalities are associated with abnormalities of the caliber and number of vessels. So we have extended weaves. In extended weaves we have aortic arch weave. So here we can see the aorta is arising from the left ventricle with an acute curvature like a candy cane appearance, giving rise to candy cane appearance. So we have ascending aorta, arch of aorta, descending aorta. From the superior aspect of the arch, we have 3 main vessels: the brachiocephalic artery, the right common carotid, and the right subclavian arteries. So again we have variation here called Goyen arch, where the subclavian, the brachiocephalic artery and the right common carotid artery arise in the same plane. Next we have ductus arch weave. Here we can see the ventricle, substernal ventricle is the right ventricle. This is arising from the anterior-most ventricle, has a wide C-shaped configuration giving a hockey stick appearance. And this ductus arch is joining the descending aorta. Next we have bicaval weave. So here we can appreciate 2 veins draining into the right atrium. IVC, so draining from the lower part of the body, and superior vena cava draining the upper part of the body, opening into the right atrium. Sometimes we can see isolation valve protruding into the right atrium, which is a normal anatomical variant. And we can also see some bulbous dilatation of the IVC before entering into the right atrium. This is because of the drainage of the ductus venosus and the hepatic veins into the intradiaphragmatic IVC. Last we have pulmonary veins. We have 4 pulmonary veins, that is 2 inferior and 2 superior right and left pulmonary veins draining from both the lungs into the left atrium. And usually appreciation of 2 pulmonary veins should be sufficient on 4th chamber vein in most of the cases. Okay, to summarize, sequential segmental approach is very essential in fetal echocardiography for achieving higher detection rate of cardiac anomalies, and identifying a normal landmarks and deviation from the normal cardiac anatomy is very vital in diagnosis of the normal from abnormal conditions. Thank you.
Tube defects by Dr. Muralidhar Kamalapur. Dr. Muralidhar Kamalapur, consultant radiologist and fetal medicine specialist, Department of Fetal Medicine and Intervention, Father Muller Medical College, Mangalore, Secretary, Society of Fetal Medicine, Karnataka chapter. He has finished his MBBS in JN Medical College, Belgaum, Residency DNB, NB, New Delhi, SDM Medical College, Dharwad. He has subspecialty in advanced fetal ultrasonography. We welcome you, sir.
At the outset, I would like to congratulate the organizing team for putting up a fabulous show and for inviting us to share our knowledge amongst you all. This is my first visit to Kodagu and it's been a very pleasant one. Diagnosing neurotube defects in first as well as the second trimester. It's one of the most common anomalies which can be detected in India. It ranges as a presentation between anencephaly, spina bifida occulta, spina bifida cystica, etc. In the year 2015, it had a prevalence of 4.5 per 1,000 live births. Speaking about embryology, it starts as a slipper-shaped thickened ectoderm there on 3rd week, and lateral edges here they start elevating. And as pregnancy progresses, this lateral edge goes on fusing or closing like a zipper. Non-fusing of this zipper by 28 days, then it might result in what we call as spina bifida. Now, what are the factors affecting spina bifida? Family history, previous pregnancy affected. Most importantly, what we see these days is insulin-dependent diabetes, maternal obesity, patient on anti-epileptic drugs like valproic acid and carbamazepine, and low socioeconomic status, dietary deficiencies, especially folic acid. Disorders of closure of neural tube are classified into acrania, anencephaly, exencephaly sequence, encephalocele, and spina bifida. The first of the entity what I want to discuss is anencephaly. This is nothing but closure, failure of closure of the rostral neuropore. There is a large defect of the calvarium, meninges, scalp associated with rudimentary brain. The cerebral hemisphere and cerebellum are usually absent. They die at birth or a few days. It's usually multifactorial, genetic, environmental, toxin, as well as nutrition. Most important thing is, it's not what anencephaly we see in the first trimester. So what begins in the first trimester is failure of development of cranial bones. Anencephaly is the final stage of sequence of events. So it's always acrania. What happens in acrania? The skull is not developed, the brain is developed and the brain is seen properly. So in the early phase, at the end of the first trimester, the cerebral hemispheres have not yet been destroyed and are visible floating above the orbits in the amniotic fluid. This stage is called exencephaly. There is a first stage where cranial bones don't form acrania. From acrania, the brain pops out into amniotic fluid. The brain contour appears normal. It's seen floating, that is exencephaly. A full-blown anencephaly is characterized by complete absence of brain parenchyma. It's usually seen in the second trimester onwards. That's because of progressive destruction of the exposed brain tissue by the chemicals in the amniotic fluid and the traumatic insults because of the movement. That results in destruction of the brain and causes anencephaly. So you go from a stage of acrania to exencephaly to anencephaly. This was a 12-weeker referred for NT scan. You can clearly appreciate that the skull is not developed, right? The skull is not developed, but the brain is seen popping out and the brain contour appears normal. It's not eaten up. The brain contour, even the sulcation of the brain can be seen, right? You can appreciate the contour of the brain and the sulcation of the brain normally seen, but you are not seeing the skull vault. So it's not holding up the brain. So the skull, when the brain is popping out, this is nothing but acrania exencephaly sequence. So this is what we see on an NT scan. Another case which came up at 13 weeks, you can again see the skull vault is not properly developed or it's totally absent, and you can see the brain popping out. There is some amount of ventriculomegaly, but you are seeing the brain parenchyma nicely. The contour of the brain is seen, well maintained, or sulcation is seen, but the cranial vault is not there. So there is acrania, then there is exencephaly. This is not yet reached to a stage of anencephaly because the brain parenchyma is still intact. Another case, you can clearly see, this is the brain is seen well above the orbits. It's on the verge of getting destroyed. Rather, the parenchyma, the brain contour is not that well maintained as you saw in the previous two cases. So this has reached a stage of progressing towards anencephaly. You can clearly see that half-cut forehead. You can see the supraorbital brain, which is freely floating out in the amniotic fluid or amniotic cavity. So this is a rendering which also confirms the acrania exencephaly sequence. So the differential diagnosis of these conditions should not be confused because it's probably easy to make. If not TAS, at least on TVS scan. However, extensive encephaloceles you can get confused with abundant presence of brain outside the cranium. It could be associated with other malformations like spina bifida, anencephaly, cleft lip palate, congenital heart disease, limb anomalies, etc. The risk of aneuploidy is very low, it's around 2 to 3%. The most important non-chromosomal conditions to be looked out in this condition, in this entity, is amniotic band syndrome, where you have thin amniotic bands seen getting attached to the fetus. They do cause various malformations. One such most characteristic malformation what we see in amniotic band is constriction bands. The limbs are constricted at various places. There is auto amputation of the limbs as well as the digits. Another entity what you need to look for is thoracoabdominal syndrome, which has anencephaly, cleft lip palate, omphaloceal, congenital heart disease and other limb anomalies. Moving on from crania, exencephaly, anencephaly sequence is another entity closely related to the one described earlier is encephalocele. They are usually seen in the occipital region, less frequently in the frontal or nasofrontal region. They may result from failure in the fusion of the neural tube at specific closing sites. Cephalocele may also be caused by amniotic bands. This was a case, 12-weeker, primigravida referred for NT scan. She was a prominent obese lady. You can appreciate the nasal bone, the NT, everything, but on further evaluation, we are not happy with this small bump which is seen here. Right? You are not happy with the small bump which is also appreciated in the axial section, but another important clue what you get is dilated ventricular system. So this is the still image which shows a tiny bump. So on a transabdominal section, the more prominent is the cistern spaces which is getting dilated. So immediately switched over to a transvaginal scan. On a transvaginal scan, we could clearly appreciate that this tiny bump is nothing but a occipital encephalocele. So this might go undetected if we just resort to a transabdominal scan. So this is a very classical representation in early pregnancy, in around 12 to 13 weeks. You are seeing a small bump, the defect here, and it is coming out. That is nothing but an occipital encephalocele. This is the rendering from behind. This is the occipital region, this is the ear. You can see this defect and the brain protruding out. This was another 12-weeker, which was very obvious. You can see the entire good amount of brain has popped out, and right? You can see the syndromic flat faces, low set ears, and you can see the occipital encephalocele very clearly. Another entity where it can manifest as a part of a syndrome or another complex is anencephaly. Anencephaly is nothing but stargazing fetus, where there is shortening of the spine. This fetus always had this attitude where it is extended with hyperextension. On further examination, you can appreciate there is an occipital encephalocele. On this, you can appreciate radiodiagnosis of the spine, splitting of the spine with occipital encephalocele. Though this can also manifest in a part of a syndrome or in a part of a complex of other cranial or extracranial manifestation. You can appreciate occipital encephalocele with radiodiagnosis of the spinal cord. Later gestation, sometimes what happens if there is less amniotic fluid, we are able to miss because the spine looks fairly normal, but on further evaluation you see a big mass which is seen in the occipital region, the defect in the skull through which the brain and the meninges are herniating out. You can clearly appreciate in these axial images and even in this cine loop, right? The brain is protruding out. So this has a close resemblance to even hemangiomas, which can be very difficult to look for if we don't follow the right protocol. So one thing which a huge occipital encephalocele should be differentiated is a cystic hygroma or a hemangioma of the neck. Because a hemangioma, you need not go ahead and terminate, but one good part is you just put color and you'll see the color within the mass, which confirms the diagnosis of a hemangioma. The differential diagnosis, defect in the skull vault through which the brain is herniating out. Right? Other malformations are urgences of corpus callosum, ventriculomegaly, holoprosencephaly, spina bifida, frontal encephaloceles, median cleft lip palate syndrome are the ones which you should look out in such cases where there is association with encephalocele. Risk of aneuploidy is around 7 to 18%. Always look for amniotic band syndrome where there is cephalocele, amputation of digits and limbs and facial disruptions. Frontonasal dysplasia syndrome, where there is cephalocele, hypertelorism with anterior cranium, bifidum occultum, widely set nostrils and median cleft lip palate. Or Michelgruber, where we have an occipital encephalocele, polydactyly, polycystic kidneys and CNS anomalies. Moving ahead from cranium and brain to spinal dysraphism, is divided into the open spinal bifida and the closed spinal bifida. The main difference that in the former there is leakage of CSF within the amniotic cavity, and the hypotension within the subarachnoid space triggers a cascade of events. In closed spinal bifida there is no loss of CSF, and consequently the cranial anatomy is unremarkable. Before going ahead, let us study this entity, what is called neural placode. Neural placode is a segment of non-neurulated tissue that has stopped developing through the neural plate stage. It can be found in open spinal dysraphisms and some closed spinal dysraphisms. In open, the neural placode is exposed to the air. So in myelomeningocele, the neural tube fails to close and the neural tissue is exposed. This is called neural placode. So this is a diagrammatic representation where you see there is a defect through which there is dura. You can clearly see you are exposed to the skin, and these are the nerve roots which are seen extending out, and the neural placode is exposed to the air. So on ultrasound it gets translated into a clear case of a myelomeningocele with elevation of the spinal cord. This is the soft tissue component on axial and on coronal, and on axial you can see this neural placode getting elevated, and these are the tightened or pulled up nerve roots. The first entity is a meningocele, which is nothing but which contains meninges, CSF fluid covering the skin. The CSF fluid protects the brain and spinal cord. The nerves are not badly damaged and able to function normally. Limited disability is present. In a myelomeningocele, it's just not only consists of meninges and CSF, but also consists of nerves and spinal cord. The spinal cord is damaged or not properly developed, resulting in motor and sensory deficit. Majority may have bowel and bladder problems. So we have a stage of spinal bifida occulta where there is no exposure, no defect, to a stage of meningocele, whereas the nerves are intact, they are not protruding out, to a stage of myelomeningocele where there is protrusion of nerve roots and placode outside. Now what are the signs? We all are very familiar with signs in second trimester. That's the lemon sign and the banana sign. The lemon sign is nothing but leakage of CSF through an open neural tube defect through the amniotic fluid, low hydrostatic pressure which develops the developing frontal bones may be the most susceptible part of the cranium to this defect, which causes bifrontal scalloping. The main idea is, what happens is leakage of fluid reduces the pressure. So these developing frontal bones compress and they form bifrontal scalloping, resulting in a lemon sign. It is affected fetuses as early as 13 weeks, in 50 to 90% before 24 weeks, but only 13% after 24 weeks. Frontal concavity has been observed to resolve after the second trimester, presumably due to ossification and strengthening of the calvaria. It's not specific or diagnostic of NTD. 1% of normal fetuses display mild concavity of frontal bones. So the lemon sign is not that reliable because it has a lot of pitfalls. That is, in 1% of normal fetuses, it appears normal. Or even as pregnancy advances, maybe at 26-27 weeks, because of the calvarial ossification, this sign is not obviously seen. On the counter hand, the banana sign happens due to the failure of closed neuropore, which prevents the physiological accumulation of fluid in the rhomboencephalic vesicle. The posterior fossa will be too small to accommodate the growing brainstem, and there is downward displacement of the dysmorphic vermis and brain to the fourth ventricle, and this causes what we call it as a banana sign. You can see the cerebellum which is compressed in the posterior fossa. This is the thalamus and the midbrain, and here the cisterna magna is effaced, and you can see the banana shaped cerebellum. So which is good, lemon or the banana? Posterior fossa abnormalities may be the only cranial finding in some fetuses. Among these fetuses, sonography between 8 to 28 weeks gestation age, posterior fossa findings were the most commonly noted abnormalities, with small cerebellum present in 96% of
cases. Visualization of hindbrain herniation is the most specific finding of spina bifida, and visualization of a normal appearing cerebellum and cisterna magna has a high negative predictive value to exclude spina bifida. Effaced cisterna magna in 93%, which compares with lemon sign in only 53% and ventriculomegaly 81%. So it's always the banana which scores over lemon. So if you see both these signs together, you are convinced. If you see only the lemon, not the banana, you need to evaluate further. So the lemon sign develops early, is inconsistently present in 50% of cases, and is lost in most cases of 24 weeks. Obliteration of the cisterna magna and the cerebellar banana sign are the most sensitive features, with the percentage of false positivity being close to 0. Right? These signs can be found from 16 weeks of gestation until term. The ultrasound examination of the fetal posterior fossa is severely hampered in third trimester by increased calvarial mineralization. This is a very important point. So it's always the banana sign which scores over. Another entity what you see is ventriculomegaly, which is relatively late in onset, is seen around 70% of cases. It appears in the late second trimester, 22 to 26 weeks, and versus thereafter. In a study, they found that of 53 fetuses, at less than 50% of the fetuses diagnosed before 24 weeks of gestation had ventriculomegaly, compared with 90% that were scanned after 24 weeks. So, a ventriculomegaly more than 24 weeks has more predictive value than before that. So in general, the relationship between the severity of ventriculomegaly and both the severity of posterior fossa malformation and the gestation age of fetus at the late onset of ventriculomegaly. It is important to note that the ventricles may be asymmetrically dilated, or one ventricle may be dilated and the other may be normal in size. So you have ventriculomegaly and you have banana sign. There are short signs of an underlying neurative defect. Even if your spine is posterior, you make the patient wait, then redo the scan, then confirm, because there is high predictive value that there must be a neurative defect. Another point was the occipital point. You can clearly appreciate the occipital horn of the ventricle is sharpened, or the tip of the occipital horn is very sharp. This is seen in axial view of up to 70% of fetuses which have proved to be spina bifida. This occipital pointing was more common in fetuses under 24 weeks of gestation age, occurring in 75% of cases, compared with 50% in those cases between 24 to 35 weeks. A triangular occipital horn is another sign, which is another indirect sign to show there is underlying ventriculomegaly and there is an underlying neurative defect. This is well established in a coronal section on transabdominal and transvaginal sonography. You are noticing a very sharp posterior point of the occipital horn of lateral ventricle on axial, and on coronal you are seeing a triangular shaped occipital horn. These two are indirect ways of telling there is underlying ventriculomegaly. Other signs of spina bifida, BPD less than 5th centile, a diamond-shaped intrahemispheric cyst, tactile beaking, and in the spine you look for splaying of posterior ossific centers, interruption of posterior ossific centers, kyphoscoliotic deformity of spine, tethered cord, absence of, and most importantly, presence of amniotic fluid is essential to demonstrate this lesion. This so happens that you have certain sign on the brain. You have known that Rachitha showed there is no fluid between the myometrium and the fetal back. You tend to miss. It's very important that you have fluid within that. So you have a ventriculomegaly, grossly enlarged ventricle. There is occipital pointing. There is banana-shaped cerebellum. On your sagittal section, notice the kyphotic deformity of the spine, and you also have a defect of the skin, which is well appreciated on an axial section. You can see that there is U-shaped curvature with a soft tissue mass in the lumbar spine, where it translates as a kyphoscoliotic deformity with a neurative defect. So this was a classical representation where it had all the signs in the brain, which brought us down into lumbar spine, showing a open spina bifida. You can appreciate the occipital pointing in this case. Another case you can clearly see there is also a barotraumatic disruption of the anterior interhemispheric fissure. That you can see, appreciate that
Because of increased pressure, the interhemispheric fissure is ruptured. There is pointing of the occipital horn, right? There is ventriculomegaly, and then when you go back, you are looking for the classical banana-shaped cerebellum. These are classical intracranial signs of spina bifida. And on your sagittal section of the spine, you can notice there is a kyphotic deformity with the discontinuity of the skin, right, which helps us to diagnose that there is a case of spina bifida. So most often what happens, it's the cranial signs which tell us there is something down. So that is usually seen in open spina bifida. So you have a classical bifrontal scalloping, that is the lemon sign. You go back and see banana-shaped cerebellum in the posterior cranial fossa. Then you appreciate, work down and see the lumbar spine. You see a soft tissue mass. There is kyphotic deformity, and you can see the skin, which was continuously seen here, now is absent. The disruption of the skin, a protruding mass coming out with all the cranial signs. This is a classical presentation of an open spina bifida in second trimester. Summing up the intracranial signs, you have the lemon sign, the banana sign, right? The banana sign and the lemon sign. Tactile beaking, you see the diamond-shaped interhemispheric fossa. Here you can pay this sweep. You are able to see all the signs. This is ventriculomegaly, occipital pointing. Then we go further. You can see the banana-shaped sign. Then you are also seeing you are able to see the tactile beaking and the diamond-shaped interhemispheric cyst. So all these are the signs which you appreciate or you see in cases of, this is the banana-shaped sign. You are seeing disruption of the interhemispheric fissure, and you are also seeing occipital pointing. So it's very easy when there are cranial signs, but difficulty lies when there are no cranial signs. Right? Then you have to directly look into the spine. And then the lumbosacral spine shows a classical features of skull kyphotic deformity with a soft tissue mass. So this patient came at 36 weeks. They skipped anomaly scan. You can see gross ventriculomegaly, right? There is disruption of the interhemispheric fissure, right? So at this stage, we don't know what we are dealing, because ventriculomegaly can be anything. It's just symptom-like. But point to be noted is, you are not seeing the lemon sign here. My idea to show this case, the lemon sign is not seen. That's because it's advanced gestational age. Suppose if this was a closed spina bifida, you don't get to see ventriculomegaly, and there is no lemon sign. Yeah, we tend to miss that all around. Suppose you get this case at 28 weeks, you have skipped anomaly scan, you don't get to see the lemon sign. The only thing what helps you is directly visualizing the spine and the posterior cranial fossa. So on further evaluation, we could appreciate that there was a huge lumbosacral myelomeningo C. You can see the lumbosacral myelomeningo C. This was a 36-weeker who had come for a growth scan with Doppler. Right? She had completely skipped her anomaly scan. So even at this stage, when spine was down, we had to make the patient wait to confirm that yes, there is a spina bifida, which can be clearly appreciated on the even in the axial view, the soft tissue mass. Right? This was another case which had classical ventriculomegaly. What I am showing is, look at the occipital pointing. Right? That is one of the characteristic feature of open spina bifida. You have ventriculomegaly happening in various other causes, but in this entity, you have this classical occipital pointing, which is very characteristic of open spina bifida. This was another case where you can appreciate there is lifting up of the spinal cord, a soft tissue mass, the skin is not covered, mass is protruding out, very well seen in the axial section. Always add axial section into your protocol, and here what you see is the nerve roots and the elevated neural placode. This thick point what you see is your neural placode. So these patients carry a very bad prognosis, and nowadays they also do
correction of open spina bifida intrauterine. So that is also a possibility. So we need to tell them whether the neural placode is elevated or not. So this was another case of open spina bifida. On further rendering, you could see there is a defect in the lumbar vertebrae, and this is the rendering which shows a clear-cut defect in the back or in the spine. Closed defects, they mask at the caudal end of the spine. Continuity between the cystic mass and the spinal cord can also be seen by definition. The skin overlying this defect is intact. Most importantly, this can be difficult to demonstrate on occasions if there is a lipoma. In some cases, the lipoma may escape the recognition because of echogenicity is atypical. Most importantly, this was a patient which came up for a routine scan. You see, the brain looks totally normal. The posterior cranial fossa is normal. Right? Anterior complex is normal, no ventriculomegaly, vermis is seen, cerebellum is seen, everything looks very normal. If we don't have the habit of looking into the spine in detail, this case will be missed completely. So on further evaluation of the spine, we could appreciate that there is a defect at the lumbar region of the spine. You can see there is a defect in the lumbar region of the spine. So on a sagittal section, you can see this is a closed defect. This is a meningocele. You don't see the neural placode, you don't see the nerve roots coming out. It is just a cyst. Rendering did show that there was a cyst in the lumbar region causing a meningocele. But neural placode is not elevated, nerve roots are not seen. You can clearly appreciate in this section. So the point to be taken here is, sometimes we are in a hurry, the spine is down, the brain, we just see and go ahead with the scan telling everything is normal. So that should not be the case. Now, closed spinal bifida with or without subcutaneous mass or diastole, two types. The one which are two hemichords are contained with a single dural and arachnoid sheath, and type B, each hemichord has its own dural and arachnoid sac. This is nothing but a case of diastole where you see a bony spur here, and on evaluation clearly appreciate there are two cords. There are two spinal cords. This is called hemichord. You can see these two dark circles. These are two cords. There's splitting up of the cord. So whenever you see a bony spur, the differential diagnosis are it's isolated bony spur or diastole where there is cord splitting. So it's always important that you perform an axial sweep to look for whether there is splitting up of the cords, right? Yeah. So this can be with or without cord regression syndrome or syringomyelia. The important diagnostic features are a blunt, sharp, usually seen in diabetic mothers, cord regression sequence. Blunt, sharp, ending spine or sagittal view, conus ends above the expected level, absent or hypoplastic sacrum, extended lower limbs, opposed iliac bones, cross-leg, Buddha position, etc. In case of syringomyelia, it's the most severe form of cord regression syndrome where the two inferior limbs will be fused into a single one, severe oligohydramnios due to concurrent bilateral renal agenesis. So this was a patient, diabetic patient, poor sugar control which came up. You can see the cervical spine, the lumbar spine and part of it, the rest, the distal lumbar and the sacral spine is cut off. So this is a classical manifestation of caudal regression syndrome. So this is a case which came up at NT scan. You can see both the lower limbs are fused into one. This is one of the most severe forms of closed spinal neural tube defects, that is a syringomyelia. So I covered the second trimester part, and the first trimester I will just show one case. How neural tube defect can be diagnosed in the first trimester. This is our classical fourth view approach for viewing up of the brain, and we usually look for all these spaces, brainstem, IT, the cisterna magna, etc., and the nuchal translucency in first trimester. The brainstem occiput ratio is what we always look for, right? The brainstem is small, brainstem to occiput ratio is large. So this is another section called as tilted axial view which we look for in NT scan. And we also appreciate and look for spine directly in all cases which are referred for NT scan.
Now moving ahead, this was one case which came up for NT scan to look for the brainstem which is large. Brainstem to brainstem occiput ratio was small. So what we did is we went ahead and did a scan which showed that there is the posterior cranial fossa of the brain was effaced, which was not seen clearly. The posterior fossa of the brain was effaced and it was not seen clearly. So this forced to go for a extended scan. On axial scan, we noticed that there was defect in the skin in the lumbar region, and on an axial sagittal section, there was a kyphotic deformity with loss of skin over the surface. So this patient, we gave a diagnosis of neural tube defect in first trimester. This was the 3D rendering, and this was the final report. So neural tube defects can be diagnosed not only in second trimester. These days, all neural tube defects can be diagnosed in the first trimester itself. It is one of the anomalies which has to be diagnosed in the first trimester. So with these things, I conclude my talk, and I thank the organizers for giving me an opportunity to share my views about this topic. Thank you.
Radiology to its legal and ethical landscape. Our upcoming sessions focus on the PCPNDT Act, which upholds the dignity and legality of prenatal diagnostic practices. To our speakers, Dr.Abhilash from Bangalore Hospital for taking session on cardiac CT and case presentation.
President at Bangalore Hospital and Arohi Hospital, Managing Director of Wish Radiology Services, ex-assistant professor at Sri Jaideva Institute of Cardiovascular Sciences and Research, executive member of IACI, Indian Association of Cardiac Imaging, trained and worked at European Association of Cardiovascular Imaging Certification, Cardiac Imaging Fellowship from Narayana Institute of Cardiac Sciences. We welcome you, sir.
Good afternoon, everyone. I'm Dr.Abhilash, consultant cardiothoracic radiologist from Bangalore. I head the Bangalore Hospital at Jayanagar in Kengeri. I also manage the Arohi Hospital at Kengeri, and I have my private firm which provides radiology services to small and upcoming hospitals. So let's come to today's topic. I've been given the privilege to talk to you regarding CT coronary angiogram. I would like you to take a random guess. You will be right. You can shout out from the audience, anyone, a random guess who these two people are. Okay, the next slide will give you the answer. There's a common pattern what you see here. On the lighter note, none of them are there today. Second, most of them we have lost due to sudden cardiac death. I think now you will be able to tell who these two people are. They are our own colleagues who have lost their lives during duty hours at their own hospital trying to save people from cardiac deaths. Of late, in the last 10 years of my experience, I've seen a rise in sudden cardiac death in young population. When I say young population, we are talking about people less than 40 years of age. And as you can see here, there's a shift in the age spectrum. Usually back then, 50 plus people were mostly affected with coronary artery disease, but now the spectrum has changed. You see a lot of young people getting coronary artery disease less than 40 years of age. This is a very sad note to share, but back then we were taking our parents to the hospital, but now it's become the other way. Parents are bringing young adults to hospital to rule out coronary artery disease, and I've seen this in my practice on a daily basis. Why is there a sudden shift of the spectrum of sudden cardiac death in young population? It's because of their diet. They're not able to get physical activity, drinking, smoking, and lifestyle changes. The sudden outburst of social media and Instagram, people are now glued to the screen more than to their friends, trying to connect or build relationship. All they are involved in getting likes and subscribing more followers. These are the most common signs we see in young adults who have sudden cardiac death. And most of these young adults just collapse. We don't know why, what, when. You see young people just collapsing during working hours or at their own will. You might ask, why can't we just get an ECG done, echo done, or a treadmill test done, sir? Why do we need to go get a CT done? As you can see, the number speaks for itself. The sensitivity and specificity of CT is very high, and the positive predictive value and the negative predictive value is high. When you have such numbers and research being published in our literature and trying to convince us, I think it is high time every one of us makes it a part of our protocol to adapt CT coronary angiogram as part of our basic investigation. I'm not here trying to push the taboo of radiation away, but the technology is improving day by day. The radiation dose has been minimalized, and there are multiple new techniques which have come into the playground where we can use to reduce the radiation dose. And a few of these techniques are the prospective triggering, 100 kVp imaging, iterative reconstruction, high-pitch scanning. These techniques, if used properly under the guidance of radiologist and a senior technician, we will be able to reduce the radiation dose to a maximum level. So who should get a CT coronary angiogram? Anyone with a symptom of chest pain, shortness of breath, and if you have an inconclusive ECG, echo, treadmill test, I think it's high time we ask the patient to undergo a CT coronary angiogram. And if you have people who are suffering from diabetes, hypertension, and family history of coronary artery disease, I think it is better we evaluate them for a CT coronary angiogram to rule out coronary artery disease. There are multiple reasons why people nowadays are getting CT coronary angiogram. Post-CABG to evaluate the graft. Pre-operative assessment, I have a couple of orthopedicians who refer me their cases, especially elderly people who are posted for post-knee replacement or hip replacement surgeries because these patients can't undergo stress test. So they on a regular basis get CT coronary angiogram done before operating on them. CT coronary angiogram helps us in detecting the abnormal coronary artery structure. You find anomalous origins of coronary arteries which can be evaluated. And congenital heart disease, CT has the best spatial resolution and imaging characteristics to rule out the congenital heart disease. The most commonly used technique is the CT calcium score. And I'm telling you, trust me, this is a very easy, simple technique which can be used. And we have done a study also to prove that this can be used on a mass level as a screening protocol. So I will just tell you how easy this CT calcium score technique is. You don't need to keep the patient on fasting. There's no contrast given. It's a very easy technique to be performed. You don't need senior technicians or radiologists guarding your department when a CT calcium scoring is done. There's very less radiation being given to the patient, and it is the best screening tool to rule out coronary artery disease. And if it is positive, then you can convince your patient to continue and get a complete CT coronary angiogram done. So basically, in this technique, what happens is, based on the Hounsfield units and the voxel, the CT calcium score gets calculated and it is graded based on the amount of calcium score detected. As you can see, these are numbers 0 to 400. 400 plus suggests that there is a high risk of the patient having a coronary vascular disease. But in my practice, if anyone is positive, I personally counsel them and ask them to get a CT coronary angiogram done, because I've seen a lot of cases where CT calcium score was 0, but patient was symptomatic and we had to end up putting stent for them because they took the right choice and did the CT coronary angiogram. So in my previous institution, we did a collaborative study with Medanta Medicity at Gurgaon. It's a beautiful hospital. If you get a chance to be in Delhi, please visit it. It looks like a 5-star hotel. So our objective was to make sure that we can traditionally use CT calcium score as a screening technique. So the role of stratification of cardiovascular disease was done. Patients with zero calcium score and not associated with increased risk of further cardiovascular events were assessed. So it was a retrospective analysis involving 2 tertiary centers, Narayan Hrudayalaya, Bangalore and Medanta. Above age of 18 were considered. People with prior stunting and grafting were excluded. At least 64 slice CT scanner was used in this study, and significant stenosis more than 50% was considered to be part of the inclusion criteria in our studies. This is the classification criteria which we used in our study. So totally we were able to include 36,437 patients, in which 3,653 were excluded. Among the inclusive criteria, calcium score was seen in 19,378, which accounts to 59%, and calcium score greater than 0, there was 13,406 patients. Amongst the patients which had calcium score 0, which is 19,378, there was no coronary artery disease detected in 17,448, whereas 10% of the total cases included had coronary artery disease. And when we further evaluated those 10% population, we were able to find out that less than 50% of them 1,398 patients had less than 50% of coronary artery stenosis, whereas more than 532 patients had 50% stenosis, which approximately comes up to 2.7%. So in significant stenosis patients, we were able to go back and check their history. Diabetic, hypertensive and chest pain were the most common symptoms what we had seen. And amongst this distribution, it is very well valid that you can say that men are mostly affected and are more likely to have coronary artery disease when compared to female. This is an image showing, as you can see, there is no calcium anywhere, but as you can see here, there is tight stenosis. This is the 3D rendering image showing that same. To confirm our study, there were other studies done, but at a very smaller sample size. 27,000 people were assessed in the confirmed study, and Seniority et al. Had just 6,439 patients. Wang et al. Also similar results were showcased. So my intention behind showing you this is to convince you that in case if you're suspecting someone, or if there is someone who you feel that should get a CT coronary angiogram, and if they're not willing to get it done, you can at least ask them to get a calcium scoring done. Based on that, we can subject them to complete CT coronary angiogram study or not. Because 97% of the time when a person's calcium score is 0, it will be normal. But it doesn't say that 100% is normal. There is still chances of him having some abnormality. So what is the prerequisites for a patient who comes into your department for a CT coronary angiogram? On a clinical aspect, he has to be fasting for 3 hours. If he has a normal serum creatinine value and an interest to get it done, that's more than enough for you to go ahead and do a CT coronary angiogram done. When should you get it done? Ideally, I would prefer the patients coming in the morning, because the fasting status, they don't show your tantrums, because if you ask them to come in the evening and the heart rate's on the higher side and you give beta log to control the heart rate, they spend more time in your department, they become fidgety and get annoyed. If they come in the morning, usually physiologically the heart rate's on the lower end. fasting will also not be an issue, and you can finish the scan in the morning peacefully and send them away. Otherwise, you can do the scan anytime and every time, when your tech is available or your radiologist is there to read the scan, you can do it 24/7. There's no issue with that. Where should you get a CT coronary angiogram? Not all the CT scanners in our country are able to do this CT coronary angiogram. A high-end machine, preferably anything above 128 slice machine, is capable enough to do a CT coronary angiogram. The higher the machine is, the lesser the radiation is, and the lesser the breath hold time is. So what happens after the CT coronary angiogram is done? What does it tell you? It gives us three important information: location of the atheromatous plaque, plaque morphology, whether it is calcium, soft plaque or mixed plaque, stenosis assessment, whether it is significant stenosis, mild to moderate or severe. I've already told you about the plaque morphology, calcified, non-calcified and mixed plaques. And further to assess the risk assessment, they are again divided into low attenuation plaque, napkin ring sign, positive rendering, spotty calcification. If you see these features on your CT coronary angiogram, you need to raise a suspicion of high risk assessment in those patients, even though the calcium score is on the lower side or the stenosis is not that much. So these are images showing you the mixed density plaque, as you can see here. This is axial cut. This is a long segmental image. These are the three different types of plaques I was talking to you about: mixed, calcified and non-calcified plaques. As you can see here, the mixed density plaque is causing more than 60% luminal narrowing in this focal area for the vessel. Based on the plaque quantification, stenosis assessment is done. It is characterized into minimal, mild, moderate and severe. Severe being on the higher side, above 70 to 90%. And our job as a radiologist ends with giving the CADRAT score and suggesting whether the invasive catheter angiogram is suggested based on the findings, what you see. Then I think the cardiologist takes it up and does a multidisciplinary meeting where he assesses the ECG, stress echo, stress TMT test, echo test and our CT coronary angiogram and takes it up for invasive catheter angiogram. But nowadays, once I put in the word suggested invasive catheter angiogram, most likely my cardiologist takes it up to the cath lab without thinking twice. So let me just show you a few examples, a few case studies I've compiled over the past years. So this is a 26-year-old chronic smoker with dyspnea on exertion since 3 days to rule out coronary artery disease. This guy happens to be the son of a famous cardiologist. He stays in our neighborhood. He knew that I've been to cardiac imaging and came up to me one day and told, "Anna, I smoke a lot. Can we do a calcium score?" I was like, "We'll do a complete study to be on the safer side." So as you can see here, there's no calcium in this study. If you had seen calcium, you would have think there's no calcium detected in this scan. So we proceeded to the next step. The beauty of calcium score is more than 50% of the lungs gets covered in this image. As you can see here, the lines, parallel lines, what you see, this is the area which gets covered in the calcium score. So when I do a calcium score for a person, I will be able to assess his mediastinal structures, lungs, as well as the bony abnormalities. And a lot of times I've picked up bronchiectasis, bony abnormalities, sclerosis, other secondary findings also. So calcium score doesn't just pertain to the score of the coronaries and the calcium deposits. We will be able to give additional information also. So this is how, this is his calcium score. It's 0, as you can see the value here. So we proceeded and went ahead and gave contrast to him. The most important difficulty what we faced while scanning patients for CT coronary angiogram is breath hold. If your patient is able to hold breath hold for 10 to 15 seconds, if you're using a 128 slice scanner, that shouldn't be an issue. I use a 640 slice scanner. The scan happens in less than 4 seconds. So breath hold is not an issue for me, but most people don't have the luxury of a high-end scanner. So if your patient cooperates, then you'll get beautiful set of images like this. So this is the long segment reconstruction image of the RCA, LAD and LCX showing you that the calcium score was 0 and there's no significant coronary artery disease with classification of CADRATs being 0. Second patient is a 36-year-old oncologist. He happens to be my senior from MBBS college. He works at Astor. He brought in 5 of his friends. All of them were normal. This guy, let's see what happens. So as you can see, there's no calcium deposits in the calcium score. So currently we can straight away say that 97% of the time these people are going to have a normal study. This is the calcium score report of the patient. I want you to look at the origin, the aorta, aortic root carefully. So the origin of the coronaries happens as the right coronary artery arises from the right coronary cusp, whereas the left main coronary artery, which bifurcates into left anterior descending and left circumflex, arises from the left coronary cusp. But whereas here, the right coronary cusp, the right coronary artery is arising from the left coronary cusp. I will show you here. As you can see in these images, the arrow points at the origin of RCA, which is coming from the left coronary cusp, and it's a slit-like origin. It has an interarterial close. This is something to be worrisome and to be aware that in case if my friend gets a sudden cardiac arrest in the future, the most likely cause would be due to this interatrial course. These are representative images showing RCA. So even though his calcium score is 0, I had to call it CADRATS 3 because the luminal narrowing is quite moderate. Next, we have a 52-year-old surgical gastroenterologist with a positive family history of heart disease. Calcium score was 0. This is the axial representative images. As you can see here, there is a tiny small speck of calcification seen in the left anterior descending artery. Sometimes in calcium score, the small specks of calcification doesn't get picked up because the volume is quite small or less than 3 mm. But anyways, he's on the safer side as his calcium score was 2.2, CADRATS is 1. There were minor plaques in left anterior descending artery, whereas it was normal on RCA and LCX. Next, we have a 64-year-old patient who's diabetic on treatment and he was asymptomatic. That's the most catchy part of this. 64-year-old diabetic, asymptomatic, but as you can see in this calcium score, there's thick chunks of calcium in all the 3 coronary vessels. Just look at his calcium score, it is 1332. The highest I've scanned for one of a VIP in our country. He's, I think, retired now, a government official. His calcium score is 9,000 change. None of us could do anything regarding it. We couldn't even go ahead and do invasive catheter angiogram. We are just doing a stress perfusion test and myocardial perfusion test and following it up. So this is his axial images. You will be able to appreciate the stenosis better in the long segmental reconstruction images, which is followed by this. I'm just giving you an overview of the axial images. As you can see here, this is the right coronary artery. We should assess the coronary arteries in all angles before we can make a conclusion of the percentage of stenosis. That is why you have me showing in a straight orientation as well as your curvilinear orientation, and it is at 15 degrees, 30 degrees and 45 degrees. This is your left anterior descending artery, left circumflex artery. This is his final report. Left anterior descending artery was mild to moderate stenosis, whereas left circumflex artery mid was on the higher side, 60 to 70%, whereas on the most affected was the right coronary artery, being 70 to 80% in the mid segment. So at the end of the day, we had to call it severe coronary artery disease in mid LCX and mid RCA, and I suggested an invasive catheter angiogram. The patient was not willing, so the cardiologist has put him on statins and we're just following it up with him. Next, we have a 59-year-old post-PTCA to LAD and RCA. This is not calcium what you're seeing, it is the stunt what you're seeing on a calcium score technique. Usually we don't do calcium score for a stunt patient, but my cardiologist was very insistent that he wants to know if there's any calcium deposits in the non-diseased vessel. These are the filming images what we give to the patient. We make sure that it is easy for our cardiologist or the referring physicians to look at the films and explain it and convince the patient for whatever treatment is on their mind. So the stunts in this patient were patent. There was no instant restenosis. And another main reason why patients post-PTCA get a follow-up checkup done after 5 to 10 years to see the patency of the stunt. Sometimes what happens is the stunt does get occluded or re-stenosed, so they need to go in and intervene again. So every 5 years to 10 years, based on the symptomatic management, if there's any new symptoms, these patients undergo and get a CT coronary angiogram done. Next, I have a post-CABG case which had come with mild chest pain. ECG and echo was normal. This case was referred to me from Andhra, Warangal. There was a Lima to D1 and LAD grafting done. Then the right saphenovenous grafting was done to the right-sided RCA. It was a triple vessel disease. Focus on this area. This one. This is your graft which is going all the way till RCA. This is your right saphenovenous graft. And I'll show you the second graft, the Lima graft. concentrate on this vessel. I have straight linear images also, so don't worry if you are not able to follow this. So these are the VIT images of the reconstruction showing the patency of the grafts which was done for this patient. You can see it beautifully being illustrated from lima to the distal LAD as well as the right cephalovenous graft. So usually in cases of post-CABG, patients are healthy. Unless they don't develop new signs and symptoms, people don't suggest for a CT CAG. Most likely the main coronary vessel which supplies the heart is patent. If there are multiple grafts, few of them get thrombosed as they age. This is another graphical representative image showing the graft. See how beautifully you can see the entire vessel. There is no coronary artery disease or any soft plaques or calcification being developed. You can see the entire length. So if you see the VRT image, you can see two small stumps. So this suggests us there was a graft previously here. Okay, this is the patent graft where we can see, and this graphic linear representation shows us the patent graft, and these two images shows us the thrombosed graft. It's quite commonly seen in CABG cases. A few more examples of occlusion of the graft. As you can see here, the graft is completely occluded. So in the VRT images also we are able to demonstrate it well. In this focal area of stenosis, even though grafting has been done, there is stenosis also. So post CABG assessment, CT coronary angiogram plays a very important role because it's non-invasive, easy to perform. You don't need to subject the patient again into the cath lab and shoot multiple X-rays on the cath lab, which is quite high on the radiation dose. So this is an interesting case I wanted to show you. So this person came into the clinic last evening when I was about to leave, and he told me, "Doctor, I have chest pain since 1 week." And I asked him, "What took you so long to come to the clinic?" He was like, "I was waiting for a general holiday. Like, hopefully, he came at the right time." And I asked him, "Why did you come so late?" He was like, "Sir, it's Bakrid and I wanted to eat biryani." So he went to his friend's place, had biryani, then he made some time and came to my clinic. So I was like, "What's the issue?" So he says he had chest pain since 1 week, shortness of breath. TMT was inconclusive. ECG, there's mild changes. So on performing the calcium score, it was 0. But I had my suspicion because when someone comes with this kind of an attitude on a Saturday evening with chest pain and shortness of breath and priority is biryani for them, I had a hunch feeling that this guy might have some issue, and I was right. As you can see here, this is the proximal LAD. I'll show the X. So this is the X. This is the representative images, linear and curvilinear. As you can see, where the arrow points out is that's where there is tight occlusion due to soft plaque. There's no calcification. He's a 46-year-old IT chap sitting behind the desk, predominantly spends 3 hours in the first half of the day on stock market and trading. So I think his money is going to be used wisely in the future. LCX was also involved. More than 50 to 60% was involved. As you can see here, there is circumferential soft plaques which is causing the narrowing. Distal RCA also had a soft plaque which is causing more than 60 to 70%. Finally, I had to give him this report. Short segment total occlusion in the proximal LAD, moderate to severe coronary artery disease in LCX and distal RCA. I have suggested an invasive catheter angiogram. I think he wanted another opinion. So let's hope God saves him as soon as possible. So my take home points is, if you have a symptom, please don't neglect. I've seen a lot of young people pass away in the last few years, especially doctor faculty. We need to save ourselves before we can save and help the humanity. Calcium score is a must above 40 years of age. If you can implement this as a protocol in your institution, in your workplace, it will be very happy. It is very cheap. You don't need to spend too much money. People in Bangalore are doing it part of the cardiac package. Every 6 months, hospitals does it at less than 1,000 rupees per scan. Their intention is, once you see a calcium score, obviously you can convince the patient to get a CT coronary angiogram. And if it is too high, the cardiologist gets a case. So, and at the same time, they are helping the society in a larger spectrum. And if you see calcium being positive, irrespective of whether it's 0, 1, 100, 400, please get a CT coronary angiogram so that you can stay in peace and have a fruitful life. And before you can do all this, I think it's better we cultivate an active, healthy and a stressful life. Even though we say it, I don't know how much of it we will be able to do it in real life. Thank you very much. Long live IRIA.
Transition from clinical radiology to its legal and ethical landscape. Our upcoming sessions focus on PCPNDT Act, which upholds the dignity and legality of prenatal diagnostic procedures. To begin, we welcome Dr. Ananda M, Associate Professor from Department of Radiodiagnosis, KoIMS Madikeri, to provide an overview of the PCPNDT Act, its foundations, objectives and implications for the medical community, and also the basics of personal finances to doctors. Having served in the health department for the last 18 years as medical officer up to being professor in Department of Radiodiagnosis at KoIMS, we are very glad to welcome you, sir.
We want to give a token of appreciation for Dr.Abhilash sir. We would like to request Dr. Mohan Appaji sir to please give the token of appreciation.
Thank you, Abhilash sir, for coming all along from Bangalore. Actually, we wanted it in between somewhere. Many people are asking why the CT in between. But the seriousness is such that we also feel to undergo at least one screening. Anyway, delivered it, sir, and probably many people will be coming for the screening at least. Thank you. I had a lengthy of slides, many issues to be covered, but shortage of time. I have cut short, very precise to the practical aspect of what really a radiologist or a sonologist or a OBG persons who are doing a scan to know particularly about PCPND to escape from all these offense and offending acts that act is giving us to follow. Because we will be doing all the scans, but without following many things, sometimes a whole lot of confusion and sometimes even to the extent of what this profession is. ಅನ್ನೋ ರೀತಿಯಲ್ಲಿ ನಮಗೆ ಕೇಸ್ಗಳು ಆಗ್ತಾ ಇರೋದ್ರಿಂದ I need to go and discuss about some of the do's and don'ts, and many information we can't afford to, though it may be subjected for discussion and debates that why this PCPND is lagging, dragging us and all, but it is a matter of act and rules that government of India has adopted. We need to follow it. In the perspective of radiologist or sonologist, let us see it, how it goes. Where all we need to apply this, and also who can take benefit out of this is not only USC, CT, recently MRI, CT, they are all coming under the PCPND Act. All the government hospitals and employers of the institution, because not only the scanning persons, even the vicarious liability of who is the owner of the scanning center or hospital is also responsible. And definitely for the sake of PG theory and practical PCPND. What are the purpose of the PCPNDT Act? To mainly punish the doctors, or so-called recently we are having lot of people who pose as doctors who tries to detect fetal sex determination. Recently in Mandya district we had thousands of such incidents. So those are also need to fear for PCPNDT Act if it is strictly followed. What are the offences probably we may get into if we don't follow those offences under PCPNDT or fetal sex determination right away? That non-registration. But many of the radiologists or genuinely practicing doctors will not go for the first criteria. But we will be again offenders by calling them non-maintenance of the so many things like non-registration. That also we are having a lot of complaints. Nobody will go for without registration. But advertisement, few of the North Indian people, they are doing it, social media and all. There the court, they given the already verdict for a conviction to the extent of many imprisonment. But F-form is the thing which we are giving. I give the statistics, how much documentary things we are non-complying and we are ending with the problem. And non-display of the certificates that we have got from the registrations, and not keeping ad copy, just a physical ad copy, not in the clinic or any hospitals, you will also amount for the offence. Not sending monthly reports. Nowadays it is relaxed to the extent of sending email monthly reports. Then not wearing the nameplate or not displaying the center's name. Many of the infrastructural needs that it is prescribed as per the PCPNDT. Not be legible outside, or it is too small. An approximate 2,700 till 2020 cases are pending, out of which many are settled, but still many are pending in the court. This is another one statistics. Problem, the registration problem is only a least. As I said, we are all complying. Advertisement also we fear for it. Sex determination less likely if it is found to be. But many of us are ending in problem facing with the, even to the level of seizure or suspension or cancellation is record maintenance, which is as per the Act and rules we need to maintain, amounting for 75% of the case. It is a throughout India statistics. So court case still pending under the same record maintenance only. So what are the act that we are going to have thorough knowledge, at least few section and few rules are as per the PCPNDT Act 1994 and 1996. 2003 it got amended. In that act, at least we should see, if not all, important section 3, 4, 5, 6, 18, 19, 20, 21, 22. So at least we should know out of total 34 section, these many sections we need to know and go in details, and it is a very small book. Provided we give time for it to read, we can try to comply for that also. And out of 18 rules, 1996, important rules are again 3, 4, 5, 6, 7, 8, 9, 10 and 17 and 18. Let us have an habit of, at least in a free time, to look into this, what are these rules and acts, so that we can defend ourselves of some smaller issues or smaller negligence can happen. So we can very boldly defend, having the help of a lawyer or anybody. So what are the forms that we need to keep according to this PCPNDT Act? Or A, B, C, D, E, F, G, H. So A for application that we apply for, then we will get the certificate that is in the form of B. Then C form is, if at all our application is rejected, it is C form. D is the record maintenance genetic counseling centers, that is only for the genetic counseling centers. And then E, record maintenance of the laboratory in case of ART and all. But for us is F form. Majority of the USG or MRI or CT anywhere, we have to keep this USG F form that should be complete and also signed by both the patients as well as the performing zoologist or radiologist. Then consent for invasive procedure, it is for the invasive procedure practicing doctors. Then H is the record of the appropriate authority given to us in the form of certificate. What are the registration that we need to make is one regarding the place where we are doing about the place and place or the site as institutions. Then missions is very particular. Recently there are many cases going on even in Kodagu. One mission is registered in his name, in the center name, but the mission is not there. Mission is somewhere else. When we went for just inspection, registration is given in 2 missions, but one mission is completely out of his privy. Where it is there, we still don't know, and it is in the court. It comes even for us also. Any unused missions, we should inform to the appropriate authority and get it cancelled or get it deconditioned. So that missions are very important. New missions definitely, before going for any registry, the scanning, we need to get the appropriate authority permission, providing all the invoice, registration numbers, everything, including probes. And persons. Persons means whoever is doing the scanning, definitely they will do. And also nowadays they are insisting upon the person who is assisting for the scanning reports, like data entry operators and whoever the staff nurse who is assisting, their names to be given and also registered. Because once any cases or any offences found out by the inspection committees, these people will be coming as a witness in all other states, stages like judiciary, junior magistrate or session or high court. So for that we need to have person's details also with the proper their qualification details. Then what are the displays that we need to do? Displays are the registration certificate, then notice board in 2 languages, both in local language and English. PCPNDT hard copy, as I already told, it is a mandatory. Many where they were published with the amendments, please keep those PCPNDT hard copy mandatorily. If at all not there, at least have a downloaded copy printed out. It should not be a problem, because any problem, it is a minor or major, they will see that it is all violation of the act. So mission registration number certificate, then doctor certificates. Regarding this also recently in our districts, they pose as MD and all, but they are not at all even a radiologist. They are giving, and unfortunately our district also has given the MD registration, and designation he has put outside as a MD radiologist. But we found out and gave the inputs. Finally was someone given the notification, so he corrected it. He was just a sonologist passed with 6 months training. But he showed that MD because he has done some online course in MD. So that was considered by the appropriate authority unknowingly. But we need to know the doctor certificate also. I am speaking in both the perspective. As a inspection monitoring committee we go, and as a person who is doing in the scan center, we need to know all these things. And name and designation plate on the dress of the doctors, that they ask it. Mainly the name, at least what we are doing, that should be displayed, the doctor's details in the notice board. Coming to rule number 9, which is the main thing which we are lagging and also having some problems because of the some of the assisting people lacuna or oversight. 5-column register at least. Nowadays, to be very safety, we are even maintaining 7 columns. The column name like serial number is a mandatory, but which you have to give running number of the month of the year, and because you can't add in between, and that can be subjected for suspicious if you do some maneuvering the serial number. So serial number is mandatory, name of the patient and address to trace back and to look for all those things for the inspection monitoring committee, and also name of the husband or father if it is a POXO case. We are nowadays very good number of cases we are getting POXO cases, so father at least. date on which the patient came for the study is also mandatory. What we are asking for our sake is sign the document the register that day only after scanning, and also if possibly put the report what you have given in short, like SLIUG, so of gestation periods like that. So that is mandatory. But this is according, even here also, as I said, in that center we didn't have such a 5 columns register there. Then a form with the patient's signature. This should be very clear. Sometimes we can say for a district team, sometimes state team also we can say and excuse. But very recently we had even a national team coming, that is also Inspector Monitoring Committee. There we can't say anything if it is not signed. It amounts again the negligence. Many cases went to court and also, so it is only a procedural lapse, it's not an intentional. But verdict was that nothing saying, nothing relaxation. If it is not signed means it amounts to be doubting about the intention of you hiding or doing the sex detection only. So burden is on us to prove that. So before going for that proving burden, let us be clear about our form completion, like taking the signature of the patient, and as well as we ourselves putting the signature in 2 areas. Then EOC report, as you all know, should be kept as a printed copy, and EOC images, if it is possible, hard copy. If not possible, keep it in saved copies in the hard disk, so that anywhere, if at all the inspection or appropriate authority ask for us to produce in the inspection or sometimes in the court, we may need to be producing the cases, particularly for at least minimum 2 years. Then consent, if it is for the invasive. Then monthly report. How it is done monthly report, sir? Nowadays in email only, because
no, both. You send it physically. Email other districts. Kodagu is different.
Kodagu we are not sending, sir. We got email only sending the
We do both. We send it by digital format to district outside.
Yes, sir.
And we hand over a copy to this one.
As we were discussing, sir, we presented this and they took it at least. Okay, give us in a, and there was a zero issue. Okay, give it in a soft copy, need not be presenting the hard copy. But many other districts like Mandya, even I don't know, Asan, how, Shivamoga, sir, you are giving hard copy only?
No, only
Scan copies. Mandya, Ramnagara, they are insisting. Anybody, Sulya? DK. There also they are insisting on monthly hard copies. So this is the thing, record keeping, and this declaration is a mandatory, name of the doctor. Even we are seeing in Hunsur, I can say, I don't know, I don't remember that name center, no declaration of such things. Nanu yaru madada enu illa, scan madirtare, signature hakirtare, ishtu. That also amounts for the suspicion and also violation. You have to declare that I am so and so doing the scan for such and such patients, not is detected or she is not told. So atharadhan madbekagutte. Mainly what to do if the mission is sealed. Idanna ಒಂದು ಸ್ವಲ್ಪ anticipate ಮಾಡೋಣ. Let us not go for that level. Let us not be at panic. ಇದೆಲ್ಲ ಆಗಿರೋದಕ್ಕೋಸ್ಕರ ಹಾಕಿದ್ದೀನಿ ಪಾಯಿಂಟ್ಸ್. Seek advice from a legal person and don't blow up the issues to the media and all telling that ಅವ್ರೇನ ಬಂದು ನಮ್ಮ ಮಾಡಿದ್ರಿ ಅಂತ. Stay away from politics. If sir was there, it would have been appropriate to say. When we all went for the inspection, it went to this stage in Kodagu only. It was taken to the level of MLA sir and also above. Fortunately, our minister was very strict about it and he said, nothing doing, you just follow it. If you are having a lacuna, you will be subjected, or if you are having any proof to prove that you are innocent, prove it in the court. So that's how I personally was subjected for all such politics when I was a part of the inspection committee. Vijay Sarthi sir knows. I went sometimes why we should become a inspection committee members, because we did just only, there was no F1s, there was no plate, but unfortunately for him, but fortunately for me, we got 200 reports outside about that, no F1, no plates, no image, no reports with them. but 200 outside reports is there. They have signed completely. There were only 11 reports, 11 F forms in the scan center. So it was a clear cut that they have maintained or the purpose is. When this was brought to MLA sir, he came to know and also understood. Then we proceeded. Case is in the court, high court level to see that. So these are all the things why we need to be, and only court can help. Our many friends who were wrongly implicated in the case got help from the court at different level, both judicial and junior magistrate and session court, high court. So that's how the thing. If at all if things happens, let us not be panic. Let us go legally and let us discuss among the faculties and colleagues. And definitely politics is not the thing for the help. Only court will help, and that's how. If not one stage, we can go even up to Supreme Court. This is why, in short, there were many stories to tell, but we are running short of time. Today, I personally thank everybody who are here at least to have patience listening to this lecture sessions. Thank you. Last session, one of my friend who has come all along from Udupi is very well versed with some kind of financial advice to doctors. So he himself is a psychiatrist.
One things we are seeing of late is ಒಂದು ನಿಮ್ಮ registration whatever form be they are giving ಅದರ ಮೇಲೆ ಇರುವಂತಹ ನಂಬರ್ ಮಿಷನ್ ನಂಬರ್ ಮತ್ತೆ ಮಿಷನ್ ಹಿಂಭಾಗ ಇರ್ತದೆ ಮಿಷನ್ ನಂಬರ್ ಕೊಟ್ಟಿರ್ತದೆ ಬೋತ್ ಶುಡ್ ಬಿ ದ ಸೇಮ್ ಅದನ್ನು ದಯವಿಟ್ಟು ಇದು ಮಾಡಿ ಏನಕ್ಕೆ ಅಂದರೆ ಇತ್ತೀಚೆಗೆ 2 ನಂಬರ್ಗಳು ಬೇರೆ ಬರ್ತಾ ಇದೆ ವಿಜಯಪುರದಾಗ ಒಂದು ಇದಾಗಿದೆ ಅವರು he was not able to produce the bills of that the machine which he was having ಅದೆಲ್ಲ ಚೇಂಜ್ ಮಾಡಿದ್ದಾರೆ but first thing we are going to see is the form B whether it is updated or not. Second thing is the number should be the same. ಎರಡನೇದು ಬಂದು form F ಸುಮಾರು ಜನ they are not signing. They are telling why we should sign. It is the work of the clerks or somebody who is typing the thing. But the thing is form F is the responsibility of the person who is doing the scan, whoever it is. That is why they have given 2 columns in the bottom. So it is his responsibility to get the signature of the patient. So next month the report na dayaviಟ್ಟು save ಮಾಡಿ both soft copy as well as hard copy and monthly submission within 5th ಮಾಡಿದ್ದು dayaviಟ್ಟು you keep one acknowledgement for that. We are going to ask them ಈಗ address ಮೇಲೆ number name plate ಇಲ್ಲ ಅದಿಲ್ಲ ಇದಿಲ್ಲ ಅದು when state inspection committee goes generally they will not give that much importance. But these things form sign ಮಾಡಿಲ್ಲ ಈ ಥರದ್ದೆಲ್ಲ ಎರಡನೇದು ಈಗ ಸರ್ ಹೇಳ್ದಂಗೆ ಅವ್ರು ಯಾರೋ ಹೊರಗಡೆ 200 ರಿಪೋರ್ಟ್ ಸಿಕ್ತು ನಮ್ಮಲ್ಲಿ ಬಟ್ 11 ಫಾರ್ಮ್ಸ್ ಮಾತ್ರ ಅಲ್ಲಿ ಎಂಟ್ರಿ ಆಗಿತ್ತು ಅಂದರೆ ದೇ ಆರ್ ಅಂಡರ್ ರಿಪೋರ್ಟಿಂಗ್ ಮಾಡಿದಾಗ ಸೇಮ್ ಥಿಂಗ್ ಹಸ್ ಹ್ಯಾಪೆಂಡ್ ಇನ್ ರಾಯಚೂರು ಆಲ್ಸೋ ವೇರ್ ದೇರ್ ವಾಸ್ ಅಂಡರ್ ರಿಪೋರ್ಟಿಂಗ್ ದೇ ಹ್ಯಾಡ್ ಸೇವ್ಡ್ ದ ಇಮೇಜಸ್ ಬಟ್ they had not uploaded the form. So when we try to correlate, there was excess amount of scans done using that particular machine, but it was not uploaded. So ivella ಏನಂದ್ರೆ it leads to suspicion that what they are doing. And ಎರಡನೇದು ಯಾರು ಸ್ಕ್ಯಾನ್ ಮಾಡ್ತಿದ್ದಾರೆ ದಯವಿಟ್ಟು ಎಂಪ್ಯಾನಲ್ಮೆಂಟ್ ಅಂತ ಮಾಡಿಸಿ. ಒಂದು ಸ್ಕ್ಯಾನ್ ಸೆಂಟ್ರಲ್ಲಿ ಡಾಕ್ಟರ್ ನಾನೇ ಮಾಡ್ತೀನಿ ಅಂತಾರೆ, ಬಟ್ ಅಲ್ಲಿ ರಿಪೋರ್ಟ್ಗಳು ನೋಡಿದಾಗ ಇದು ಬರ್ತದೆ, ಇನ್ನೊಂದು ಡಾಕ್ಟರ್ ಇರೋದು ಇದು ಬರ್ತದೆ. ಸೊ ಜಸ್ಟ್ ಒಂದು ಲೆಟರ್ ಕೊಡೋದೇನೋ ಅವ್ರು ಕೇಸ್ ವರ್ಕರ್ ಹೇಳೋದು ಅವರು ಎಂಪ್ಯಾನಲ್ಮೆಂಟ್ ಮಾಡ್ತಾರೆ. ಸೊ ಈ ಥರ ಸಣ್ಣ ಇದು ನಾವು ಮಾಡ್ಕೊಂಡು ಹೋದ್ರೆ ಐ ಥಿಂಕ್ ಇಟ್ ಶುಡ್ ನಾಟ್ ಬಿ ಎ ಪ್ರಾಬ್ಲಮ್.
Before this session, it was nice that today we had a live session with the help of a Resona i9 machine, and that was a mind drain. On behalf of this IRIA and also KoIMS Medical College, and we happily extend our gratitude, small gratitudes for their help, that they provided a wonderful machine with full resolution from the company Mind Drain. Small gratitude, Vijay sir, to hand over. On behalf of Mind Drain, Shankar, Santosh and Chaitra madam, please. Thanks for your cooperation.
Navigate complex patient scenarios but find ourselves adrift when it comes to managing personal finances.
To address
address this often overlooked aspect, we welcome Dr. Ravindra Munoli sir, who will enlighten us with foundation principles of financial literacy and planning tailored for doctors.
So I am Dr. Ravindra Munoli, additional professor at KoIMS Manipal. Finances since childhood we have seen, right? Like nobody wants to discuss, even the parents discourage us from discussing, because there is a stigma myth associated with it. Okay, if you talk about finances, children will get spoiled. Even as they grow up, and lot of myths have been put up in our brains. Money is evil. Okay, doctor should not earn money. Isn't it? Before I start, I would like to thank IRIA Karnataka, Dr. Ananda, a good friend, Dr. Sachin, and IRIA president. So my financial journey has been through one of the radiologists only. I hope most of you may be knowing, Dr. Ramamurthy, who started a thing called Wellcome. Almost 1 lakh allopathic doctors are part of it now across India, who trains allopathic doctors. This group is only for doctors by the doctors. That's it. So, special thanks to Kodagu Institute of Medical Sciences for having me here. So before I start, the customary disclaimer that it is for education purpose only. You can make your own choices or contact your financial advisor. I am not a SEBI registered advisor. Okay, so people will ask like what is the secret and will give me some tips, everything. You might have seen the Kung Fu Panda, they will ask, no, there is a secret recipe. There is no secret recipe, it is just you. You just have to start, you just have to go ahead. That's all is what is needed. So basically at the end of this session I just want to create some awareness about the financial education, need to know some of the avenues of wealth creation. Also about insurance, which we all talk about and which we spend a lot of time in understanding and are often misguided. It's something about taxation and loans. So there is a stark difference, right? 95% and 5%. So what's the difference between these groups? Just a financial literacy, that's all. So I will begin with the myths that we all have. Basic thing is everyone will tell like I don't earn enough to invest, somebody else will manage my finances, or I am too old to start investing, and money is not important. So difficult for doctors to understand. At times they mean that the share market is satta bazaar or it's gambling. Also we have seen in the movies and other things, rich people are always shown in a bad color, right? Finances should not be discussed with children. Gold and FDs are the best investment option. These are some of the myths which we all carry all through, right? I am telling these are all myths, right? So we'll see how they are myths and what we can do for these. Yes, money is not everything, that's what you have been told, isn't it? But money is needed for everything else. If you want a good quality of healthcare, you need money. You want your children to study in a good college, you need money, isn't it? You want a good quality of life, you need. For you to get treated, you need, isn't it? Also, life expectancy is increasing, so are the expenses. Cost of livings have gone up. We all know how inflation is rising up. And remember, children are not your retirement plans. Okay, once they study, once they do some professional college, they are out of the place, out of country, and they will not come back. Also, never outsource your investment decisions to anyone. Okay. So, what should we learn in finance when we talk about finances? It can be divided into very simple things: earning, spending, investing, 3 things, and taxation, insurance, and loan. So, whole finance, what a person thinks or what a person wants to do, can be understood only in these 6 subheadings. Right? So that's all is finance about. Earning, we have 2 earnings, active income and passive income. Active, okay, I am working every day from morning till night. It can be self-employed or a small business which requires my presence. Passive income, it doesn't require my presence, but I still can generate money. Investors are invested in some company runs on its own, my money is just invested, it doesn't need my presence, still it earns money for me. Loyalty or rights, I have some book written, so I will get some royalty out of it. So when we talk about financial freedom, we want this. I mentioned about active income and passive income, right? So first target is my passive income should become more than my annual expenses. Let's say I am spending 10 lakhs per year. I should generate enough passive income resources that will take care of my annual expenses. So we should try for that. Second is passive income should exceed my annual active income. Let's say I am earning 40 lakhs per year. My passive income should start exceeding that. Third, if I stop working today, okay, so I will survive for the next 20 years without any work or without doing anything. So that is our goal. Is it possible? Yes. We have many people who have almost reached that stage. Dr. Anand can know, Anand will be knowing, one of his batchmates will be almost retiring next year. So other thing that we have is, okay, in addition to our degree, we have PhD in spending, okay. So all the dopamine surge that we get is from spending, okay. The happiness that we get is spending. You go to mall, spend, splurge some money, kids want to play, okay, put some thousands and all we spend. Buy a new shirt, whether we need or not, buy some sneakers. Okay. And when it comes to investing or saving, we are illiterates. Okay, many times you see young people who have just finished MBBS or degree, then come out and at the end of the month they are like, okay, again struggling to have anything in hand. So where do we spend? There are two things, components, products of need and products of prestige. So distinguishing is very simple. Products of need are some simple things that we need for survival. We need our daily expenses, food, clothes, some tuition fee, bus fee, etc. Products of spending, everything that goes on Instagram to show off, those are products of prestige. Okay. So that is as simple as it. Now important question comes, we all know we need money, we need to have enough money, so then why don't we invest? Common answer is I don't have time, I don't understand, isn't it? But it's not. So now there are two terms that I was mentioning, saving and investing. Saving is earning 100 rupees, spend 80 rupees and keep 20 rupees in the bank. That is something called saving. Investing, you earn 100, spend 80, but you buy appreciable assets of 20 rupees. Appreciable means that should grow. That is investing. People have the myth, okay, to save money, I should save money. No. Invest that so that it should get appreciated. Car is an investment? No, it is a liability. The moment it comes out of your showroom, the value goes down. Okay. So there are two things, what we call it as assets and liabilities. I mentioned that appreciable assets. So any assets is anything which pays you. Right? Let's say you buy a stock, it gets appreciated, it's an asset. Buy a house, price gets appreciated, it's an asset. Isn't it? Liability, anything which takes money from you. Assets can be physical, financial or intangible. It can be gold, real estate or any machines. Those are all assets because they are generating money. We can focus more on that. Now it will happen so that I may not be able to go and do real estate, okay, I may not be able to spend more time dealing with brokers, etc. Then comes the important thing called financial assets, in which we have equity and debt instrument. Equity is nothing but shares. Debt is we keep money in one of the tools or instrument which will give fixed returns irrespective of market movements. Let's say, simplest is let's say Sukanya Samruddhi Yojana, which we do for girl child. It started with 9.8% annual interest, which was a compound annual interest which used to go. Or your PPFs, it may give 7.5%, right? Irrespective of market movement where the inflation goes, they will give only that much interest. Intangible ones are copyrights, brands, trademark. So we Indians are lagging behind this. Okay. You won't copyright the work that we do. You know, even basmati rice, they went ahead with the trademark and copywriting, isn't it? So we need to work on these things. Our own brand, our own trademark, our own copywriting. So simplest example is, let's say you develop some tool of assessment or something, you copyright it. Every time somebody uses it, some royalty should come to you. Let it be any amount. Let it be 50 rupees per patient, 5 rupees per patient. So for the research or anything that anybody use, some royalty should come. So anything which is of your original work, think of having a copyright or trademark. So now I mentioned about how equity, etc. So how I can divide? For a young person, you can think of going like this. G is gold, R is real estate, E is equity, D and debt. So 10, 40, 40, 10 percentages. Okay. Now the question comes, real estate will require a lot of capital. In the sense you may need a couple of crores. So for a beginner, it may be very difficult to accumulate that much of money. So we shift real estate to equity as much as possible. Debt is for safety. Let's say you put PPF or something, 10%, gold you buy that. That's it. For an elderly person who doesn't want to take much risk, okay, here debt instrument will be more. In the sense, let's say you want to put some FD or some PPF, etc., that should be more. True assets versus pseudo assets. True, easy to sell. There is no emotional involvement, isn't it? Jewelry, is it true asset or pseudo asset? So you ask your wife whether she wants to sell any of her jewelry, let it be 40 years old. Okay, she might not have never taken it out of the cupboard, but still it cannot be sold, isn't it? House in which you are staying, let the loan be 2 crore, 3 crore, still you don't want to sell it, isn't it? Though it is an appreciable asset, still you don't want to leave it. Furniture, you still dump it in the backyard, but still you don't want to sell it. So that's how these are all pseudo assets. True assets, simple things, you don't have any emotional attachment. Let's say some stocks, share, you don't have anything. Some policies, some mutual funds, land where nothing else is done, some gold coin, etc. See, gold coin, not gold jewelry. No. Some commercial building, you will not have any emotional attachment. So you can think of creating these assets. Now I am focusing more on stock market. Why stock market? Because we don't have other skills, right, to go and do any business, start any new business, meet with people, spend time in knowing and all. So the simplest way is this. Because we have enough cognitive skills, isn't it? So now who are there in the market who are leading? MBBS doctors? No, right? Someone else. Usually we talk about people who have done BCom and etc. Now who are the people who took MBBS after 12th? Top scorers or the people who scored less or less? Isn't it? So when the people who are joining MBBS who have more intelligence, more abilities, then why can't they understand it? Is it so difficult? No. Okay. So remember, subject is very simple. Only thing is we are afraid to enter or read or understand it. It will hardly take 5 to 6 months to know what exactly is the stock market, where we can invest, where we can not, and how we can save money or grow, create a wealth. Nothing difficult at all. Only thing is we are not aware, so we are scared of it, that's all. So stock market is nothing but a marketplace where shares of publicly listed companies are traded. In the sense, let's say, I will take an example of one of the firm, Reliance, one of the largest market capital company in India. Let's say it may have a market capital of 18 lakh crores. Okay. That entire 18 lakh crore may not be owned by one person. They may, let's say, Ambani family, they may not be owning that, they may own 60%. Out of remaining 40%, somebody will own some another 10% and all. Some people, as a retail investor, so the common man, can also own part of the company via the shares. Let's say you are holding 100 shares of Reliance company, you may be 0.001% owner of that company. Okay. So when you are holding some shares or buying some shares of a company, you are owner of that company. That percentage, you will have that privilege. And whatever company makes profit or they give dividend, that much will be passed on to you. Okay. So stock market will help us to be part of these, because we cannot start our own business, we cannot start our own ventures. Okay. So it allows us to be part of a business. So what will earn more money? No. Our profession? Which one? Business mainly? Okay. So let's say like I'm renting a room for my clinic, okay, or some shop. So I have to pay rent to that person, isn't it? Or some shop owner, so I am renting my shop to that person. So now that person should earn more than what he has to pay rent for me, right? So for earning, that person is buying from some company and selling it. That means that company should earn more than that person and more than me to survive. So ultimately it's the business which is earning more, isn't it so? I cannot start a business, so indirectly I can be part of a business. Okay, so that's why the market is the one place where we can be part of a business and make more money. Key players, retail investors just like you and me, where we can buy some 100 shares, 1000 shares. Okay, institutional investors, just like fund houses are there, Motilal Oswal, etc. They are like buy in the bulk, 1 lakh shares, 2 lakh shares. There are brokers and traders, there are regulators, because whole transaction is happening, somebody has to regulate or guard like a police. So yes, SEBI is there, Security Exchange Board of India. They are supervising this so that nothing illegal happens there, so that our money is safe there. There is a fear among people that, okay, now I put money, what if company will drown and all. Don't worry, that's not going to happen, because we'll select a company which is doing good, not some other company, and there is SEBI which is going to look into those aspects. Some of the very simple things are, okay, I will buy something which is available at cheap. When the price goes up, I will sell so that I can make profit. Let's say I will buy one share at 100 rupees, once it goes at 150, I will make 50% profit and I will sell. To do so, just understand the company fundamentals. In the sense, choose a company which is making profit. That's all. Don't go for loss-making company. Diversification reduces risk in the sense, choose companies from different sectors. Let's say pharma sector, automobile sectors, hospitality sector, entertainment sector, aviation sectors, etc. So that if one sector is not doing well, some other sector will do well, because money will keep rotating sector-wise, either in the bank, financial instruments, etc. So some of the things are like, okay, people will think I will buy when the market goes down, etc. Timing the market is very difficult. So always think that you have a fixed investment in a company or in your one of the instruments, so that you go on adding them. So whenever there is a dip, when your market goes on, you add more. That will help. Understand the business, not just stock. Okay, so that will come little more. So let's leave it at that. Emotions can be costly. This is the place where the people will lose money. You have seen every now and then you will see in the paper that, okay, doctor is due for 1 crore, 50 lakhs, etc. Because the promise that they have promised money will double in 2 months, money will double in 3 months. It's not going to happen, because there is nothing. The business should grow to that at that pace, right? To grow the money, that's not going to happen. So control your greed. Think of practical and possible returns. So tradable securities are these shares and debt products I had mentioned. Okay, so this is the difference between shares and debt products. So these are exchange traded funds and direct mutual funds which are there. So there is one thing about the mutual funds. So many of you might be investing in mutual funds, right? How many of you are doing direct or via the agent? There are 2 types of mutual funds. One is direct, another one is regular. Okay. Direct. Okay, if somebody is investing via the agent, let's say the bank or some agent will come, doctor sir, you are busy, you just sign here, I will do the rest of the things. that is regular mutual funds. That means the part of the profit will go to the agent. They say only 1% commission ashte sir mattenalla, but that 1% translates to more than 10% of your profit. You may feel what is the big deal, okay? So your money goes into, let's say, 5 crores when you want to withdraw over a period of 10 years and 15 years. Now the agent, what he will get is 50 lakhs from your 5 crores. That's 10% profit. So what is the agent's role here? He just fills the form for you, that's it, nothing else. Isn't it? Same, sir. Always go for direct mutual fund. Direct growth, that's it. You ask them whether it's a regular or direct. If they say regular, no. The same mutual fund you can select on your own. There is a Zerodha coin and mutual fund and many other things are there. Just you can do it on your own, sir. And monthly you can automate whatever amount you want to put, you put. Either same lump sum or in SIP mode, anything is fine. So always stay away from the agents. It's not difficult to select which mutual fund you are going to select. Okay, it's very easy. It's their business model, okay, agent's business model. When they come, doctor sir, you are busy, then they are telling you are donkey, I will do the rest of the things, you give me money. Okay. So this is interesting. Okay. So when we talk about the compound interest rate, so one of the wonders of the world. Just some examples. Okay, to understand how starting investing early will help. So when to start is the question. No, I will finish everything. I will finish my MD, I will finish my DM. Then I will establish my clinic, then I will have kids. By the time I am 45, I will start investing. Or I am 18, I will start whatever is possible. So you can see here two people, someone has started at age of 25,000 monthly, 5,000, he stays invested for 35 years. Total investment is 20 lakhs here. Somebody starts a decade ago, invest 3 times more money and invest for 25 years till the age of 60. Both are till 60s. He has invested 45, this one has 21. But who is getting more money? Okay. The same example. Okay. Here, another thing that person did it is, he started investing 10% more annually. Remember, if you are doing mutual fund or any SIPs, please increase investment by 10% every year. Let's say this year 5,000, next year it should go to 5,500. Next year is 5,500, 10%. Okay. Because that we should invest something which beats inflation. That much amount should go. So here, this person started early. Okay. Returns will also differ accordingly, depending on the assumed return. So these are same examples. Basic idea, this is the whole equation which can explain the long-term wealth creation. This is the only equation. We call it as Aparna equation for the ease of understanding. A is total amount after so many years. P is the principal or original value. 1 plus rate of interest per annum, let's say 12%. It will be 1.12. And number of years the money is invested. So which is the most important factor here? Somebody said? Number of years, exactly sir. Okay. Even if the rate of interest is, let's say, instead of 12%, let it be 10% also, all that matters is n. Okay, the exponential growth that happens. What we are talking about is compound annual growth. Okay. So it's an advice to start early, but at least if they feel like you are a little late, your family member or dependent who is there, teach them to start early. Whatever the amount may be, let it be 1,000, 2,500, no matter. Let them start first, they will understand. Another thing that we have to keep in mind is about inflation. Okay, this is a taxation without regulation. Simplest way is we can assume it as 6% per year, but is it so? Inflation, we talk now and then government comes. Okay. What we have is sectoral inflation or segmental inflation also. Not everything goes at the rate of 6% per year. Let's say some pen is 10 rupees this year, next year it is 11 rupees. School fee, it changes. Okay, entertainment sector changes. Transport, every quarter they revise. Okay. So if you look effectively, as we move up higher in the ladder, in the sense in our economic status, the inflation for us will be somewhere around 20%, roughly 10 to 20%. So we need to grow money at that rate to beat the inflation. Also, lifestyle inflation, we increase our spending as we grow old, isn't it? After certain year, like how many years are left, we just have to spend. That also creeps in after 40. What am I going to do with the money that I have left? Simplest way to understand, okay? FD, why I talked about FD is because that has been considered as the best investment plan. To ask our parents, grandparents, everybody, I put 5 crore in FD, etc. They keep telling. Current FD rate is around 6%, okay? Let's say it's 100 rupees you put in FD, it is 6% interest. Then FDs are charged at our tax slab. Most of us will fall in 30%, right? So it will be 1.8 rupees. Post-tax inflation or the return is 4.2 rupees, right? 100 rupees will become 104.2 rupees. Inflation is what? 6%. So what are we doing? We are killing or destroying our own hard-earned money by doing FDs. Okay? It's not helping us, it is helping just the government. Government uses the same money or banks use the same money to invest in something which can generate more income, or it gives loan, it generates more income. So the value of the 100 money will go down next. So inflation till, okay, this is a rough estimate, goes up and down. Okay. So there are different methods of calculating, but they always keep it under below 10. They always show it as, but it is more than 10 all the time. Some of the terms that you need to know is CAGR, compound annual growth rate. How much it is growing exponentially. 100 rupees, it grows 106. Then 10% of that 106, so it's like that. Insurance policy, internal rate of return, XIR is another thing. So this is a rough graph till 2019, what all has happened. What would have happened to the money that would have invested? Okay, how the money has grown. Silver, gold, Sensex and FD. FDs are blue line, you see they are still here. Gold now has shot up in the last 1 year, it has given 60% return. Those who have got gold bond in the last tranche which was there. Silver, it's also growing up now. But what happened to the market, Sensex? So why didn't we be part of it somewhere in 80s, 90s and all? Because nobody taught us, nobody told us. Now it is at least we have access to internet, etc. In the older time, it was like you call up the Mumbai, tell the broker, I want to buy some share. The person will buy 1 or 2 days or at whatever rate is available, it will get delivered to you after 2 weeks. Okay, that's how it was. But now, at least that would have helped. But see the growth that has happened. Sensex now it is touching the 1 lakh. This till 2019 till the COVID time it was somewhere around 40,000. Imagine from COVID time till now it has doubled. So this is one video clip. This audio is not there, I think. So what would have happened if 100 rupees was invested in all the assets from 1990 till 2020? Despite all the bad news, okay? Harshad Mehta scam. And Lehman Brothers crash came. Kargil war, I don't know why any war should lead to the market crash. In everything it crashes, it rebounds with a higher thing. In Ketan Parekh scam that has happened. General election, Congress wins, that became some bad news for some people. Not for any political party, market is not related to any political party, please remember that. 2008 market crashed from here till here, but after that see how what all the recovery has happened. So what's happening to the cash, the 100 rupees that you have kept in 1990, keep an eye on that. What is happening to the FD, what's happening to the gold, where Sensex is going. COVID, etc. Sensex, I just showed it till 2020. Now Sensex is at 25,000. Here it's 39, 27 only. Take it as 4,000, 6 times more than that. So the growth has happened to that extent. So, if we are so much afraid of the market, whether would have got all these, whether would have made any money. Basic ideas, long-term investment, wealth creation will happen. Okay, whenever there is a crash or anything, buy more rather. Not less, buy more. No need. People, what they will do when a market crash, they will take out the money and run away from the market. No. Those are the chances of wealth creation. Whenever there is a dip, buy as much as possible. Rather, you can double it also. Buy. Next comes about tax. Death and taxes are certain. You cannot avoid. So there are many taxes now. Earlier the taxes weren't there on certain things, but those have come up now also. Let's say before this NDA government comes, there are no tax on the dividends paid by the company. In the sense I told you earlier, if a company makes a profit, it will give dividend to its shareholders. So that each shareholder, per each share, I will give you 10 rupee. Like that. That was entirely tax free. Now, new government came, they started imposing tax on that as per your tax law. Then other taxes also started coming in now. Short-term capital gain, LTC, long-term capital gain. Let's say you are holding a share for a period of more than 1 year or a mutual fund more than 1 year. Whatever gain that happens, let's say I invested 1 lakh, so gain is around 20,000. So for that 20,000, tax wasn't there. Later tax has been tax is being imposed now. It varies. Within 1 year 10%, 12.5%, 15% for different instruments. But taxes are there for everything. So taxes are either direct taxes or indirect taxes. So all of us are paying. Either income tax, wealth tax, gift tax, and many other taxes that we give, GST, etc. Anything and everything that you do, you have to give tax. There are simple terms to understand what we mean by previous financial year and assessment year. Headings can be salary, house income, professional business income, capital gain, other income, dividend, interest, gift, lottery. Everything gets taxed differently. Good practice is to keep a document of everything, whatever you are paying, whatever you are buying. Have a document of it. As much as possible, pay by your account. Illegal to avoid tax paying. Okay, so we do a lot of circus to save tax ultimately, so it may not help. In the old tax regime, we had some of the tax saving avenues where we had like ATC. Either you will go for PPF, Sukanya Samriddhi, etc. So up to 1.5 you can save. National pension scheme is there up to 50,000. Then there is home loan reduction was there. Then Mediclaim or Medicare for self, spouse, etc. So all these provisions are there in the old tax regime. New tax regime, nothing. Okay, it takes off everything straight away. So recently there was some change, right? Okay, when our tax mother has announced like there is no income tax for till 12 lakhs. So what exactly did that mean? Is it so? Or is there any cash in there?
You're paying for everything else.
Yes, sir.
You're paying for everything else, so that doesn't matter.
So 12 lakhs, let's say a person is earning 12 lakhs.
GST.
Then he has to file income tax.
Yes.
He need not pay any tax, right?
But that 12 lakhs is after having paid for everything, everything comes under that.
Yes, sir. Despite that, if he has 12 lakhs still. See, that there was one clause in that, one small clause. When the person doesn't have any other source of income. Let's say the person with 12 lakhs, he invests in market, buys 1 share also, makes 1 rupee also, he will fall in tax bracket straight away. Okay, that's a catch in that. So it's 12 lakhs tax waived off, it's not straight away. So if you are investing somewhere or if you have any other source of income, you are going to get taxed. Okay, so that's a fine print in that. So these are some ATC facilities which you can avail. Another biggest thing is about insurance. Please note, insurance is an expense, and never ever mix insurance with an investment. All the agents will come, doctor, take this, you will get this much return, 6%, 7% return. No. Okay. By doing insurance policies, only agents are getting rich. That's it, nothing else. No insurance policy will beat any market return, any other return. And insurance means, keep it very simple. Term insurance, that's it, nothing else. Other insurance are general insurance which can include your health, professional indemnity, car, travel, etc. Insurance for your life is just term insurance. So what is term insurance? We'll just talk about the health insurance. This is of, who is the patient here? Became a big news, right? So the amount approved was somewhere around 25 lakhs. Okay. Anyway, term life insurance. Okay, it's quite simple. Okay, start early. Let you be the age of 18, 20, 25, 30, but start early. Term insurance means you are paying some money to the insurance company every year, okay, for a particular lump sum that you have defined. If you survive beyond that period, you are not going to get any money, but your ticket get cut prior to that, your dependents will get that money. Remember, that is term insurance. So, at the age of 25 or 35, you can start. Okay. So, how much should be the insurance cover? Standard is 20 times the annual income. Let's say I am earning 50 lakhs per year. The insurance coverage, term insurance, if something bad happens to me, my dependent should get is 20 times of that. That will be around 20 crores. 10 crores, 20 times of that. Okay. Then, take for a duration of 70 years. Why? Why not for 100 years? Because we are doing it for our dependents, isn't it? So by the time our dependents, by the time I reach somewhere 70, my children would have started earning, they will be independent. They may not need our money. Okay, so take till 70, or if you still are little insecure, take till 80 also. Second reason is that most of Indians' average lifespan beyond 70 is doubtful. Okay. No matter whatever we boast at this juncture now, with current life lifestyle and our habits, we may not make it beyond 70. If it's good if you can make it with the healthy lifestyle. So dependents may not need that money, so no point in pay annual premium till term. Why? You might have seen agents coming, there is a discount pay or short pay. You pay like in 10 years only you can finish your premium, in 5 years only you can finish your premium. No, don't go for that. Pay annually. Let's say something happens in between, still you might not have paid, that money is for you. Company, which company to select? There is some term called claim settlement ratio. You can open in any let's say website, or talk to insurance agent or any insurance firm. If you are going through agent for term insurance, that's fine. Choose an agent who is younger to you, not elder to you. The reason? He should outlive you, not like, okay, the insurance agent is there, his ticket gets cut off before you move out of this place. Doesn't help, right? Because once you leave this world, your dependents should not struggle to get the money that they deserve. Okay, for that, if you are choosing an agent, choose somebody who is younger to you. And claim settlement ratio, look at that. Most of the companies we may have 90, 95, 100% claim settlement. In the sense the chances of rejection will be less. Declare everything before you get an insurance. Whatever, my family is doing this, I underwent this, I have this, that's fine. If premium may go up, that's fine. But later when they do exam intake history or something, after you are not in this your family members are not going to get money, because insurance companies will find ways to reject your claims. So always declare everything. Premium will go up by 1000, 2000, doesn't matter much. Another important thing which not many know or not aware of it or not being told also. Married Women's Property Act. Let's say a person is taking term insurance. Similarly, the person has a loan of, let's say, 10 crore, 20 crore, etc. Okay. Person dies by the age of 50 in an RTA or road traffic accident or something. Now, the people who have given loan to him can have a claim on that insurance money rather than his dependents. So to prevent that, while taking a term insurance, remember while taking, not after, after it is not possible, while taking a term insurance, ask for this MWP. This is a simple form, one-page form, which tells that if anything goes wrong with me, all of it will go to my dependent. It can be wife or children, how I am going to divide that money percentage-wise. And no one else will have claim on it. No loan lenders, nobody. If you have not signed, it will go to the people who have given money to you. Okay. So that is essential. That is the insurance means only term life insurance, that's all. Okay. Then health insurance and all, you have to do, and don't take a like family floater, family cover, no. Take separately. For yourself, for your spouse, for your children, separate insurance and as much as possible that much coverage. So, one of the last segment, loan. Okay. This is the modern day slavery. Okay. Most of the slaves are in the debt. Okay. You see Bangalore and other places and everywhere like okay, EMI that goes. So the interest that they are paying is huge. Humble request, as much as possible, stay away from loans. If at all it is needed, take it for some purposes which will help in your growth. It may be profession, business and all. Not for something like I want to buy a car, I want to buy a home, I want to buy a TV, I want to buy a fridge. No, please. Good loans will increase your productivity, which create assets, sometimes save tax, education, for children education, that's fine. Bad loan, personal loan, it's a big problem now. We may feel, okay, we will not be taking it, but if you go to a lower middle socio-economic status, people are taking huge loans, personal loans. Nowadays they are giving online also. Credit card loan, consumer loan. You get calls right from HDFC Bank, ICICI Bank, Bajaj Finance. In credit mail and all loan kodthivi. So loan, I want to buy an MRI machine, okay, I want so many crores, etc. So what is the eligibility that they look for? IT returns. When did we start filing returns? After post-graduation or during post-graduation? Why not from the age of 18 years? Let them have a bank account, PAN, start filing returns. Zero return, that's fine. Okay. There should be IT return filed, but details should be there. CIBIL score and report, assets and income, they look at these for eligibility. What is CIBIL score? It's a credit information bureau India limited score. Okay, so there is a report contains information about the loans, repayments, EMIs, defaults. So any default is going to put a black mark and the score will change. Okay, your CIBIL score is this much, you might have seen in the ad, right? So start filing IT returns from the age of 18 years. If at all you have taken loan in the past, be very punctual in paying loans. Don't default. Use minimum credit, don't default, borrow or guarantee. So simple way of understanding is the CIBIL score is between 300 to 900. So it is nothing but the credit worthiness for individuals. Higher the score, higher the chances of approval. Not everyone who goes to bank manager will get a loan of 5 crore or 10 crore. Okay, so we look at these. So these are simple take-home messages. Some other content is there if you want to invest, so it will take some more time. So I will just close it here. If somebody wants, I can tell you later. So I have told like finance is nothing but just 6 terms: earning, spending, investment, tax, insurance, and loan. That's all we have to know. We have to be conscious about. Earning, actually we are all earning. Okay, start focusing on how we can have a passive income source. How that can exceed our active income, and it is possible. One of the simplest way for us, for our profession is equity or stock market. Reading is required, little bit is fine. Spending, let us be little mindful. Let's say I am earning 1 lakh per month after expenses of household, etc. Probably I can think of investing 40% of it into something which appreciates rather than spending on something. Investment, do it on yourself, start early, look at the number of years. Tax, good at early stage. Insurance, only term insurance, no investment policies. Loan, CIBIL score, and avoid consumer loans. So be mindful of this. This will help in you managing your own finances on your own. You may not depend on anything. So important thing is about investment. So where exactly to invest is the question. Okay. If there is 5 minutes, I can tell that. If we are late, you can just find it out. Investment, just I can tell you. Nobody knows anything about the market. So what we have, if somebody is new to market, doesn't know anything, think of investing exchange traded funds, which are directly investment into top 50 companies, top 100 companies, or top 150 companies, and into the gold. So these are nothing but Nifty Bs, Junior Bs, Bank Bs, or Gold Bs. In the sense, Nifty Bs will invest indirectly into top 50 companies. You need not go for, let's say, Reliance share is 1500 rupees, how can I buy? Or TCS is 3,500 and all. Instead of that, these are exchange traded funds. So you give 250 rupees, that money will get equally divided into those. Return of that I will tell. Junior Bs is 51 to top 51 to 100 companies. Gold is, it's like indirectly investing into gold. Okay, you can start with 50, 100 rupees also. So this is how the returns are there. So I mentioned this Nifty Bs and Junior Bs. This will give on an average 12 to 14% of compound annual growth rate. In the sense, this year 100 rupees, if you keep it for 10 years, next year it will be 112. Next year 12% of 112. Next year 12% of that. It will grow like that. It is little stable. Junior Bs can give 24 to 25% compound annual growth. Okay. Remember, it's not every year it will go up. It may come down also. You buy more again so that you can, instead of 24, you may get 30-40% also. But stay invested at least for 7 years to reap maximum benefits. So a person who doesn't know anything about the market, just open an account in one of the brokers. Start monthly putting in Nifty Bs, whatever amount, 20,000 in Nifty Bs, 20,000 in Junior Bs. Nothing else, you want to expose yourself to gold, another 10,000 in gold Bs, that's it. 50,000 you can start investing monthly in these 3. That's all is needed, you need not worry anything. If you want to create some wealth. Imagine after 10 years, 20 years, that will be in crores. Okay, nothing else to worry, you need not understand market or anything. Okay. So this is what the great investor of all time will tell. So to more about finance, kindly send hi on this number. This is not my number, this is a Wellcome, the group or the forum created by the radiologist Dr. Ramamurthy. Thank you. After protests and all, when we felt like, okay, government told that I am going to suspend all the doctors. Then we felt many doctors said that, okay, we don't have any other income source. That's when they felt like I should empower doctors. That's when he started training. Now it's online training, everything happens, some courses are there. So now doctors started understanding and more of them have joined. So that's why I told almost 1 lakh of us are there in the group in different places. So many courses and everything they do this. And they are confident in managing everything on their own.
As well as interesting. Now we request Dr. Shyamapanda sir to give away a token of.
Definitely, we want to know few words from our senior radiologist, Dr. Sam.
We do have a handful of audience down here, but what I must say is, because even I was informed about this meet maybe around 2 weeks back, and for that shorter time to now what we saw today, it's a fantastic, I'd say the turnaround is fantastic. What happened today, the speakers, the way the speeches were delivered, to the way things were organized, to the food, I'd say hats off to you, Dr. Anand and Dr. Sachin. And I'd like you all to join me in giving them a big hand. And we know now it's reassuring and we feel very good because we know that the department's so very capable. And I'm sure that in the coming years we're going to have a lot more encouraging and fantastic things. And hats off to your whole team. And may this just be the start of things for better things to come. Congratulations and all the best.
Radiology work ಮಾಡ್ತಿದ್ದೆ almost 10 years, 2016 2016 ವರೆಗೂ I was working there. 2016 I took voluntary and I am running my Madikeri Diagnostic Scanning Center, Madikeri. So ನಂತರ 2019 Dr. Sachin came, 20. Then 2021 Dr. Anand came. They made it very, means of course ಕಾಲೇಜ್ ಆದ್ಮೇಲೆ ತುಂಬಾ ಚೆನ್ನಾಗಿ ಆಗುತ್ತೆ. So MRI, CT ಎಲ್ಲ ಬಂತು, ultrasound ಬಂತು. They are doing well and crowd is also pulling. And that way is nice. And this regarding this program, first time they have conducted medicines and pediatrics, they have conducted many times. But radiology, it is more informative. That to cardiac imaging, we were struggling to understand. It was fantastic. It was good. We were not trusting that much. As a radiologist, we were not. But it is nicely informative and it is very good also. So this program as such, even ultrasound imaging, everything was very good, very nice. And organizers, Dr. Sachin and Dr. Anand, main pillars, they have done it very well, great achievement. And of course, after a few years, they will get expansion of their radiodiagnosis team in KoIMS, and they will proceed with this thing. We will be staying with you. Thank you.
I really congratulate our KoIMS Radiology department for having this wonderful program. And it was very informative for us. I am basically an ENT surgeon. I am posted as professor in emergency medicine at KoIMS now. But it was a wonderful program which we really enjoyed. We have conducted a lot of CMEs from all the departments. It's the first time happening. This radiology department have taken it forward and they have conducted it so well. So I hope this will continue. And KoIMS, I am a part of KoIMS team now. So we'll also start conducting so many programs shortly. Thank you.
To Dr. Anand sir. Sir Mohan Apadi sir, we request you to give a token of appreciation for and make this event a grand success.
To deliver the formal vote of thanks, we once again invite Dr. Ananda M. Sir, Associate Professor, Department of Radiodiagnosis, to give away the vote of thanks.
I would like to extend our heartfelt thanks from the Department of Radiodiagnosis, KoIMS, and all the departments, heads, and Dean and Director, and our administrative heads, the KoIMS, and also IRIA team who have all come, including President and Secretary here, and they took all the guiding force and they supported us. So individually, I need to thank definitely our President who was very guiding and also encouraging to conduct in all the districts, all these IRA meetings, and also Dr. Paveen. We will extend our heartfelt thanks from the department and also from on behalf of KoIMS in his absence. And we extend all our thanks to our college administrators, including Lokesh sir, Superintendent Somsekhar sir, Vishal sir, Principal, and our CAO Rohini Madam, and our district surgeon Nanjundaya sir, and department heads, and Dr. Mohan Aphaji sir, and department pediatrics HOD Dr. Purushottam sir, and dental HOD Dr. Kedarnath sir, and OBG department. They were main in getting all this orientation, and they were also present PGs and staffs. So we extend our heartfelt thanks to all the PGs of all departments, and also not forgetting the many PGs from Surya Medical College, and also Mysore Medical College, Austin Medical College, and Austin Medical College. Our staff also had come. For them we will extend our thanks, and also ultimately our all volunteers who stood since the last 2 to 3 days, dividing them the activities, because we were only 2, but we felt they are all our departments because they were divided and they got all these things smoothly done. Thanks for the final year students, and also thanks for all the volunteers directly indirectly helped this CME successfully completing at this juncture. So we thanks, and my sincere thanks to Vijay Sarthi sir, because still he is ensuring that we will finish at the end, and that is how his commitment. He only pushed it. We were a little bit hesitant, as sir was telling, but he said everything is possible to start with a single step. So we were able to do with his guidance, and thanks for that also. And thanks for all other people, even the social security scheme we were extended towards that ITDP officer and all, they cooperated, and also for our image missionary support from Mindray, and also VBRA contrast people, and overall once again to all the people who have supported, and also Prasad who did all the recordings and photographies. Thank you once again, and thank you all for all this patience and also support given to us, which will make us to do further CMEs and educational activities. Thank you once again. Thank you.
We bring today's program to its graceful conclusion.
May the insights gathered here guide our clinical decisions, and may the connections forged here flourish into future collaborations.
Thank you once again for your gracious presence. We wish you a safe journey back and continued success in all your endeavors. Thank you.